chaired by Dr. Legado. It's wounds and burn care. So I'd just like to invite Dr. Legado onto the stage, and then we can kick off. Thank you.
Thank you very much, JP Ogalo. My name is Dr. Luegado. I work in Eldoret. I'm a reconstructive surgeon. I've been given the task of starting off this first session. We have about 5 presentations. I request that whoever is presenting keeps time so that we may be able to have enough time to cover most of them. I'm told 3 have already given in their presentations. For those 2 who have not, kindly please do so as we go on. Without further ado, I would want to introduce the first speaker. Our first speaker is Dr. Ruth Wanjiru. She'll be talking about utility of fullness skin grafts in simple to complex burn contractures. I'm sure you all know that in Kenya we have a lot of burn wounds, and managing of burn wounds normally is a challenge. Let her come and give us insights on how to do the contractures. Karibu daktari.
Thank you. Good morning all. Good morning all. My name is Dr. Ruth Njoroge, plastic surgeon here in the Coast region. So my presentation my topic is utility of full thickness skin grafts in simple to complex post-burn contracture. So as you're all aware, post-burn contractures remains to be a major cause of long-term disability for burn survivors. They have this reminder with them that they had a burn. Not only the scars, but the contractures. So we have issues concerning functional and cosmetic, which are very important, especially in our growing children, and also across major joints. So full thickness skin grafts provide really a durable, elastic, reconstructive option. So I'll briefly go through a bit of the pathophysiology of post-burn contractures. Basically, it's the burn injury response. The deep burns destroy the dermis and the adnexal structures, and then healing occurs via secondary intention. We have a fibrotic scar, or if we do split thickness skin grafting, you know it has more secondary intention, a secondary contraction, sorry. So then scar formation and remodeling. So we have the fibroblasts and the myofibroblasts, which have a variactivity, excessive collagen type 3, and then type 1, then abnormal cross-linking and loss of elastin, causing these stiff scars. So the mechanical forces, we have tension across joints, which stimulates these contractile scar burns, and which lead to the limitation. And then more so, and you know our children are the ones who are most affected by burns, we have scar tissue that does not grow underneath does not grow with the underlying structures, worsening the deformity as they grow older. So why full thickness skin grafts? One, it provides both the epidermis and the dermis. It has superior durability and elasticity, less secondary contraction compared to the split thickness skin grafts, and they are better functionally and cosmetically. The limitation is usually the donor site availability. So harvesting techniques. So we have so many donor sites. We have the abdomen, the back, the buttocks. We can do serial excisions with tissue expansion, or basically just the serial excision will provide that for us. Then we can use flaps and grafts combinations, yes, but it may be a bit extreme. Or you can mesh the full thickness skin grafts, but it will add to our contraction. And then donor site you can close with primary closure or split thickness skin grafts. So here is an example of just how we can increase the size of our full thickness skin graft harvesting. Then clinical utility, basically it's effective literally everywhere. So the axilla, the neck, the hands, and then it provides better joint mobility and recovery. And this can be combined with other techniques, Z-plasties and flaps. So why did I decide to talk about this mainly? So we usually have an annual reconstructive camp with the Aga Khan and the Reconstructive Women International every year. And this year we were able to do a reconstructive camp in March. And Oh, so we had a Reconstructive Women International in conjunction with Aga Khan Mombasa. We do a reconstructive camp every year. We did one in March this year. We had quite a wide range of patients, but more so the post-band contractures. We had 17 patients for ages ranging from 3 years to 46 years. So basically, this is just a graphic representation of the different types of contractures we dealt with. Majority were auxiliary contractures, post-band contractures. And then majority of our patients were female. So these are some of the contractures that we encountered, and I've just put the pre and the post-op. Maybe why full thickness skin grafts? When you're doing a camp, it's tricky sometimes to have post-operative care for flaps and such, but you find that the full thickness skin graft will have less maybe post-op care. So this is rather ingenious when you want to do this wide, like high impact camps. Maybe you're in the periphery. Here we are in Mombasa, maybe not as bad for post-op care. So these are some of the cases that we did. We have this lady here, as you can see. Then you have this hand also. These patients are coming from far, all the way from Malindi. So there we don't have a plastic surgeon. We only have such care here. Then here we have a child again. Then here we have another patient that we also did a full thickness skin graft. Here we have an axillary contracture that we released, and also an unstable band scar that we excised and resurfaced with full thickness skin grafts. So key takeaways is basically they provide full thickness skin grafts, provide durable elastic coverage. They are good for joints, and for pediatric cases, it prevents recurrence better than split thickness skin grafts. And the only challenge we have is the limitation in the donor sites. Thank you. And this is part of the team from Aga Khan. We have Dr. Nancy Van Lagen from Canada. In the other, we have Dr. Alexis Hans, I think, from New York. Thank you.
Thank you very much, Dr. Wanjiru. We will keep our questions till the end of the first session, then we will give them questions, all of them. So if you have a question, just write it somewhere. You'll ask her in the next few minutes. Thank you very much, Dr. Wanjiru. Our next presentation is from Stanley. I don't know whether he's available. Yes. Stanley will be talking about discharging patients on negative pressure wound therapy. I'm sure for us in Kenya, we know we use so much of NPWT. The problem is normally the materials to use, but the machines are always there. Karibu.
Thank you. Good morning. My name is Stanley. I'm a wound care nurse from Aga Khan, Nairobi. Okay, I'll be talking about discharging patient on negative pressure wound therapy and lessons learned. So declarations, there's no conflict of interest. Okay, I'll briefly speak about what is negative pressure. So negative pressure wound therapy has been an important additive in management of complex wound, promoting granulation tissue formation, reducing wound bioburden, shortening the period between the start of therapy and surgery, and eventually healing. Most of these things, as plastic surgeons, I think you've interacted with them, especially in complex wounds. And I think you can appreciate what negative therapy does to wounds. So while inpatient care challenge and closure monitoring can be structured, inpatient to outpatient negative pressure wound therapy initiation have some hiccups. telling the story of what it has learned while researching patient on negative wound therapy will highlight advantage accrued as well as the practice-related systematic barrier that were exposed. So what are the advantages of negative wound therapy at discharge? So usually it reduces time to surgery and healing, TOT. So patients who are discharged with negative pressure wound therapy have faster wound bed preparation and may undergo surgical closure or grafting sooner than in standard care. I think all of us can appreciate that. And then it also enhances quality of healing. The optimized wound environment favors maintenance of good granulation and better results according to continuity of therapy at home. Decongesting inpatient beds, because now if you have like 10 patients who have complex wound and you're keeping them in the hospital, and you're doing the normal changing of wound dressing, it might take them a lot of time for them to be able to maybe discharge. So self-discharge with negative pressure wound therapy allows for continuation of advanced care outside the hospital while reducing length of stay. So this is one of the cases that we've done in Aga Khan. This patient came in with an injury to the knee. It was a dirty wound. Sorry that I didn't get the first image. But now after doing the VAC therapy, these were the results, and then you're able to graft. This is another case. This patient had a CA breast, undergone chemo, got reaction around the breast and the stomach area. And this wound is after now the third session of negative pressure, and we're able to graft it. So what are the challenges in researching patient negative pressure wound therapy? So patient and clinician education. So patient understanding wound care. This sometimes is a problem. So structural teaching is often required by many patients and families in dressing, management, device troubleshooting, and red flags. So these are real challenges that I've experienced with these patients. Patients go home with the negative pressure therapy. They have no idea what it means by this alarm. How do you troubleshoot it? And what structures do you have to follow in case you are unable to do it? So clinician knowledge gaps. So not every clinician understands negative pressure wound therapy, inclusion and exclusion criteria, and that will lead to improper selection. So what are some of the inclusion criteria? So structured teaching is often required by many patients and families in dressing, management, device, and troubleshooting. I think this one is different. It's a mix-up. So some of the inclusion criteria usually is the wound that is very wide, and maybe it has a good bed, like it doesn't have slough, or maybe a hard eschar. And some of the exclusion criteria are unexplored or ostomies and osteomyelitis. Patient who has osteomyelitis is not treated. You cannot put the negative pressure. So negative pressure wound therapy documentation prescription. So sometimes you have lack clear prescription on the length of treatment and number of sessions required. So this was a real scenario where you had a patient who required 2 sessions but ended up being discharged with so many materials that will have taken him 4 or 5 sessions. And when this one happens, it's a cost to the site of the patient, and usually it's not very cheap. So missing details regarding the quantity of consumables, e.g. canisters, dressing, drapes, and to be ordered. So sometimes surgeons discharge the patient, but they miss out to write how many canisters does the patient require, And sometimes even liaising with the vendors become a problem, and this ends up as a challenge. So limited to no wound image with the description for continuity of care. So these are patients that you have discharged home. It's being changed by the vendor, and then they don't document. They don't send in the image with measurements. So you are unable to tell the progress of the wound with time. So staffing challenges in wound care clinics. So high turnover of trained wound care staff usually causes inconsistency in practice, variation in the quantity of patient education, and lack in the continuity of care. So if you don't have people who are trained in this care, you might experience this problem. So financial and consumable limitation, negative pressure machines and consumable remains on the expensive side. Outpatient could miss out on supply due to financial barriers or due to the short of supply provision. Then approval of insurance procedure often lead to delay in treatment as in patients who are discharged before the procedure can be confirmed. So insurance policy barriers, outpatient negative pressure wound therapy rarely is covered by the insurance. So length of pre-authorization requirement and copious documentation. So continual follow-up just delay or deny therapy access to patient. This one can be appreciated by people who have done this. And the insurance, I don't know why they are here, because this was a really thing. So what are the lessons learned? So we need to develop clear discharge protocol, enhance patient and clinician education, strengthen communication across the care levels, advocate for insurance and policy support, and build sustainable wound care teams. So in conclusion, discharging patient on negative wound therapy has clear clinical advantages, decreased waiting for surgery and improved healing outcome. Nonetheless, there are issues related to education, documentation, staffing, financial sustainability, and insurance coverage. Overcoming these systemic barriers with the standardized protocols, improved patient and clinician education, and policy advocacy may improve continuous care and derive maximum benefit from negative wound therapy in both inpatient and outpatient settings. And with that, I say thank you.
Thank you, Stanley. I think, thank you for keeping time. Our presenters have really been keeping time. I hope those who are coming will also keep the same. I'm reliably told that the next two presenters are not yet with us, Patrick and Dr. Joyce Chege. So kindly allow me now to allow for our master class presentation, and this will be done by Dr. Peter Thumba, who is very much available. He'll talk about advancement in perforator flaps, bone reconstruction, and peripheral nerve therapy. Dr. Krieger will be warning you on time events. You can always be looking at him. He'll show time. Thank you.
Thank you, Dr. Lagwad. I'll make sure I look at you, JP. I'll not look at Krieger. Morning, everybody. Thank you. I unfortunately will not cover some of the, it's a very broad topic. The letter of invite said something a little different than the amount of time I have, but so be it. We'll try and go through this real quickly. When I started practice, I started off with micro, and very quickly found out I was killing everybody around me, so I had to figure out a way of survival and yet provide the care patients need. I work at AIC Kijabe Hospital up in the Valley, a rural hospital. What we want to do is very quickly review the history, terminology, and anatomy of perforator flaps, understand pros and cons, describe the vascular anatomy of the leg. Then, if I'm able to describe just briefly my technique, and then examples of perforator use. We don't have time, but this is, for example, one of patients that presented to us. And the question, you look at this girl, she's actually AIDS, HIV positive with this squamous cell carcinoma. And the question is, what in false smelling discharge, what are the goals of care? What options for reconstruction? What patient desires and what resources, and then what cost considerations, because that is an important thing for us. This is a 30-year-old soldier who suffered a blast injury and destruction to the face and has contractures on the neck as well. Again, then the other concern that we have is when you have a patient that you have to communicate through an interpreter and you don't really know what they're being told. This patient, for example, wanted to see. That's all they'd come to do. And so we had a very difficult conversation. Agastilo 3B, presenting at 2 weeks, common problem, similar injury. And they all want their legs preserved. So perforator flaps have a learning curve. The surgical technique is initially certainly is experience dependent. It can be tedious, difficult, and time consuming for the beginner. And then there is what they call a pendulum effect, where the surgeon may, in the excitement of a new technique, apply it even inappropriately and get disappointed. Sometimes people give up on perforator flaps because of that problem, and then others just go back and rework things. Problems, flap design, technical errors, excessive pedicle torsion, and then what is your help in the OR? Availability of loops and bipolar cautery, which is one of the advantages, I guess, of perforator flaps, although you do micro too with loops. And then the need for fine instruments. I think one of the zone of injury is overemphasized, and I think it is not as important a factor in the use of perforator flaps locally as most people would imagine, at least in my experience. Then smoking, diabetes, obesity, children. I find children and women, generally, the more fat there is, the more unreliable large flaps will be. And then, of course, the occasional anatomic considerations. Post-op issues would be infection, and I had this, a patient comes up, we have limited time, and I want to debride them quickly, put a flap, and then I got a series of infections and finally decided I needed to do the debridements myself, and I needed to be happy that it was appropriate. And then dressings. Sometimes you use a dressing in the OR, they go to the ward. If they bleed into that dressing, it becomes a tourniquet, or if it's oozing, you covered a bone that was bleeding, then someone might come and help you to stop the bleeding, just tie basically a tourniquet. And then edema, anticipating edema post-operatively is important so that the flap is a little larger than the defect. I'll not go through the history, although that's an important part of this process. And then I think it is important to differentiate between angiosome, the angiosome concept, and the perforasome concept. They are somewhat related, but very different. And the beauty with perforasomes is that you can preserve the source vessel, whereas with angiosomes, you effectively take away that source vessel. It's amazing that how much perforator flaps can cover if appropriately raised, preserving what you need to preserve. There are between 350 to 400 cutaneous perforators described in the human body. There are purists Blondil has a big textbook. People actually met to define perforators, direct cutaneous perforators, indirect perforators, what are real perforators, are musculocutaneous perforators, are septocutaneous perforators. The important thing anatomically is to be able to delineate. The easiest way for a beginner is to figure out where the septum comes up to skin. You will find a perforator there. And then using that to define how you can cover the defect. Freestyle perforator flaps, you have a defect, no known perforator around the region. You can Doppler, find one, and raise. This is a child who Ponseti, clubfoot, ended up with pressure. You can see the ankle joint is all open, and I did get a little bit of edge necrosis, but that was possible to cover in the end. So akin to choke vessels in the angiosome theory is direct and indirect linking vessels that join a link perforasomes. The beauty about perforators, once you've cleared off adjoining perforators, then you end up with hyperperfusion effectively, which then gives you a very well vascularized flap that can be used to cover defects. You know, previously when I was growing up, we were told you needed muscle to help bring new blood supply, et cetera, but actually perforators will do pretty much the same. Mike Sincere and his colleagues did a lot of work on mapping out perforators, including the lower extremity. Maybe someday if the president likes, we can try and get him here. He's a very interesting guy. I think he's in Arizona right now. So those are linking perforators. Once you close they open up, and you can get a flap that's much bigger than is detected by normal mapping, either using ICG, for example, or CT angiography. And this is just a further example of the same. So this is in a lab, but essentially what you do is define a big perforator, and then using that, define the area that you need in order to be able to cover that flap. I did talk about hyperperfusion as a result of delineating the flap that one will be using. I no longer use delay flaps because I've had miserable experiences with edema, etc. I don't discourage people, but that's my own experience. But I find that it's possible to take flaps that are much bigger than expected based on some degree of experience and knowing what perforators. The other important thing is, I think in this, because most of my patients are trauma, I'll do subfascial dissections, as I'll describe briefly. Most people would do a suprafascial because for a number of reasons, including I think there is a concept of muscle hernia, but I'm yet to experience one. I may get some feedback from the group on that. So I've described that. We've talked about that. So I think important too is the fact that extremities, you want axial flaps and perpendicular to the trunk in a midline for your perforators. You can make a few changes depending on where the perforator is, but by and large, you need to be axial in the extremities and perpendicular in the trunk. And those are just the different plexi or plexuses in these are the flaps, the perforators we talked about: direct, cutaneous, septocutaneous, and cutaneous perforators. Venous drainage, it basically reflects. So the perforators are interesting because you don't have axiality. A perforator comes right up to you, and it doesn't really matter whether it's antegrade or retrograde. As long as there's blood coming, it's coming up, whether the source vessel was divided proximally or not. And so the tissue of skin that is supplied remains the same irrespective of the direction. So there's really no directionality with regards to feeding that perforasome. I'll quickly then, although some experience allows a degree of relative freedom in determining what a sufficient perforator looks like, imaging does eliminate the need for some guesswork. And so, pre-op anatomic imaging provides information about vascularization of superficial tissues, allows one to plan operative techniques, reduces operating time, and hopefully improve operative outcomes. Minimize postoperative complications, and also informs on the need for example, for supercharging, etc. The problem is this process can be expensive, and it does add time. It also allows you to, for a personalized approach to each patient's vascular anatomy. Ideally, combining a number of imaging techniques gives you the best yield in terms of ability to plan. The problem, like I said, is the cost. Considerations include you can have ionizing radiation and iodinated contrast, and these have their own concerns, whether you're concerned about ionizing radiation with BRCA mutations or iodinated contrast with patients that may have allergy to iodine. And so those become a bit difficult. So the ultrasound is one of the most useful instruments available to us. And maybe also mention briefly then the thermo mobile phone, although I think it has only been available it will come thermal imaging using a mobile phone. Unfortunately, I think that little gadget was only using iPhones. I'm not sure it's available for the Android phones, but it's a pretty neat gadget and allows for certainly user dependent, but I think can give fairly good results. The ultrasound identification is the most common method used to locate blood vessels pre and post-operatively, but unfortunately may not be able to accurately distinguish between perforator vessels from source vessels, especially when vessels are deep. The other bit is, of course, it depends on the probe that one is using. There may be poor or little correlation between audible sound signals and vessel diameter. And then I do not entirely agree with the fact that you cannot tell. There are some, I have an old Doppler, when it used to work, it will tell you, you'll see arrows pointing to both sides, just showing bidirectionality, which means the perforator is hitting you, and it's possible. Certainly from the sound, you can tell the difference between a vein and an artery. But I think ultrasound is one of the best, cheapest methods to identify perforators. And after some time, if you've used them long enough, frequently you know where the perforators are. So I did talk about the CT angio. The MR angio is another one. that can be used. And then ICGA is one that really tells you the size of the flap, where the perforators are, and sometimes even where they link. They'll even use 3D printing now to be able to define the block of flap that one will be raising. Like I said, so in our environment, what probably will come to serve as the best is SBTI, is a smartphone-based thermal imaging and ultrasonography. So real quickly to vascular supply of the leg. The skin of the knee and leg represents about 34% of the integument of the lower extremity, with about 40 perforators. There are 5 vascular territories, beginning with the DGA, descending geniculate artery, and then popliteal artery, and then your posterior, anterior tibial arteries, and the peroneal artery. And these are just territories as defined. The DGA, through its superficial branch, the saphenous artery, supplies that territory, and this is just a quick example. So one of the problems with a subfascial dissection is the fact that you end up with quite a chunky flap. But that's a perforator. There are a number. One chooses the largest they need that allows for the flap to get to where it needs to. The popliteal artery laterally is extremely useful. The popliteal artery will have the medial gastrocs and the lateral gastrocs perforators that one can develop, and if you want to extend, you can dissect down to the source vessel. Then posterior tibial, so for around the knee. Posterior tibial artery, this is one I wanted to say is one of the most useful that most people here have used. There is quite a bit of predictability to where the perforators are. For example, at about 10 centimeters above the medial malleolus, there is always a chunky perforator there that one can use. Most perforators will be concentrated in the middle third, and then, yes, thank you, Kiriga. I promised not to look at you, but somehow you still come into the field. Posterior tibial, and these are just examples. Sometimes you go in and the tissue is literally cement, really hard, but it's almost always possible to find a perforator to raise. And I know I did talk about axiality, but actually with a posterior tibial, I found it's reasonable to fashion a flap appropriate for the defect. This gentleman had a 50-year history of smoking, 25 years of discharging, used to work on roofs, and was brought by his son after they'd had lots of arguments. He had this drainage. I expected to find a Magdalene's perhaps, but we're able to cover him, and he never did come back, but this is almost 15 years since. But reason to show some of this is the osteomyelitis that can be used for heel. We can discuss this. I think this was earlier in my days. Right now, I think I'd be happy to discuss a full thickness graph, for example, because one of the problems is a thick pad that is insensate can be a problem, and a full thickness skin graft will probably get sensate a lot sooner than this pad, the likelihood of pressure, etc. Anterior tibial artery is, it can be useful. It's probably best for free flap reconstructions. but has perforators as well. Peroneal artery, I'll run through this. Keystone flaps. You can see the first, hopefully there are no orthopedic surgeons here, but this 1 minute you'll add me. This patient is given to me after these guys made that incision, and that incision. And it's at this point we are consulted. And somehow, we were fortunate we were able to cover him. But it's really nice to encourage. We're still struggling in my hospital to get that oncoplastic relationship. They won't call us until they've done a number of things. I don't know. I understand Kenyatta has managed to get through with that. I'm hoping that happens. This was one of my earlier ones where I didn't do a lot of due diligence, and so I got an infection tip. This guy had fallen into a toilet. I debrided him once and covered him and ended up with soup, but the flap worked okay in the end. After the tip necrosis, I didn't have to graft. Then freestyle perforators. So I think I don't have time to describe my technique, although I did already describe it, I believe. So, I think anatomy is important, knowing where the perforators are. When you're starting out, best thing is to Doppler. Maybe you start out with Dopplering with someone who knows the sounds, and thereafter you should be able to run. I want to give you a solution to the patients. We saw this is one of those patients, so this end up with a keystone perforator flap. The young lady, this gentleman had that. We're able to debride him and then use all those little flaps to rearrange, cover bone, and skin graft the rest. And that's his leg. He was 20 years old, wanted to keep his leg. Sometimes we shorten the leg because it's infected. Here we used supraclavicular flap and facial artery perforator flap to cover both the hardware and give her mucosa. She doesn't have the most beautiful mouth, but she certainly wasn't smelling and was able to go home. Burn, circumflex scapular artery perforator flap. I don't have the time to describe it, but it's a very useful flap, much longer than is described, but actually possible and gives excellent outcomes. And this was a pre-expanded perforator flap. To get that, unfortunately, comes from another country, so we were never able quite to do all the things that we would have wanted to. And then Cancra Morris, who had been operated on from somewhere else, and came with lumps and bits on the face, and we were able to plexiform neurofibromatosis. The nice thing, if they have a blind eye, then it makes reconstruction much easier. If the eye is not blind, then this is difficult. But basically, what I do, because they lack, is excise everything and bring up a suprascapular flap, which in this case did not have the disease. Congenital infiltrating lipomatosis of the face, similar supraclavicular flap for pre-expanded. The problem with this is keloid forming even after this. Then all kinds of perforator flaps in the upper extremity. And I think I want to, I used to tell Kiriga when he was visiting about the importance of keeping time, so I'm going to stop right here so he doesn't. Oh, this is an interesting one. So this patient had radiotherapy for a CA cervix, and about 10 years, this is what happened. She blew out and presented, and it's really difficult, but we're able to excise everything and use lumbar perforator flaps and get her covered. We had 1 or 2 breakdowns, but you can see she did close. So perforator flap surgery requires minimal technology, easy to learn, provides results comparable to free tissue transfer. without the attendant costs, and is therefore an excellent technique for low and high environments. Cosmetic results are excellent with color match. And some perforators are relatively constant in the anatomical location, and therefore, if you use those that are constant, I think the learning curve becomes much smoother. Thank you very much, and I'll invite the chair session.
Thank you very much, Dr. You got 4 more minutes, which was good to you. I do not think the other presenters are there, so I'm requesting the 3 presenters to come forward so that you may be able to answer some questions that the participants may be having on whatever you have presented. So kindly, Stanley, Dr. and Dr. Thumba, you can come and have a seat. And then I'll request anybody who has an issue or a question on the presentation, you are ready, you're free to give or to ask your questions. We'll start with Prof. Do you have another microphone somewhere?
Thank you, the presenters, for a very good presentations. I know some audience are still on their way coming. The first question is to Stanley. Yeah, Stanley, your talk was very good and is very, very relevant in our environment, and you gave very good points why it's good that we discharge these patients. From your experience, how frequently do you change the VAC? Because I've seen a few patients who have really overstayed with the VAC when they go home. And when they come, you find that actually it's all infected, it's smelly. And then because of the moisture, you find that actually those wounds are now macerated. And the small benefit that you could have benefited from the VAC, actually you feel like you've really lost it. Then Dr. Thumba, that's a very good talk about perforator. Yes, when I started doing plastic surgery, maybe 14, 15 years ago, and even where I trained, for the lower limb, I was told that for defects of the knee, gastroc, for the midfoot, soleus, and then for the lower foot was the reversal. And that was the standard practice for many years. Now that perforators have become very common, do you still use the gastrocs or the soleus as part of the armamentum in the management of your patients?
Just take note of those questions. Any other person with a question?
Yeah, thank you to the presenters. I enjoy the presentations. My name is Kiriga. And to Stanley, I know you work in Aga Khan, and maybe your patients may not be worried of cost. Of course, VAC can be cost for those of us who work in the rural areas. Are there maybe a few patients that you've had where you've had to do some modifications on the VAC to just reduce on cost? And maybe that extends to also the other presenters. Then to Dr. Nthumba, an excellent talk on the pedicle torsion. There are people who feel like dissecting around the perforator flap to just increase its mobility would help that perforator vessel from really kinking and torsion. Those who feel you actually need to leave some muscle cuff around it to avoid that. Maybe your take on that. Then do you use tourniquet? Because I know one of the issues around dissecting perforator flaps is, I know you talked about having a bipolar with you that will help arrest the bleeding. But I don't know, do you use tourniquet or not tourniquet? Then lastly, I never saw in your presentation any reverse Suro flap. I don't know whether that was intentional or you completely don't do any reverse Suro flap. Thank you.
Anybody with another question?
Thank you. Those were nice presentations. I just have a question for Stanley. There's a photo you showed a malignant wound, and you put a vac. There are some controversies. I don't know how was the outcome of your wound with the vac on the malignant wound, the breast. Thank you.
We can allow them to answer, and then we'll get the next session of questions. So we start with Dr. Thumba.
Thank you, Dr. Lugada, for this young man had the first question, but since you're the boss, maybe I'll start reverse. I'll start with Dr. Kiriga. So the reverse sural flap is based on a perforator that is about 8 centimeters above the lateral malleolus, 5 to 8 centimeters above. It's consistent, it's constant, and you break about 5 perforators as you come down. It does have a place, I have to say, but it's like it's the last one. I hate destroying perforators. So I think this year, last year, if I've performed any, I don't discourage, my team does, and some people who've been trained by Dr. Langole do. But I think the last 2.5, 3 years I've used, maybe once I've done a reverse Suro. So generally I don't, because I don't believe in destroying perforators. And that's one. And then, but I think, so the reverse Suro has undergone a number, I don't want to go into discussing it, but I guess that's position. Let me not go into the technicalities of revisions, et cetera, in trying to get it to do well. Tourniquet, I use tourniquet because my loops are 5.5. I can't see with any blood. But I don't exsanguinate because I have to see the vessels. I'll raise the leg 5 minutes, put the tourniquet down, and then dissect. Perforator dissection, so in acute trauma setting, I will not dissect into the muscle because of the risks of, there's already an injury, I'm likely to do something. If I was to dissect, then I'd leave a healthy cuff around the perforator. But otherwise, standard dissection, the closer you get to the source vessel, the better the turn you get, the less pedicle torsion one gets. If I do a delay flap, I will always get a torsion. That's my experience. I'm not saying that it is wrong to do a flap delay. I think that answers Dr. Kiriga's questions. Then, Dr. I'm a perforator purist. And again, I don't stop people from using muscle flaps, but I don't use muscle flaps in my, unless, for example, if the proximal tibia, third of the tibia, and maybe you're going into mid tibia, limited tissue around, and I have a nice medial gastroc, I can chimerize the based on the medial sural artery and the medial gastroc belly. It's possible to play around and get a lot more tissue. So rarely I will use it, but like this soleus, I don't. I think The soleus is an extremely important muscle for walking. But that's, and then sometimes when they're smashed, because of the muscle is just fibrous, and it's very difficult to make it. So you take away something that may not help you, but yeah, I don't like, muscles are more useful. I mean, I don't use muscle flaps generally anywhere if I can avoid. I think the current place for muscle are free muscle transfers, but I think perforators pretty well cover anywhere you want in the body. I could be stoned for loving them, but thank you.
Thank you so much. My name is Thank you. So I'll start by a question from Dr. Nangole, frequency of change of VAC. So usually we do 5 to 7 days. And if you're using a good machine, some of them will stop sucking after 7 days. But we have various machines in the market, so I don't know which one you're using. But what I use most of the time, after 7 days, some of them they'll stop sucking, and then the patient has to come for change of dressing. On the issue of modification on the VAC, okay, for your information, I didn't start working in Aga Khan, so I've been in various hospitals. Dr. Nangole can confirm that. I've been to Kenyatta, I've been Coptic, and I've seen modification, but currently where I'm not using modifications. So I've done modification with the VAC using, like when you're doing draping, using Opsite, but now I'm doing draping using hydrocolloid, which is giving good results. So for the other image, if you may allow me to go back to a slide so that I'm able to use the image to describe or to answer your question. So I guess this is what you're talking about, isn't it? So this patient had malignance of the breast. And then they did chemo, they did mastectomy, but after various cycles of chemo, she reacted. And where the wound is not on the breast. So I understand malignance is a contraindication for VAC. So when we did the VAC, is not on the breast where the active malignance was. So that VAC was on the abdomen. So we didn't do directly on the malignant cells. Does that answer your question? Yes. Thank you.
There's a comment.
Sorry, just a comment for Stanley, just in supporting him, because I work very closely with Stanley. In terms of the cost question, I know it's a very common misconception. Everyone is like, the patients who come to our institution have a lot of money. Actually, we have patients who have exhausted their finances. They come to us as a last ditch. So in terms, financial constraint is a major consideration for us. Some of the things we do with VAC, we find that some of our common suppliers, they come with a big sponge, they come with big canisters. So we try to control, tell them, if we do VAC in theater, the first VAC, wherever we can after debridement, we do it in theater, and we make sure that the wound is absolutely clean, because if we put it on a dirty wound, it's a complete waste of resources. So we have to make sure that the wound is absolutely clean. When we open the resources in a sterile way, we seal everything that we're not going to use. Whether it's even a hydrocolloid, an opsite drip, everything is sealed sterile, so that when the patient goes home with the VAC and the items, then the VAC, even the VAC rep knows what we like. We don't contaminate the materials. We save everything we can. Now we have to prescribe because we don't want the suppliers to be giving patients unnecessary materials. So we are very stringent on the material, and that's how we help our patients with cost effectiveness. I just wanted to discount that notion.
Thank you very much. Dr. Obire.
Thank you very much, the presenters and Dr. Esther for that comment. Just two quick observations. One is for Dr. Ntumba. I think the issue of lower limb reconstruction and I think the issue of patient selection is a factor to consider, because there are those patients who you may actually not have that option of using the perforator, depending on the injury they come with. So I think looking at the patient from case-to-case basis is still important. Then the issue of course, we know that some of our colleagues places may not have access to Doppler, and there have been a few times where we've gone in to do a facial cutaneous flap, very confident that we'll find the vessel, and didn't find it, including one time we were doing an LT3 flap and we were shocked with that descending branch was not there. So I think those are key considerations, and of course the individual's skill and experience in doing them. They tend to have a little bit a steeper learning curve compared to an ordinary muscle flap. So I think for individuals, you have to consider those before you pick it. For the negative pressure, I tend to feel that despite a lot of efforts to increase awareness amongst the surgical community in the country, the industry is lagging behind in terms of pricing. So this is not for the presenter, but the industry, I think they are lagging behind in terms of pricing. VAC is still relatively expensive, yet even now an ophthalmologist training in our institutions know there is VAC. So the demand is there, it is huge, but industry needs to do something about pricing. Thank you.
Thank you, Dr. Wabwire. Anybody else with a question from the panelists?
Thank you. Maybe to Dr. Ntumba, just to add on the VAC. I know in Kijabe you use the non-conventional VAC. Maybe you talk about that and the efficacy of what you use.
Dr. Obire has run away, but I was going to say something. I agree absolutely with him. I think it is, so the muscle flaps are an important tool for the trainee. So somehow finding a place for that is important, because we're plastic surgeons and we're expected to be able to. But as a tool for everyday solution, that's maybe different. Part of my training was in India, and one of the things we did there was the VAC. The VAC, we used what the Americans call serine wrap. Here we call cling film. They call serine, yeah, cling film. So gauzes, and so the beauty with gauzes, unlike the sponge, if you leave the sponge for more than 5 days, what happens is you have granulation tissue grow in. And we've had patients where we've had to take to the OR because of what, I think it was Dr. Nangole who talked about leaving them for too long. And granulation tissue has grown. I have some nice pictures right through the. So you have a black. You have black tissue, and you have to take him to theater to remove that whole layer and remove the sponge, the vac sponge. So what we do is we take Vaseline gauze, put it with a healthy sludge of Silverdin, and then lap sponges and cling film, and hook on to vac to negative pressure, so the wall suction. Unfortunately, our patients can't walk around with their vacs. But it does the same, it serves the same. You can control the pressure on the wall. And the beauty is, even if you left it for 5-7 days, you don't have any ingrowth of granulation tissue, and it serves the same purpose. It's a poor man's vac that is very cost effective, because all you're considering is SSD, Vaseline gauze, lap sponges, and really almost free cling film. So thank you, Dr. Kiriga. I think we'll be hiding some things from the residents.
I will allow one last question from Dr. Said.
Yeah, it's not a question as such. I just want to come into the VAC question. You guys of the industries are putting it very expensive. I want to put a cost to it. The cheapest VAC in Kenya at the moment, commercial, is 15,000. And that is the salary of 60% of Kenyans per month. 16,000 Kenyan shillings. The others go to the 20 to 30,000. How many Kenyans can afford that? With what Dr. Ndumba is doing is what we are practicing in Nyeri, and the price comes down to 400 shillings because they only have to buy the cling film from the supermarket. So if the industry doesn't catch up, you'll be priced out of the market.
Thank you very much, Dr. Said. I think that brings us to the end of this session. Oh, you have a burning one? Okay, thank you. Yes.
I just wanted to add that now when we are having much better collaboration with the orthopedic surgeons, VAC has a lot of advantages, but it has also some disadvantages. So if you VAC, for example, a fracture or an implant, then if it's too long, you get biofilms or you get an osteomyelitis. And in former times, many plastic surgeons, including in our department, we always thought the problem is solved when we cover the wound. But actually it's not, because we are creating new problems that we just don't see or did not see. So I think we have to be a bit cautious with the VAC because it can help us in a lot of situations, but in some we really have to be fast, covering the whole wound, because that can really solve the problem, and we don't get more problems by the VAC.
Thank you very much. I think that brings us to the end of the first session. Can we give our presenters a clap? Thank you very much. I think now we'll proceed to the second session. Dr. Safat? Dr. Safat and Dr. Berebu, are they around?
Good morning. Thank you for inviting me and also putting me as a chairman. So nice of the session. I want to invite our first speaker, Dr. Emma Mutio. She will talk to us about telemedicine, enable pre- and post-operative care in cleft lip and palate, cost efficiency, and stakeholder partnership. Thank you, Dr. Emma.
Thank you. Yeah, so good morning, everyone. Yeah, my name is Emma Mutio. I'm a pediatric anesthesiologist. I don't think we have any other anesthesia provider in this room. So I'm here to talk to you about telemedicine-enabled pre- and post-op care for cleft lip and palate. So for us as a pediatric anesthesiologists, for us our perspective is we are sort of a bridge between connecting surgical excellence from surgeons who are here together with patient safety, and we're able to coordinate the care. So of course patients come first, the safety, through optimal preoperative assessment and risk management, contributing to a smoother surgical journey and recovery. So telemedicine, we can't run away from this. It's basically going to help us enhance this role for remote evaluations, allowing for superior preoperative risk stratification, leading to safer operating room environment. So what are some of the challenges we want to address with the telemedicine? Of course, there's a patient burden. We come from some of our facilities, we have resource limitations, a lot of it. So you find patients have to travel a lot. There's a lot of cost and time commitment for families. Like the image there where we have our clinics, you find patients have come from so far. For the clinically, we get logistical complexities of multidisciplinary team clinics. We have limited capacity for long-term follow-up, especially when we are doing outreach missions. And from an IT perspective, we have data silos for different specialties and geographical locations which can hinder coordinated care. So preoperatively, how can we optimize this through telemedicine? We have, for remote assessment and screening, we can have initial virtual consultations, pre-anesthesia, as well as surgical evaluations and preliminary speech and feeding assessments. We're able to do them through telemedicine. Another area we can optimize is the informed consent and education, where we can have video sessions to explain procedures and manage family expectations. As well as digital data integration, where we can securely transfer patients' photos, scans, and records in a safe way through telemedicine. Postoperatively, in order to enhance recovery, for example, in wounds and scar monitoring, we can have secure images and video transfers for remote monitoring. Especially, you'll find patients who may be lost to follow-up because of distance and costs, the issues are raised, and thereby we're able to reduce unnecessary visits. For speech therapy, the tele-rehabilitation, the virtual sessions, they have actually been proven to be as effective as in-person therapy, especially for these cleft patients. And as we also have nutritional support, where we can have video check-ins with the feeding specialists, IT and data, post-operative surveys, and secure patient provider messaging can be very helpful. So what is the cost efficiency? What are we looking at? We look, first of all, to the patient. We have reduced costs. We're able to eliminate significant travel, lodging, missed work expenses, and there are studies that have shown these savings to be there for families. We also have optimized resource allocation. We're able to free up clinic space for complex cases, and of course, this reduces administrative overheads. We have increased surgical capacity by reducing unnecessary visits, opening up slots for newer patients. Of course, IT infrastructure is a big deal when we talk about telemedicine. We need secure platforms with end-to-end encryptions like that Zoom for Healthcare or Doxy.me. There are also network requirements, of course. We need high-speed, secure internet, secure networks with encryption protocols, as well as hardware and software considerations. We need high-definition cameras, professional microphones, secure data storage, and proper integration, which is needed. So, of course, there are security measures when we talk about telemedicine. For example, administratively, we need to do regular risk assessments and training of the staff, as well as proper business associate agreements with the vendors. Physical, we need to conduct visits in private, secure rooms, ensure devices are protected. Technically, also, we need to implement data encryption and multi-factor authentication, such as the OTP, the one-time password, and other audit trails. For patient education, we also need to advise patients to use secure networks and devices. Are there some current examples in Kenya? Yeah, I was able to pick a few. We have the AMREF Leap M-Health, which is a platform for community health workers. At Gertrude's, there is a telemedicine consultations, especially for children where you need to do remote monitoring. We have this Farm Access Foundation, the MTIPA app. We have a lot of radiology teleconsultations across most of the major hospitals across East Africa. They're able to consult even for hospitals outside the country. And there are also from the MOH, we have pilots for rural and remote counties to expand access. And across Africa, in Ghana, there's this PACT program where it's a collaboration with Seattle Children's Hospital for virtual training of multidisciplinary teams. We have Smile Train. I think they'll be speaking, and they are major sponsors. They leverage on partnerships to provide telemedicine speech therapy to remote patients. In Malawi, we have the ConnectMed, which is a proposed national database for cleft care with integrated telemedicine. We've also heard of Mercy Ships in Madagascar, where they use telemedicine to connect their local teams with international mentors. So, so you can see for the African context, we can actually think about adapting this telemedicine so that because we can focus on mobile technology, we have a high mobile penetration rate with mobile-based solutions for effective communication and referrals. We can also think about hybrid models where we can blend in-person missions with remote follow-ups, maximizing on resource efficiency. And local training, telemedicine is a key tool for local capacity building and mentorship. We should, flow with it so that we can address challenges and adapt for areas with inconsistent internet connectivity. So I'll talk a bit about PACLIP, which is Pan-African Association of Cleft Lip and Palate. This is the executive committee of which I'm a member. So this is basically, we advocate for comprehensive cleft care across Africa. So I'm one of the 6. We have our president from Nigeria. We have the vice president from Congo, general secretary from Zimbabwe. We have our assistant general secretary from Nigeria, and our treasurer and myself, I'm the financial secretary. So I'm here to just talk about it and invite the Kspras members to join, of which Professor Nangole, we were there, we did the elections last year. So this is really a call for networking for all surgeons, anesthetists, speech therapists, nurses, orthodontics, nutrition, psychotherapists, because we're involved in policy shaping and research collaboration. So it's really our thing, and we invite you all. So in conclusion, as I finish, telemedicine is really a powerful tool for delivering comprehensive, coordinated, and long-term cleft care. It offers significant cost efficiencies for both the families and the healthcare systems, especially in resource-limited settings. And with strategic partnerships, like I highlighted earlier, and robust, secure IT infrastructure, we can be able to implement this successfully. And of course, my invitation, please join PACLIP in building a Pan-African network for inclusive, affordable, and cleft care. Thank you so much. I think we'll have a question and answer session later. Thank you.
Thank you, Dr. May I invite Dr. Patrick Mutuma Kiambi. He is talking about wound management in a remote area with limited opportunities. Dr. Patrick is here.
Good morning. Good morning, everyone. Point of correction, I'm not a doctor. I'm a clinical nurse practicing at Kenyatta National Hospital. My name is Patrick Mutuma Kiambi. My topic is very simple. Sorry for coming late. I arrived this morning and it was a bit wet. I'll just go direct, which is more of a repetition from my first presenter, what he did, Stanley. I'll be covering similar, so I'll shorten it as much as possible because of a crash of program. So, mine is collaboration approach in wound care management, and my point goes to wound care remains the most pressing challenges in both the urban hospitals and overcrowded facilities like where I work in Kenyatta National Hospital. And also, as Dr. Said was saying, in the remote areas with a very limited access of advanced technology. The approach emphasizes on collaboration, innovation, and resource optimization to deliver effective wound care management and reduce complication and shorten the hospital stay. My point was using antimicrobial dressing for the remote areas and the resource limited, where a nurse practitioner has to have innovation, and this one is supposed to demonstrate the capacity of antimicrobial porous dressing that are being used with the negative pressure. This is in order to come out with a better outcome, and it has frequent change, as well as lessen the treatment burden. A good antimicrobial should have the following properties, whereby it should be porous to allow X-rays to pass through. It should be biodegradable dressing. It should have antimicrobial properties and also compatible and maintaining a good seal, which is integrity. As my previous speaker was talking about the minimum period, but in the remote areas, like what Dr. Said was saying, an average is 3 to 5 days, depending with the amount of accident and also in the conventional practice. But we need to extend it up to 7 with the above, with the below to cut cost in terms of change of dressing and reducing the overall cost. My case presentation that I want to demonstrate here is demonstrate the capacity of antimicrobial dressing which are porous, and this one is an innovation in the clinical evidence with limited opportunities to meet the guidelines used as or use of antimicrobial dressings as a wound care nurse. So in my first step here is whereby you do the setting. The second one is you create the porous. This is why I'm focusing to the theme of creating incisions in the dressing so that now the fluid can seep in, which is an innovation. The third one is how you lay your dressings and so that you can get the antimicrobial. The next slide is a foam placed above the primary dressing where you get the fluid will be able to seep through, and then you cover with a transparent dressing. It must be an aseptic technique applicable. That is my settings, and that is the second slide shows directly how to secure the margins to avoid maceration. That is the next slides there shows how I perforated my dressing, and then the second one also shows the negative pressure foam, which is above the primary antimicrobial dressing and covered with a transparent film, and then you connect it to negative pressure. In this one, I used the copper, which provides antimicrobial action, and the small incisions are made in the dressing to facilitate the fluid pass-through, and this one allows this to continue. I'll rush to the next. It is this intervention should be adapted by all wound care practitioners. It will improve the patient outcome and enhance efficiency. Fewer dressing changes and saving time and cost and discomfort to the patient. Those are few cases I did. One was a very old in our own base in a remote somewhere in Muranga, and after several change of negative pressure, as well as using the localizer as cheap as 4 shillings, I was able to come up with such a result after several change of dressing. This is another case. I didn't do the conventionals. It is extended using gauzes, and we were able to get such results where the plastic surgeons need a graft. That's a necrotizing fasciitis too, and we were able to reach. These are the most difficult cases which we get through in the facilities as well. That's another one too, where using of antimicrobial, and at the end of it all you get 90% takeover graft. That's another degraving case, and it was quite difficult with the very undermining deep as 7 to 8 centimeters undermining edges. So in conclusion, by case presentation, you get early granulation, fewer infected wounds for using antimicrobial, fewer dressing changes, thereby cutting the cost, good percentage of graft uptake. It saves the healing process of those patients and the minimal deformities in terms of shrinking and so kind. To achieve the above innovation and inspire, it is a collaboration through the multidisciplinary approach. Those are my references, and I have no conflict of interest whatsoever. Thank you very much.
Thank you very much, Mr. Patrick. Now, our next speaker is Dr. Joyce Chege. She's going to talk to us about delayed abdominal closure. Don't run.
Good morning, everyone. My name is Dr. Joyce Chege. I am a senior registrar in general surgery based in Nairobi. I shall be discussing delayed abdominal wound closure, a single center experience. Disclosure, there's no financial interest or affiliation concerning material discussed in this presentation. That shall be the outline of my presentation. So to begin with, delayed abdominal wound closure is defined as a surgical strategy whereby the abdomen is temporarily left open to manage contamination, infection, and edema, allowing for safe, definitive closure at a later time, either through delayed primary closure or secondary closure with the aid of flaps or grafts. There are a variety of causes, chief amongst them being trauma and intra-abdominal sepsis. With trauma, the abdomen is usually left open, usually in damage control situations, due to gross contamination and gross soft tissue loss. While in sepsis, as demonstrated in the diagram on your left, there is gross purulent discharge and tissue edema. This makes primary closure difficult due to the risk of abdominal compartment syndrome and the risk of wound dehiscence when the tissue edges are approximated under tension. This means the clinician adjusts their treatment approach upwards according to the reconstructive ladder approach and utilizes temporary closure techniques up until definitive closure is safe. So temporary abdominal closure, there are a variety of classifications. However, I'll classify them into improvised and commercial techniques. An example of an improvised technique, as shown in the diagram, is a Bogota bag, whereby a sterile, transparent saline or urine bag is sutured along the wound edges. And there are other commercial techniques, as shown in the diagram. The Apthara vac system, which is a commercial system for open abdomens. There are various advantages and disadvantages of these techniques. For improvised techniques, some of the advantages are low cost and that it's widely available. And it's useful especially in low resource settings. However, the disadvantage is it is difficult to manage wounds and there's a higher chance of infection. With commercial techniques, the advantages are that it's user-friendly and allows easier control of wounds. However, it is expensive in some settings with limited availability and requires trained staff. With this background in mind, we describe our experience using the tension relief closure system with negative wound pressure therapy with installation, commercially known as a top closure system. So this system uses two approaches that synergistically combine. That is the negative pressure wound therapy with installation and the tension relief system. So these two systems aid in primary closure of the abdominal edges. With the negative wound therapy, with installation, it reduces tissue edema, facilitates local sepsis control through continuous saline irrigation, while the tension relief system facilitates skin expansion for the closure of skin and prevents loss of abdominal wound domain. So we shall move on to the apparatus for top closure system. As stated in the previous slide, there's a tension relief system, which the apparatus that aids with tension relief are attachment plates, as shown in the diagram, attachment straps, and a lock and ratchet system, which is present on the attachment plates. So from the diagram, the attachment plates are placed around 2 centimeters from the wound edges on opposite sides along the entire length of the wound. This increases the surface area and reduces the tension on the edges. The attachment plates, it's not so clear with the cursor, are pulled together with traction from the attachment straps, which is, the straps are of variable length to accommodate the size of the wound. And the plates are held in place by skin staples and nylon sutures. On the attachment plates are a lock and ratchet mechanism, which allows gradual tightening over time and maintains tension over the entire wound without tearing the skin. So I've just described the tension relief system. In addition to that, we have the negative wound pressure system with installation, which is applied on top of the tension relief system. The negative pressure wound therapy has 2 ports, as shown in the diagram, which are placed superiorly, and the 2 ports serve to instill oxygen and saline into the wound in a unidirectional flow with the aid of gravity. So the oxygen prevents anaerobic bacterial growth, while the saline facilitates continuous irrigation of the wound. We begin our case series, which consists of 3 patients managed between the year 2019 and 2021. The patients were all managed using the top closure system, and 2 of the patients presented with severe intra-abdominal sepsis, and 1 patient had anterior abdominal wall necrotizing fasciitis. So our first patient is a 42-year-old male. He's a known sickler on follow-up in our facility. He had no previous abdominal surgery, was admitted 1 week prior with a pain crisis and managed with medication and discharged. He then presented at our accident and emergency department with features of peritonitis, and a diagnosis of spontaneous bacterial peritonitis was made in a known sickler. Intraoperatively, distended small bowel was noted with multiple interloop abscesses, and the small bowel was noted to be herniating through a mesenteric rent with resultant bowel edema. The mesenteric rent we postulated was likely from the ischemic changes related to the sickle cell disease. In addition, the patient had purulent collection in both paracolic gutters and the pelvis. The procedure that was done, we released the small bowel from the mesenteric rent. Thorough washout was done. Bogota bag was placed, as shown in the diagram. And after 2 relook laparotomies with washouts, it was noted that the intra-abdominal sepsis was not improving. A multidisciplinary team discussion was had, and the decision was made for top closure system to be placed. And the reason for this, as I had said, was the persistent sepsis and the fact that the patient was unable to tolerate further OR visits. So top closure system was instilled. The outcome was the sepsis was controlled and the wound was functionally closed after 5 days of top closure placement, as shown in the diagrams. The second patient is a 76-year-old female admitted 1 week after laparoscopic cholecystectomy. She presented with painful discharging umbilical port site wound. Diagnosis of necrotizing fasciitis of the abdominal wall was made. An emergency radical surgical debridement was done with a resultant large abdominal defect, as shown in the diagram. The wound was subsequently packed, and on relook surgery after 48 days, the top closure system was applied, and the wound was successfully closed after 5 days. That is just a pictorial representation of the top closure system and the resultant closure of the wound. The third case was a 23-year-old female, 2 weeks post-appendectomy at a previous facility, presented with features of peritonitis. An emergency laparotomy was done with resultant Bogota bag placement, as shown in the image. Thorough peritoneal washout was done, and after 8 days and 2 relook laparotomies, top closure system was placed, as shown in the diagram, and sepsis was controlled, and the wound was closed successfully after 10 days. So in conclusion, the table shows the 3 cases, and the average length of stay of the patients was 32 days, and the average length of time that the abdomen was open was 13.8 days. Time of closure after top closure was noted to be less than 1 week, and the number of OR visits was on average 3.7. The device cost ranged between 30 to 50,000, with a constant VAC cost of 18,000. So overall, this reflects that the system allowed relatively quick wound closure and fewer operations, despite cost being a limiting factor. In regards to outcomes, sepsis was controlled in all patients. However, 1 patient developed a superficial surgical site infection, 1 patient was lost to follow-up, and no other major complications were noted, in particular enterocutaneous fistulas. However, we expect a ventral hernia on the patient who we are still following up, as we were only able to close the skin and subcutaneous tissue and were unable to approximate the fascia. So the advantages of this system is to reduce the number of reoperations, hence decrease hospital stay and overall decrease in cost. The challenges we faced were barriers in prescribing the apparatus by the surgeons due to lack of familiarity and, as I had said, financial constraints. So in summary, delayed abdominal wall closure is a common surgical scenario faced by most surgeons and offers numerous challenges. A multidisciplinary team approach comprising of general surgeons, plastic surgeons, wound care nurses, amongst others, is necessary in the management of these patients. And the top closure can help reduce morbidity. Thank you.
Thank you very much, Dr. Shaggy. I may invite all the speakers, please, to come up for questions. Mr. Patrick, Dr. Emma, you can come, and if there is any questions, please. having the microphone, I start with the first question. Dr. Emma, thank you. Very good job coordinating all and using the telemedicine. It was a dream. Many years ago, we were using the radio for AMREF. Now we are somewhere else. Dr. Shegi, thank you. That's very nice. We always get this problem of burst abdomen, when to close, and so on. It is very important to delay and take time. Any other question from the audience, please?
Thank you. I just want to ask you, what is a Bogota bag? I'm pretty much from Bogota in Colombia, but I don't know. Can you explain what it is?
It's a form of temporary abdominal closure, whereby you have a transparent, we improvise either with a saline bag or a urine bag, and we anchor it along the edges of the abdominal incision. Have I answered you?
Thank you very much, all the presenters. Dr. Emma, it's not really a question, but maybe a comment on how we can work together as the Pan-African cleft. I remember we were in Zimbabwe. The elections were, was it early this year? October last year. And we had a lot of discussions on how we can improve this collaboration. I don't know, maybe I've been losing out, but not really seen as if we've really done much, either at the continent level or also at the regional level. And I think we have a lot of potential to do a lot, because we know that we do get many patients that require cleft lip and palates surgery. So I don't know if there is a way that you, as one of our representation in the council, you could ask the office to be more visible among the members, come with very clear programs, both education and also come out with workshops, especially workshops I think can really help us. I know that locally we've been doing a lot of work with Smile Train, but that is more limited to our MOU as Kspras or as the University of Nairobi with Smile Train. But I think if that can be pushed to another level, then this can really help, because there's so many surgeons who are passionate to do cleft lip and palate surgery, and what they require is training, availability of workshops, training places, patients to come so that they can be able to learn, and then they can be ready to go out there and be very good craniofacial or cleft lip or palate. So my suggestion is yourself, ourselves as Kspras, and anybody who is doing this kind of work, probably we need to organize meetings and just be able to lay out good programs. Because also, if we say that we wait for the president, who is, I think, in Nigeria or wherever, to come and organize us, I don't think he or she may be able to do that. But I think if we push it from this end, then it could be easier. And then we draw a budget and tell them these are the activities that we've planned for this year, and therefore are they willing to fund us? Thank you.
So thank you so much, Prof. Tangole, and I echo your sentiments. What you're saying is very true. Remember, PACLIP, we have found it actually, there's zero in the coffers. There's no funding per se. So actually the move has been to really popularize it and bring it to the knowledge of all members, wherever they are. So we have just recently, just ratified a new constitution, and we have a very active WhatsApp platform. Maybe through you, Professor, we can invite all the other members of Kspras who are interested, so that we can all, it's really a place for policy and advocacy, and I agree with you about the education, workshops, and meetings. We really want to revamp, and that's why we are here. We just want to really popularize amongst all cleft practitioners, because it's about comprehensive cleft care. So we really, for now, rely a lot on partners such as Smile Train, as we well know, because there's no money per se, but we are really working. We have just recently, just last month, we've been able to open an account. PACLIP has not been having even a bank account. We managed to open one in Zimbabwe, and we are really looking forward to revamp and engage with willing partners. Otherwise, thank you so much, Prof, for even this opportunity and for, drumming support for PACLIP, and we are really on the same page. Thank you so much.
Thank you very much. One last comment to Mr. Patrick's. Just tell us, in the remote areas, how do you access that? How do you go? You by also telecommunication, or how do you manage that?
Thank you very much. It's a bit challenging to link up with the remote, which is more of home-based setups. It is through the family support of the clients, and at times you find yourself traversing across from the urban areas to the remote areas. It is more of, as we usually say, nursing is a calling. You go an extra mile to reach out to those patients, because you have seen them from where they have come from the date of admission, and you find that the condition is improving, the family is suffering. It is more of sacrificial to reach out to them to impact a positive outcome through the patients. It's a sacrifice.
Thank you. If there's no more question, I think we'll invite you for tea. Thank you very much.
Yeah, I think we've had a wonderful morning session. To Mombasa, and for some of you to Africa. And in Swahili we say karibu sana, feel at home, and feel the warmth of Africa and the warmth of Mombasa. Karibuni wote, na tumewapenda sana, na tumefurahia sana nyinyi wote kwa hapa. I'd like to take this opportunity to thank the organizing committee that have done a very, very good job to make sure that this happens. Dr. Mukami, please stand up so that we can appreciate you. And all the other members that were with Dr. Mukami, you can all stand up so that the rest of the team can see you for the good work that you've really done. Dr. Dan, you are the chair of the scientific committee. Please let us appreciate him. Without their work, without their efforts, I don't think we'll be having this wonderful session. I also want to take this opportunity to also recognize the members of the executive. JP is always busy doing something. Please stand up. He's my deputy president. Dr. Luara, I saw him somewhere. Oh yeah, he's there, he's behind, he's always behind. Yeah, Dr. Luara. And then of course, Dr. Mukami again, she's in that committee. Let's appreciate her. Dr. Wabwire is there. Dr. Sarah, she's not yet come, but I think she's on the way coming. So without this committee, really, I don't think we'd be here. There's a lot of things that happen behind the scenes. Ama in Kenya tunasema nyuma ya tent. There's so many things that happen to make sure that all this happen. I really want to take this opportunity to also thank our international faculties that have come all the way from different parts of the continent. We have our special friends from Italy, Professor Innocenti and Mori. Please let us appreciate them. Professor Innocenti is going to be the chairman of the World Reconstructive Society of Microsurgery. I think it's from today. Is it today, Professor? Or? No, I'm the next president. You're going to be the next. 2007. And I'm very sure that he's going to be a very, very big asset to us. Already, Professor Innocenti and Mori hosted Sarah when she went there for her fellowship, and she had a very, very, very good experience there. And I know that with you there, we are going to have more collaborations. We are going to see how we are going to work better so that we can not only make microsurgery a hub here in Kenya, but in the entire African continent. I also have our friend Agostino. Agostino, all the way from Middle East, but originally from Nigeria. Let us appreciate him. Then we have, where is Charles? Oh, he's here. From UK again, we can appreciate him, Professor. But of course, originally from Zambia. We've been with him in many forums. The last one, we were with him in Barcelona. And when we talked about improving the phase of plastic surgery in Africa, he said that he'll be here with us. And there are a few others who are outside, our friends from India, and also our friends from the US, and many, many others will be joining us in this forum. Oh yes, behind there, let's appreciate him. Yeah. All the way from Tata Medical School, where again, one of us was there. And again, we are very, very grateful. And then of course, so many of you who come from different parts of Africa feel welcomed and feel part of this conference. So this conference is going to be a conference that has brought in so many, many master classes from different disciplines and from very well-renowned speakers from different parts of the world. And I'm very, very sure that it's going to be very impactful. And at the end of the 3 days, we are going to have learned a lot. And that is really the aim of the conference, to exchange knowledge and to be able to exchange skills. And at the end of the day, be able to improve on ourselves. But alongside that, we're also going to look at collaborations, because collaboration is the only way that we can grow. Through collaborations, we can be able to improve our own exposure. We can be able to see how we can build where we are not doing so well. We are still a very, very young society of plastic and reconstructive surgery, but our numbers are growing, which is a good thing. And because of that, we still need many forums that we can expose our members to be able to improve on their skills and to be able to have their own career path develop. And that's why we are very, very keen to improve on collaborations. And in line with that, I really want us to appreciate the Italian Society of Microsurgery. The Italian Society of Microsurgery has been a very, very key partner with us. That for the last 2 years, they've been able to take 2 of our members. Kiriga, where is Kiriga? Kiriga is here. Grika was one of the beneficiaries of the Italian Society of Microsurgery, where he was able to go for his fellowship training in microsurgery. Again, Sarah, who is not here, was also one of the other beneficiaries. And I think let's applaud the Italian Society of Microsurgery. We also have the Tata medical colleges, where one of our members, after having the meeting that we had last year, again, we are able to send Nyamboga to go there to do her fellowship in microsurgery. And again, that is something that we, as the Society of Kenya, Plastic and Reconstructive Society, we are very happy, and let us appreciate the Tata School for allowing our members to be there. So we look forward to more collaborations. We look forward to more partnership. We look forward for forums that we can interact with our colleagues so that we can be able to grow and we can be able to become bigger as themselves. There's a special group of visitors who've always attended our forums. And these are the people whom we've been working with on a daily basis. These are the people that we've been interacting with on day in, day out. And this special group of people are the wound care specialists. The wound care team, please, can just stand up or wave and let the members know where you are. All of you, the wound care team. Without this team, I don't think we'd be where we are. They've been so passionate. In fact, sometimes they've even become better at wounds than ourselves. Jackie will always tell you, Dr. here, I think let's use Actisoap. Let's not use Aquacell. I think Actisoap will do better. And then, of course, you say, yeah, I think she has a point. Let us use this. So we do not take your presence for granted. And I'm really pleased that even in the last in the first 2 sessions that we had, you had your presentations. We look forward to you presenting more and more. And we want you to be part of the Plastic Society family because you truly belong here and you're part of us and we must grow together. And we look forward to even more sessions. In fact, in future, I'm foreseeing a situation where we may have 2 or 3 sessions so that 1 or 2 sessions are purely about wounds and the challenges that we face when we confront those wounds. I also know that there's the Smile Train team, which without you, Smile Train, Emily, I don't think we'd be here. Please stand up so that you can be appreciated. Where is she? Yeah, there she is. Emily and Joseph. They've really come a long way. For those of you who may not know that this conference, actually Smile Train, has sponsored almost 50% of it. And without them, I don't think we'll be able to have such a venue. Alongside that, they've also sponsored our residents, and each year they sponsor at least 4 of our residents. Joseph, I know that you've reduced the number to 2, but we are appealing to you, we are requesting you that do your level best so that we can still go back to the 4 residents because the need is enormous. And majority of the residents who are here, the reality is without that sponsorship, they cannot go through their program. So use whatever means possible to tell them that please, we still need that sponsorship to make sure that we're able to move on. Ladies and gentlemen, even as you spend as much time in this conference as possible, please just take some time to go around and see what Mombasa has to offer. It's a very beautiful city. It has got very, very vibrant life on the beach and in so many other places. So don't just limit yourself in the limitation of this hotel, but just find time to go out there. Some of our guests have already been in our national parks, and all of them are very happy with what they've seen. And I want to believe that for those of you who've not done that, there's still a lot that is there that you can be able to get. I would like to take this time to invite our chief guest. Our chief guest, who is representing the CEC of Health, Mombasa County, is none other than Dr. Saumu. Dr. Saumu is a consultant pediatrician, and she's also the head of medical specialist at the Department of Health at the Mombasa County Hospital. I want to ask her, I don't know where she is, if she could come forward and open this conference for her. Let us appreciate her for finding time to be here. Karibu Daktari. You can still become a plastic surgeon.
I know. Once upon a time I was to become a surgeon. But then I changed and went to pediatrics. I think the children got a hold of me. Thank you very much. Thank you for having me at this conference. Good morning, everyone. Welcome to Mombasa, and on behalf of the Department of Health, we'd like to welcome you and appreciate you for hosting your conference in Mombasa. I'm here representing our Waziri, Dr. Soba Omar, who is engaged in other activities, and also representing the Department of Health in general. So, distinguished guests, members of Kspras, esteemed delegates, healthcare professionals, invited guests, ladies and gentlemen, good morning once again. It's a great pleasure and honor to join you this morning in this beautiful city of Mombasa for the annual scientific conference of the Kenya Society of Plastics, Reconstructive and Aesthetic Surgeons 2025. Allow me at the outset to commend the leadership and members of Kspras for your continued dedication to advancing surgical care in Kenya, and for organizing this important gathering under the timely and thought-provoking theme, Innovative and Inspire, advancing a collaborative approach to aesthetic, reconstructive, and reconstructive surgery. This theme actually encapsulates what we as a health sector must strive for in the years ahead. That is a future where innovation, collaboration, and patient-centered care are at the hallmark of surgical excellence. Plastic, reconstructive, and aesthetic surgery is not just about form. It is fundamentally about restoring dignity, functionality, and hope. From post-trauma reconstruction, congenital deformity correction, to burn care and complex wound management, your work directly transforms lives and communities through improving self-esteem, mental health, and also allowing for social integration. So today, as we gather here in Mombasa, we are reminded that innovation in surgery must go hand in hand with equity, accessibility, and ethical practice. So it is not enough to just develop new techniques or technologies. We must ensure that they're integrated into a robust healthcare system, one that serves every Kenyan regardless of geography or economic status. So as the Mombasa County Department of Health, we do recognize and deeply value the role of professional societies such as Kspras, what they play in shaping the future of healthcare. And we do actually are committed to supporting these efforts through strengthening training and capacity building, through the surgical training program that is actually hosted at our county teaching and referral hospital, and investment in subspecialty skills, creating more opportunities for mentorship and also for research where necessary. Public-private collaborations are very important. We believe in fostering stronger partnerships between government, private sector, academia, and professional associations to enhance service delivery and innovation. And I think in this regard, we do recognize also the collaboration and partnership that we enjoy with the Smile Train, not just in plastic surgery field alone, but in so many other fields, including pediatrics, I would say, and also anesthesia. Thank you very much, Smile Train, for working with us. Universal health coverage, this is something that we should not forget. Our goal, of course, remains to make essential surgical care, including reconstructive surgery, a key pillar of UHC. So access to surgical care must be a right, not a luxury. I also wish to encourage Kspras to continue engaging in outreach programs and regional collaborations. So let this conference serve as a platform, not just for scientific exchange, but also for building bridges across disciplines, sectors, and borders. To our visiting delegates, welcome to Kenya. To our local professionals, thank you for your service and for your leadership. I wish you all productive deliberations, innovative discoveries, and lasting collaborations throughout this conference. May you leave Mombasa inspired, re-energized, and united in purpose. Thank you very much.
Thank you very much, Daktari. But you know, you need to declare the conference open. There's one thing she's not said, isn't it? Afungue conference.
The hosts, as the host. Okay. It's now my honor to officially declare the Kspras Annual Scientific Conference 2025 open. Enjoy and stay well.
Thank you very much, Dr. Saum. So at this juncture, we'll have some entertainment, just 2-3 minutes. For those of you who may want to shake a leg or an arm, please, you are welcome. And join them into this, to just feel the hospitality of the Mombasa. It's a very easy dance. There's no particular style, so you can just come and dance whichever way you feel comfortable. Thank you. Asante, asante, asante sana. Well, I think I need to start going to the gym. Yeah, but it's a good break away from the free flaps. So at this juncture, we like to invite Smile Train. I think, Joseph, you are ready to give us one of the key note speech about international collaborations of Smile Train and impact on plastic surgery training. Karibu sana, Joseph.
All right, good morning, everyone. So my name is Joseph Kariuki. I work with Smile Train as the Senior Program Manager for East and Southern Africa. And I'm happy to be here. It's courtesy of our partnership with Kspras and the University of Nairobi. And like Prof said, so through the power of collaboration, we've been able to do over 360 cleft surgeries with Kspras. We've also been able to sponsor 18 plastic surgery residents at the University of Nairobi, and also support research for over 6 of the residents. So Smile Train, thank you very much, is the world's largest cleft charity, and we focus on sustainable cleft care through empowering local medical professionals, providing training and resources. Through our 25 years of being here, we've been able to provide over 2 million cleft surgeries. We've also been able to provide over 100,000 training opportunities, and we've been able to train over 20,000 medical professionals across the globe, including surgeons, anesthesia providers, nurses, nutritionists, all the professionals that are in the cleft ecosystem. So our main goal is to give every child with a cleft the opportunity to live a full and healthy life. And since then, we've been able to do a study on our socio-economic impact. And we realized that through the surgeries that we've been able to provide, we've injected back over $69 billion into the economies of the countries that we work in. So our overarching goals, one is to ensure access to safe, high-quality, comprehensive cleft care through a proven sustainable partnership model. When I say comprehensive cleft care, I mean we don't just provide surgeries, we also do provide nutrition support, speech therapy, orthodontics, psychosocial support, oral health, and audiology for the patients that are born with cleft. And also through that, we also strengthen local health systems. We invest in the hospitals, we invest in the government to ensure that we are providing safe and quality healthcare in the countries that we work in. We also drive innovation by leveraging technology and research to transform global cleft care and foster a global cleft community through awareness and education to reduce stigma and ensure acceptance of people with cleft. So we do this through partnership with local hospitals, local medical professionals, governments in the countries that we work with. And through this, we've been able to, some of the strategic partnerships we've had include with the WHO for a project we call the Art Impact for Health, We've also been working with the Kids Operating Room, or popularly known as Kids OR, to supply state-of-the-art pediatric surgery infrastructure and expertise across Africa, while piloting innovative renewable solar surgery solutions. And together we've been able to provide over 80 pediatric operating room theaters in more than 20 countries since 2020. We've also been working with Lifebox to distribute pulse oximeters and capnography devices, which are helping in patient monitoring and safety for anesthesia and surgery. We're also working with, we have a training called the Pediatric Anesthesia Training in Africa, or PATA, that is meant to strengthen pediatric anesthesia education at teaching hospitals to improve perioperative care for children. We do this through partnership with the Elmer Foundation and the Vanderbilt University. And so we've been able to provide this training to over 22 participants from Ethiopia, Kenya, Tanzania, Uganda, Zambia, and Zimbabwe. So in Ethiopia, through the collaboration with the Ministry of Health and local partners, we've been able to build a sustainable and comprehensive cleft care system. And since our partnership in Ethiopia started in 2006, 2007, the median age for primary cleft surgery has fallen from 12.33 years to 1.15 years in 2024, 91% reduction. In Zambia and Zimbabwe, we are working with the Ministry of Health for their National Surgical Obstetrics, Anesthesia and Nursing Plan. And through this framework, we are going to be able to enhance the cleft care services in these countries. This is a snapshot of some of the partners that we are working with, including the University of Nairobi, COSEXA, CANEXA, West Africa College of Surgeons, Lifebox, and all these others. Through the education and training fellowships, we have a training with the West Africa College of Surgeons, post-fellowship. We've graduated 29, and an advertisement is out for the 2025 intake. 4 for the diploma have graduated, and again, the advert is out for application. We have a post-fellowship with COSEXA, where we've already graduated 15, 9 are in training. COSEXA for plastic surgery, 15 are graduated. We have 7 in training. With the University of Nairobi, we've already graduated 5 in plastic surgery, and 13 are in training. We have pediatric surgery with the Kids OR, where we've graduated 8, and 28 are currently in training. CANEXA for pediatric anesthesia, we have graduated 15, 6 are in training. We have a post-diploma in anesthesia again for WACS, where 3 are in training, and an advertisement is out for the 2025 intake. PATA, the pediatric anesthesia training in Africa, we've graduated 33, 11 are in for 2025. ENAM is for speech training, so 3 are currently in training. The ratio of male to female for 2024 training, we've been able to train 18 male and 13 female. I think that deserves a clap. Thank you. So again, this is a snapshot of the people we've graduated from the different fellowship trainings in cleft and anesthesia. Beyond that, Smile Train's #1 priority is the safety of the patient. So we continue to strengthen the safety and quality of care through other trainings, including the BLS and PALS training, nursing training. We have a new training that we've developed called the START training, team cleft training, that is training soft skills. We know in theater, the surgeon does his work, the anesthetist does his work. So, but we ensure that we provide soft skills where they're able to communicate to each other in theater and reduce the hierarchy things that normally happen in the theater. Through innovation, we've been able to build pediatric theaters in different countries in Africa. And also recently, we launched the Cleft Leadership Center in Kumasi, Ghana. And during their launch, it was said it is in Ghana, but it is for all of us in Africa. So if we need anyone to get trained, because it's a high volume center where a lot of patients with cleft are treated, we can send trainees to train in cleft surgery or anesthesia. We also have the Smile Train Africa Alumni Network, popularly known as STAN. And through this network, we are offering the following opportunities: scholarships for advanced cleft surgery training, access to online and in-person workshops such as Simulare that we've recently did with Kspras and the University of Nairobi, hands-on experience in cleft surgery at Smile Train partner hospitals across Africa. Where non-surgical roles beyond surgery, opportunities exist in leadership and advocacy, and we encourage the alumni to become local cleft care advocates, help raise awareness, influence policy and improve access to cleft treatment, career development support, competitive opportunities for travel support to present cleft-related abstract at selected conferences, and networking and experience sharing among alumni through Smile Train supported networking events. So these are some of the opportunities: the post-fellowship training in cleft care. We have the CANEXA, pediatric anesthesia training, and also the ENAM, speech therapy fellowship, and especially for Francophone countries. So the way forward for strengthening the alumni networks is network and collaboration, peer support, and in conclusion, we call on the Smile Train alumni to consider how they can individually and collectively contribute to expanding cleft care in Africa. And interested alumni can get in touch with us for more information about Smile Train training programs, available resources, and partnership opportunities. We thank you, Kspras and UON, for the support and the partnership. Thank you very much.
So, thank you, Joseph. Any questions or comments before he sits down? Yes, Saidi.
Thank you, Joseph. It's not actually a question. It's just to appreciate the work you're doing as Smile Train. I work for Nyeri, and we are great beneficiaries of Smile Train. We have a comprehensive cleft center because of you, several trainings and everything. Thank you for that. And I'm just concerned about the protocols, especially anesthesia protocol. If you had to roll out cleft care in Kenya, we don't have too many pediatric anesthesiologists. The standards that you are giving are standards of USA and American, whatever, and their cleft burden, they are not as big as ours. I think we should be in this stage where if we can offer this standard, that is acceptable in Africa. 3 years ago, I presented in this conference my challenges in anesthesia, doing cleft surgery across East Africa. And only out of 11 centers, only 2 had anesthesiologists, not even pediatric anesthesiologists, just general anesthesiologists. Majority actually had nurse anesthetists. How do you work in Africa realistically with the Smile Train to offer these services? Otherwise, we are going to lock out very many centers who should be doing this work in Africa. Thank you.
Okay. Thank you very much, Dr. Saidi. And Nyeri is one of our partner hospitals in the central region of Kenya. So, as Smile Train, so the safety and quality protocol, like I said, our number one priority is the safety of the patient. And the safety and quality protocol that we use is actually nothing foreign. It's just what the WFSA and the Association of Surgeons safety quality anesthesia guidelines. So we've just taken some things from there. So it's usually what is supposed to happen. It's just that sometimes it's not followed to the core, and that is why we have a few run-ins with some of the centers. And in fact, most of the cleft surgeries that are done in Africa, they are not done by anesthesiologists. They're done by nurse anesthetist and clinical officer anesthetist. So we have those courses like BS and PALS, Safe Pediatrics, that we provide for them to ensure that they improve on their pediatric anesthesia. But again, it's always good. Like we say, a pediatric patient is not a small adult. So we need the pediatric anesthesiologist or general anesthesiologist to provide training for them to ensure that they are providing the safest surgeries. And then actually Dr. Emma is one of our safety auditors, and she's here. She's able to provide some bit of more insight on your question. Where is the mic? Dr. Emma.
Thank you so much. And thank you, Dr. Saidi. I think we've just met over the phone. You have talked previously. Thank you so much for your question about the anesthesia coverage. As one of the few pediatric anesthesiologists in the country, we only have 20 so far, and we have to cover a population of almost 50 million. So that's a very valid question, Daktari, that you ask. And my answer is this. We really recommend that the anesthesia providers who are within your purview, we recommend that let them be at least be someone, someone who sort of oversees, whether be it a pediatric anesthesiologist or a general anesthesiologist. Let your center be covered by a consultant, so that, because you find most of the time cleft patients, they are already syndromic. You have so many issues. They can have other, one congenital anomaly comes with another. Most of the time you find they have other cardiac issues, airway issues. Those are the most concerning for us in anesthesia. So we like to say, let your center, if you're going to offer cleft care, let your center be at least under the coverage of an anesthesiologist. And we also, just as Joseph has said, Smile Train has a very robust, mentorship and capacity building program in terms of the trainings they offer. They even give capnography, so they are doing the capnography trainings. They give pulse oximeters. So they have a really robust way of taking care of the safety of the patient. So, but it's very much in order that your center, it's really very important, just from even other sentinel events that have occurred. We are just talking from experience. Whenever there's a sentinel event that occurs, you find a lot of gaps, especially most of the time, especially the ones to do with anesthesia. These are things that are actually preventable. And you see, with a lot of training and learning, we say these are elective procedures. Most of the time they're elective. Let us optimize the children so that we maximize on benefits of having the surgery. I mean, I'm sure you as the surgeon, you want to operate and your patient is safe. So anesthesia is a very key component for the safety of your patient. I think it's a whole talk. Let me end there for now. Thanks.
Okay, thank you, Joseph. We really look forward to continuing working together and even in strengthening the relation with the Smile Train. So we have some time. So because of that, we are lucky that we'll be able to bring in one very interesting presentation before Dr. Swafat gives us his experience, 45 years of experience in surgery. So Dr. Rajesh, I don't know if you are ready. Dr. Rajesh is going to talk to us about suspension palatoplasty for velopharyngeal insufficiency, 5-year follow-up. Of course, one of the biggest problems with cleft palate is velopharyngeal insufficiency. And it can be very, very difficult to manage, especially in a setup where we do not have regular speech pathologists. And you find that even after you've done a very, very good cleft palate surgery, you still find that the quality of speech is not very, very good. And therefore, we really want to see what is Dr. Rajesh is doing, and we can be able to learn from his experience. Karibu, welcome.
Good morning, everyone. So I am Dr. Rajesh, and I come from Hyderabad, India. And it has been lovely here in Mombasa. And actually, I did my schooling in Kenya, Nairobi. So it really finds it, memorable to come back to Kenya, and because this feels part of my home. And thank you once again for the invitation. So we all do, so I would like to disclose Smile Train funded these procedures, and we all do a lot of cleft palate, and achieving normal speech is the plastic surgeon's goal. And sometimes normal speech may not always be attainable, whereas maybe because the primary surgery was done somewhere else, or because of the outcome in which there is a large gap in the posteropharyngeal wall, which leads to VPI, velopharyngeal insufficiency. So this is our protocol for treating VPI. So, and we have our 5-year follow-up. So once again, thanks to Professor Nangole, for the president, and for inviting me here and for having me here. So this is one publication, one study that we had done way back in 2013, where we had analyzed children with velopharyngeal insufficiency. And we also had some normal speech pathologists who contributed, and they had undergone video fluoroscopy to see how much amount of gap in the posteropharyngeal wall really contributes to VPI. And when we found that when the resting velopharyngeal gap, that is the gap between the soft palate and the posteropharyngeal wall, is less than 5 millimeters or around 5 millimeters, the chances of closure are almost 95 to 99%. Whereas when the gap increases to more than 5 mm, the chances of VPI become full-blown. So based on this, we hypothesized that we should devise, so all these patients that we're going to see now are operated already and who have confirmed VPI. So based on these findings, we formulated that we should somehow reduce the resting gap and keep it to less than 5 mm so that we can achieve normal speech. The method involves using a simple borrowed Furlow's double opposing Z-plasty. However, to narrow down the velopharyngeal gap, we keep a small posterior pharyngeal wall, which is based on the, which is based superiorly. And along with that, we dynamize this flap in order to reduce the VP gap and achieve a good closure. So this is the video in which this is a child with VPI. Sorry, just. Yeah, this is a child with VPI, which we typically see, where nasal endoscopy done prior showed VPI. And this is where the soft palate is, it has been repaired elsewhere, and the child had velopharyngeal insufficiency. We can also see that there's a small pinhole fistula in this. Is it already playing? Okay. it's playing here. Display. It was, yeah, it's playing now. Yeah, it's playing. Just sorry with the video. Double checked it. Just close it 1 second. Maybe we'll just close it and restart it. Close the program. Yes. Maybe we can directly play it from this itself. Yeah. Yes. Yes. Maybe we can just duplicate the screen. Or slideshow, yeah, slideshow. It is playing now. It is playing now. It's okay. We can play it. So basically in this technique, sorry for the apologies for that. So a double opposing Z plus T and a small pharyngeal flap is what we interpose. And I have a small operative video of the procedure which shows how to achieve this consistently. So it involves first opening up the entire soft palate in a Z-shaped manner and using this superiorly based pharyngeal flap in the middle. So this is a child with VPI where we have a small pinhole fistula in the soft palate as well. And this is the prior nasoendoscopy, which shows a moderate gap. That is, when we classify it as mild, moderate, and severe, we reserve this for the mild to moderate gap nasoendoscopy findings for suspension palatoplasty to achieve good results. It starts with a Z-plasty. We make a markings of oral Z-plasty, like how it has been described in furloughs. But however, the angles tend to be a little wider. So once the Z-plasty flaps are elevated, so we elevate the Z-plasty flaps, the oral side. The oral side do not contain the muscle. They just have only the mucus and glandular tissue. Whereas the nasal side, the opposite side Z-plasty is done, and the right-sided nasal Z incorporates the levator palati muscle. So this is where the knife is showing that we are dissecting off the levator palati, which has come and got attached to the posterior border of the hard palate in spite of a good repair in the primary surgery. So the left-sided levator palati is separated from the nasal Z. And then the left side, we do a Z-plasty that is based anteriorly and to interpose a small mucosal flap in between. Once the breaking down of the soft palate is done, we elevate a small superiorly based pharyngeal flap. The idea of this flap is to anchor the soft palate or position it as high as possible to the posterior pharyngeal wall so that the work that the levator palati has to do comes down in the form of reducing the resting gap to less than 5 mm. This is the superiorly based pharyngeal flap, which is elevated just deep to the superior constrictor muscle. Keeping a little bit of muscle on the flap makes it sturdy and available for suturing, because a mucosal flap only can lead to dehiscence, as well as it tends to break down. So leaving that little amount of superior constrictor muscle makes the flap sturdy and easy to suture. So the flap is anchored at 3 points. So on the right side, left, and the middle. So it's a standard 3 suture technique to keep that. So once that is done, the donor side can be left raw, but we usually suture it primarily. This reduces the pain in the postoperative period, and also there are no raw areas, which leads to better healing as well. Once the donor site is closed, now the further what happens is the nasal Z-plasty is anchored even more posterior to the base of the pharyngeal flap. This retroposes the soft palate as much as possible, keeping it much closer to the pharyngeal wall. So this is the picture after the inset of the pharyngeal flap. We can see 2 ports on either side of the midline. Those are the breathing ports, and the midline is closed. Once this is done, it is matter of closure of the remaining amount of the palate. The other Z is transposed, lengthening the palate because of the Z-plasty. And this is the uvula creation is done. Finally, the most important is the levator sling. So a good levator muscle is still there. It is sutured along with part of the pharyngeal flap and then to the opposite levator. So making this repair not just static in terms of a pharyngeal flap, but also adding dynamism, because the pharyngeal flap along with the muscle on top, every time the patient moves, the patient speaks, the soft palate and the pharyngeal flap moves as well. This is the final closure of the Z-plasty flaps. To make them, there are no lateral incisions given because we don't require them, as the Z-plasty itself achieves the lengthening. The soft palate, the pharyngeal flap has been incorporated along with the levator palati muscle. This is the final closure. And after completion of the oral Z-plasty, a wider angle of the Z also helps us in making a good watertight closure. There are no gaps anywhere, which will achieve primary healing, and no scarring at all. This is after the completed Z-plasty. This is an overall of the procedure, and we have our results in form of 5-year follow-ups. Initially, we were skeptical because this is what happens when you see the postoperative nasoendoscopy. You can see a small midline flap and 2 ports on either side for voice, for speech, as well as for breathing. So every time they speak, you can see that the flap also moves a little bit. These are our results, where we had operated around 104 patients between 2014 to 2016. And this is what they had come for follow-up. And what had been our surprise is that 29 of 41 patients had normal speech. So this was something that we never imagined of, because borderline speech is also acceptable sometimes, and normal speech was very good.
Audio. 65, 66, 67, 68, 69, 67, 91 to 99 91, 92, 93, 94, 95, 96, 97, 98, 99.
Thank you, but sorry for the... And this is... Thank you. This is our publication where we had published this, and we had seen many surgeons adopting this. And this is in CPCJ, and always team effort. So that's my boss in the middle there. So Professor Mukund Reddy. So he is the Smile Train director of our center, and who has been able to make this possible. And our speech therapy team, who actually bring out the fine post-operative results. And thank you once again for the presentation.
Thank you, Dr. Rajesh. Any questions for Dr. Rajesh? Okay, Dr. Rajesh, we'll invite you in one of our workshops so that you can come and share this technique with us when you come to Kenya next time. So this Change will like to ask Dr. Safwat. Dr. Safwat is going to give us talk on 45 years of experience as a surgeon. Dr. Safwat, I can assure you that when you started practicing, majority of the people in this room were not yet born. Maybe just a few of us were born. So I'm very sure that your experience is going to be very, very meaningful and helpful. Karibu.
Yes, dear colleagues, Professor Nangoli, I'm very honored and thankful for the invitation. It is really a great opportunity to show you what happened when I came to Kenya 1979. I really want to assure you that any photos here is really, I took permission to show it, and also that it is really my all photos, is not borrowed. And most of it, over 90% is my work, all with a colleague. Here, I really want to mention my late Dr. Sumaya Mina, my wife, which I owe her all success in my life. She sacrificed all for me and our children. Thank you. I graduated in Egypt 1973. I did internship in 1974. And most of my time in Egypt, I was a surgical and urology resident for almost 3-4 years. Luckily, I trained some in anesthesia, because in our district hospital, we have only one anesthetist who said, you have to assist me. So I used to take calls just when I just finished my internship in anesthesia. And also gynae and obstetric was only one consultant, so I would share with him the calls. It was a great pleasure to work there in Egypt, very hard. I learned a lot. But we were many, like we are 5 residents in urology, 1978. And the consultant want to do only private practice. So he just come in Egypt, does one case and go for tea, and we didn't learn. So I met my uncle who was working in Uganda. He came to visit. He showed me the beauty of East Africa, the national park, the origin of the Nile. And I said, please, I want to come there. He said, apply. So after 1 year, I got a contract, medical officer, urology in Mulago. I married quickly before the opportunity. In 2 months, I married and traveled. But I met Sumaya in the Suez Hospital. We were working in Suez Hospital. And really, we know each other, so it was not an effort. So I came, my first flight was to Nairobi. It was okay. My second flight was to Entebbe. When I arrived here at 5 a.m. in Nairobi, they say the flight is canceled. What? Why? They say there is a war there. There is that, Idi Amin time. And I said, I can go by the bus. They said, you are an Egyptian. you look like Libyan who's fighting there, they will kill you. You stay here. So I stayed in Nairobi 2 weeks, 3 weeks, no hope. I went to Ministry of Health. I applied for a job. In 12 days, I posted in Kiambu District Hospital. And actually, when I went there, it was Professor Odwari, pediatrician, who was the chairman of the medical board. I said, I want to do a license exam. No, go work. Come later. Every few months, I call them by phone. When is the exam? He say, I've never seen somebody like you. When they do the work, take the work, they never come back for exam, say, I'm busy. So I said, no. Anyway, I did it. And actually, my registration here was 1563. While in Egypt, 5 years earlier, it was 22,000. So you see how many doctors were in Egypt, and here we were less. So first day I went to the hospital. I met the medical officer of health and the consultant surgeon and say, what did you train in Egypt? I say, I did a bit of urology. Say, okay, just in half an hour, go to the operating room. There's a prostate in the table. Just go and start, and I'm joining you. That man never came. I finished the prostatectomy alone. Okay, thank God. Next day, the same. I came to the director office, and he said, oh, please go. There is another prostate. I'm coming. He never came. The man was 85 years old. And by 2 a.m., they called me, say, the man is not breathing well. Only 5 respiration rate is 5 per minute. So the medical officer in charge came and found me. Why do you operate on this man who's 85? You are killing our patient. That's my second day. I say, I haven't selected. I found him on the table. Okay, go and sleep. I say, no, I'm not going unless he die or he live. And I started doing mouth-to-mouth breathing. There was no resuscitation. And the man lived. And I became a hero. In 1 week, that doctor resigned, because here in Kenya, when you want to do politics, when you want to be a member of parliament, you resign. So he resigned, and I was the acting surgeon for 2.5 years. I really enjoyed it. I tried it. There was no any anesthetist, clinical officer. There was no gynecologist. There was no anything else. I was doing everything. I was with my wife. I was taking a call every night, every other night, one for my wife and one for myself. She got a baby. So and in the other days, when anybody doesn't know how to do laparotomy, I can go and help. And when a patient comes who needed blood, they say, transfer to Kenyatta Hospital. I say, no, I don't want to lose that patient. I will donate my blood, and then I go and operate on him. So it was really a very nice time. I enjoyed it. And it is that time where we used to have corporal punishment. According to the British law, when you say you are imprisoned, and then you take 10 strokes. So as a doctor, I used to go to the prison and see them examine the prisoner before he being stroked, and after to sign that he's healthy. So I formed a good relation with the deputy OCPD, and we became friends. In few months, I got a threatening letter. We're going to kill you in Kiambu. Why? I don't know. They looked at the signature, nobody knows. The police, my friend, they say, don't worry. I can give you a gun. I can give you a pistol. Say, why? I'm not not coming to kill people here. I'm coming to, so I decided actually to leave. We didn't know who did it. I went to Kenyatta, and where I really applied to finish my surgery. So because I didn't finish my master in Egypt, It was really a great time, but very hard, because in all KNH 2,000 beds, we were only 10 residents. All the hospital, do all the surgery. And it was really hard time, because even you rotate in plastic and orthopedic, we would do even laparotomy every day, and when you are not on call, the case is admitted with you, you do it the next day. We had external examiner from UK, and actually the pass rate, we're only 4 candidates, 2 passed, which was 50%. But we learned a lot, and that's why you can see what I'm going to do later. So in my training, I finished also in the same time my master in Egypt in urology, 84, and immediately I finished my master, I went to pediatric surgery because I loved children and I loved surgery. And that time, Professor Cambi was coming fresh from Germany, and he took me straight. He also get a scholarship to go to Johns Hopkins for 5 months for observership. But the American said, we can't take an Egyptian. Find for us a Kenyan. And he was so great. He told them, this is the only one I have ready, the most senior. You either take him or leave him. But then he came and whispered in my ear, you will come back. You will help my people. I don't want to send you in America. You don't come back. I said, I promise to come. So I came back to Kenya, and whenever we traveled, we found happy, peaceful, appreciative people, very grateful, and we felt welcomed and needed. And after 10 years, after I came back from the US, I think that Kenya was my God's choice for our family. In volunteering, we started in the Coptic church from 86, 88. I think some of you know where Coptic is now, but I started as an outpatient, and then it became a nursing home in 92, where we used to treat refugees and from all over. And this is the time we used to really just receive patients until they go big hospitals, then they come. Then also, I started volunteering with the Flying Doctor, and also with the International Committee of the Red Cross in Lokeshokyo, which was an eye-opener. This one, this car boot, was my pharmacy. So I used to really see patients. This is near Maseno. And these books is the ones we used to rely on. And this is like, you see here, Professor Wasuna, surgery in a district hospital. This is how to do obstetric, gynecology, anesthesia, here another. So these are all from the WHO, and it was really very educative to us when you don't know what to do. I heard a lot about the stories of the Flying Doctor, Dr. Michael Wood. He started in '56 here to Kenya. He used to use his Land Rover, go do operations, come back in the end of the day. And I read all his books, Go Extra Mile. I advise all the young people to read this book, and this No Turning Back. It is so scary when you can see exactly he's in the airplane, in the clouds, and he still go to see a patient when everybody tell him, you're going to die. Also, his 40-year experience in East Africa, and Mama Daktari is a French lady, Anne Spory, who was a pilot, and he would go to all the remote areas and do surgery there. The Flying Doctor service was really a great opportunity to me to serve. So we did either emergency cases. I would go in the morning, come back in the evening, do the surgery. My runner nurse was even the pilot. He has nothing to do. He stay with me. And or specialist outreach 3 to 5 days, or later they started transferring the patients to Nairobi. And when you go there, you are Nairobi here, civilized. This Dr. Tom Rassen, who was really from Holland, and Dr. Marlene. And then you go now to the bush, you land there, and now here you go, you start. And you know, lot of experiences. You come now, you are for your own. East Africa is beautiful. This is like Lake Magadi and Lake Natron, where I was flying to Loliondo, which here in East Africa. This is many stories. This man was stabbed in the tummy 3 days earlier, and they called me to come to operate. Only the skin was sutured, and he had a cut wound in the stomach, which was stitched, and the only hematoma, there is no infection. I said, who operated on him? They said, that is the Maasai doctor. How did he operate? What did he use? He used the tail of the wild beast. That wildebeest, he used the tail. But how does he sterilize? He used urine to sterilize. And the patient lived 3 days, waited for me, has no infection, and this is now the family is telling me thank you before I fly. Stories are so many. This is Lake Paradise. It is Marsabit. Marsabit is northeastern. It's a very remote area. I went many times. I'll tell you only one story when I was there, when there was even a wife of a driver. They said she overdue and she wants cesarean section. At that time, although I was a pediatric surgeon, I could do anything because of my training. So when you are not very busy, say, I can go. So I went. The lady is not in labor, there's anything, nothing. So when I was walking to the theater, say, come and look at this one. And I found a lady, her HB is 5 grams. She's admitted for 10 days, admitted for 10 days, transfused twice, and say, what is that? She pregnant? No. She's just got a baby. She didn't meet her husband. I say, I don't care. That looks like rupture ectopic. They say, sorry, we can't do it. Why? She will die, HB of 5. I say, look, I'm coming to help. If I don't do that laparotomy, I'm not doing the cesarean. And they accepted. And that lady, it was a rupture ectopic. And even after 1 year, I was walking in Gertrude, and the small, Somali lady or whatever came and said, Doctor, are you the one who came to Marsabit a year ago and operated on a lady? I said, yes, it is me. It is me. I said, oh, praise the Lord. So it was nice, and it was really many rewarding stories. Thank you. This is, any guess? I written Lake Victoria. So beautiful. The biggest Victoria, our biggest lake. And here, this is Oldonia Lengai. It is just in Tanzania when you cross Kenya. So beautiful. You feel you are in the top of the moon. I tell you that story, how I took that photo. It was in the 90s. This camera, you put the film and you have to, and then the pilot say, take, this is beautiful. Then we pass, say, did you take? Say, oh, sorry, my film got finished. We were all alone. Say, don't worry, prepare yourself. He went around, came back for me to take the photo. But it was nice. This is Ngorongoro crater. It's very beautiful from the air. This is Kijabe, Dr. Zumba. Beautiful. They are enjoying please, we are not jealous from you, but it is beautiful. I used to travel to go to Kijabe to do some surgeries there. There is a Mutumo hospital where there is a missionary team used to invite me for pediatric surgery. Sometime I come all the way, I fly and say, no, this is just a paralytic Elias. He does not need surgery. Sometime I operate, but it was very nice. The most rewarding one is this case, Northeastern in Wajir Hospital. This is early 90s. And this child has imperforate anus with a huge tummy, 4 days intestinal obstruction. And Dr. Emma will tell me, how did I operate? Look, there is no oxygen, there is no anesthetic machine, there is nothing, only ambu bag, and I did a laparotomy and a colostomy, and this child has survived. I came back to Kenyatta, and really, we operated on him. Safe improvisation. We operated in many, Kapenguria, Kakuma, Mandera, Moyali. It was really a lot of perseverance and taking a risk, but for a good reason. In culture here, intermarriages, these 2 moms with 2 brothers' dads, 2 sisters' mom, they got intersex in 6 children. I operated on them. It is really, please stop and don't encourage that. The good thing is now that our culture is moving. There is integration to the modern culture and to the traditional one. The missions, Kapanga Hospital is a medical mission of Mary. And that one, you go, you find many patients waiting. The changing room for male and female, and that is the phlebotomist, anesthetist, and even working casualty to get lines. And you get a list of 9 cases, single-handed. Sometimes I work even up to 2 a.m. to finish the list. And that's huge, mini hernia, cystic hygromas operated, sacrococcygeal teratoma, huge, and then they bleed, but that you get some people to donate. This is big growth in the leg, and you do amputation. Theater light, no theater light, only that lamp, you get hot. You operate 2 tables at a time, and you do calling the patients, calling the nurse to pick the baby. And you can't leave before you teach. And you feel great operating up to 9:30 in the evening, taking tea in the container. The ICRC mission this is in Lokishokyo. This is Sudanese refugees coming, walking 20 kilometers to reach Kenya. This is now the Turkana people. And this is how the dog is very important to them. So this is why there is a lot of hydatid cyst, another amoebic liver cyst, another TB, peritonitis in HIV patient. And this is still Lokishokyo. You go in the morning to operate, the road is clear, then some rain comes from Uganda. By the end of the day, you can't cross. You have to sleep in the hospital. Lot of trauma, amputees, lot of bullets. In one mission of 3-4 days, I removed 11 bullets. This was next to the heart. And also at night, you do some delivery. This patient now is 30 years. I think he came to my office. I left them my card 30 years ago. Suddenly someone appeared and said, you are the one who delivered me 30 years ago. Now, when they have no enough money to travel, we now started bring me the patients. So this is 11 years from Moyale in the border of Ethiopia, was raped, complete perineal tear, She walked 11 kilometers to reach to the Kenya side of Miali so Amref can pick her. Fecal impaction, packed, and we did it, and she have now, this is nerve stimulator, very nice. Another one with stab wound, and also she went well. I've seen dangers many times during my life, and when I tell people what I pass through, say, and you are still in Kenya, you have not left. I mean, like I was carjacked twice, head-end collision, nobody was injured, house break twice. In the flying doctor, I've seen many near-death experience, many. And you know what happened a few weeks ago or 10 days? It was dangerous. You go up to the air, and then you look to the pilot and say, oh, my door is open. Don't worry, push it up and bring it back. What? When I pushed it, I found the air down. One time, you know, the doctor said, you know, here, the visitors, we are very common to do strikes. So I asked it, I was in Kiambu, 1980, and very new, and I took permission for 10 minutes more. And then they said, we want to do strike. I say, I'm not part of that. No, you have to be. How do you do the strike? Can we do the emergencies? No, you just hide. You go, run away, leave the hospital, so because they will come arrest you. I say, arrest me for what? I want to work. No. So I told my wife, you sit at home, I will work. So by the end of the day, I did all the work of the 4 doctors. They came to my house and say, we want you. Say, what? No, your wife. Why? She's arrested. The minister say, if by 2 you don't come to the hospital, you will be arrested. She has a baby. Oh, she's allowed to come with a baby 6 months. What? And now we went to the police station. And then I found my colleagues already arrested, all sitting on the floor. And when we are about to enter, to take her from me, that police officer, my friend, say, why are you doing strike? I say, I didn't do. So they told him, it is his wife who strike. How come you don't agree with each other? Your wife do strike, and you don't do strike. I say, no, she was sick. Sick? How do you prove it? I looked for anybody to sign for her a sick sheet in the morning. All the doctor disappeared. So what to do? I signed it myself. Then he looked at it. Common cold, flu, 2 days off. Who signs this? It is me. How can the doctor sign to his wife? No, sir. I say, but I'm the only doctor. Then he looked at me and said, you are right. You stupid people, how do you bring the lady when she's sick? I'm sorry, Dr. Safwat, you go home, take it. But it was very scary. Anyway, anesthesia, Dr. Emma, is our challenge. You have to tie the people almost like this to really achieve. This is, I'm glad we were up, not down. This was a commercial flight in Mwanza, and it was down. Now, my story with Surgical Society, because of time, you know, by 1950 to 1980, there was something called ASEA, Association of East Africa Surgeons. And then many British surgeons. And by that time, they say we do the COSEXA, and I was a founding member or foundation member of COSEXA. And then now we started forming our association, SSK and Surgical Society of Kenya, and I was one of the steering committee. And we really started, I was elected to be the camp coordinator, Dr. Dumba knows, and he was there. And I started from the scratch, actually, and gradually we improved. And I realized that this was the first one. There was medical camps. There was no any surgical camps, where now you take your instrument, you take your surgeon, you go to the remote area, and we all work hard and do almost 40, 50. And then gradually, we started going to many places. And we gradually knew how to beg. And this is where we did. We started from Narok, as many, many places we have gone. And this was the first SSK meeting. Sorry, that is the second. That was in Kisumu. And the first one was in Aga Khan. So you just leave your comfort zone in Nairobi, you go to the unknown. And this is the first team. And this is now you bring supplies, find patients, you really go and improve. So I was a founding member of the Kenya Association of Pediatric Surgeons. I was the chairman 9 years, Pan-Africa Pediatric Surgical Association, Kenya Association of Urologic Surgeons. I founded Surgical Hope Children Fund to pay for children cannot afford. I was also one of the founding members of the Coptic Hospital and foundation member of Kspras, and I was elected by Surgical Society as a fellow. I think Dr. say I'm the only fellow living in this country. They didn't select another one. I don't know why. When you're chairman, you should have selected. You did. Oh, no, he was the first. I'm saying I'm the only one living. So you need to get another living one. Thank you. So, plastic story. Now I can stop now. Can I continue the plastic professor? In early 80, there was Professor Hack, who was in Aga Khan. Very nice surgeon. In Nairobi Hospital, we have Dr. Landra, who even operated up to the age of 80, who was the only plastic surgeon. The Professor Balo in University of Nairobi, he was from 84 to 93, and he was a great man. He's the first one to invite me to do urethroplasty in a plastic surgery list. He's the first one to invite me as external examiner, and so on, and the relation was so nice, and he was a great man. Unfortunately, I couldn't find a photo. And up to the early 2000, it is a pediatric surgeon, and previously the pediatrician used to treat burns in this country. This is now Dr. Makram Gali. He was from 82 to 88 from Egypt. He was a resident in UK, senior registrar. This is Dr. Ashraf. I know some of you might know him. He died of COVID, unfortunately, 2020. This is Dr. Adam Ray. He was working with AMREF. And this Dr. Long was working with also AMREF. This is Dr. Arif, who was really from Egypt, I think 91, 92, up to 2015, was a great surgeon, and we great friend, and we did a lot of cases together. Okay, I know you are a plastic surgeon. I do nothing in comparison to you, but this is an omphalocele. You can see the intestine. We wait until epithelialized. Then now we wait when it is already epithelialized, then we just close it. This is another proboscis hernia when we do just reconstruction. This is another interesting case. It was in Kijabe where I was called to do urethroplasty, and then when I looked, I found, oh, there's a breast here. This is the time when you didn't have karyotyping, we didn't have any investigation, even ultrasound was hard. But anyway, so we ended doing, clitoroplasty and vaginoplasty, and we saved the day. After we did actually laparotomy, and we found that she is a lady, not a man. And so on. This is, dermal graft for somebody who have severe cordy. And this is bladder extrophy where, with epispadias, where we repaired the epispadias repaired. This is nowadays even not you alone do breast implants. We do now testicular implants because of after torsion for gangrenous. Now, this was bilateral Wilms tumor. inoperable. Everybody said you can't operate. We went to Gertrude as a free case. This now was 20 years ago, and this man is still in contact, come to me, and really, if I have time, I would have told you a story about him, but now I know. This is also my hero, Richo. Richo have a huge Wilms tumor. We did the first one, and then she bled 8 units of blood, and the nurse in Gertrude say, "Doctor, why are you killing our patient?" I say, what do I do? She lived. And after she lived, she became better. And this is the old Coptic hospital. This is her mom, and she was going home. But then it came back in another year. Then we removed it again, then came back in another year. And then the fourth operation in 4 years, it was inoperable. But still, her mom is very grateful. Of course, she got a divorce and she got all the problem because nobody wanted to care. So, wisdom of the years, I'm concluding. Surgery as a hobby, passion, honestly, commitment. Listen and appreciate your patient. Mentorship, which I see here, very vital. You are doing it, is vital. Usually, please go to the surgery which fits you. Don't overdo it or don't do it alone. And the only motive to operate on a patient is to benefit the patient. Surgery is a humbling experience when it fails, so be encouraged. Each one of us should have his own charity project, deal with each other on fair basis. Don't give up. Keep on trying, but ask for help when needed. The reward will come in due time. The life of a surgeon is 3 decades. The first decade, he knows how to operate. The second decade, he knows how to operate well. And the third decade, he knows when not to operate. In conclusion, despite our challenges, we must continue to do what we can with what we have to help our patient and make our experience satisfying and rewarding to be on the top like these children. And the most reward, I say, is when you are in the lift or in the corridor and somebody stop you, say, "You operated on me." I say, "I don't remember." "You operated on my son." And then the most rewarding, when you get the second generation, he bring you his child. Say, "You operated on me, now I brought my child for you to be operated." So it really gives you a great reward. And when you go to the top, you have to be with your patients. Thank you very much.
Dr. Safwat needs another applaud for the good work. Standing ovation, Dr. Safwat. Thank you. Thank you. Thank you. Thank you. Thank you very much for that wonderful work that you've done. We can only say thank you. You've been our mentor. You've walked through. You've shown us the way to go, and we are following in your footsteps. And I think those 10 commandments that you've given us, we need to have them somewhere. We'll keep them somewhere in our operating rooms and just keep on reminding ourselves on what it means to be a good surgeon. It was not easy, ladies and gentlemen. The country is still, of course, we are much, much better than when Dr. Safwat was here 45 years ago. But we still have a lot of challenges, especially when you go out there in the village. I'm very sure that some parts of this country, even when you go to, not much has really changed. And there's a very, very strong need for those outreaches. And as the Kenya Society of Plastic and Reconstructive have really taken on the issues of outreaches, just to go out there and be able to provide some of these services in those communities where none is available. And we like to ask all those who are willing to work with us, to partner with us. We can be able to do this, and we can make a very, very, very big difference in the lives of those very, very needy patients. Dr. Safwat, your generations of doctors and surgeons were probably more committed than we are. I saw you said that the most critical is the wellness of the patient and not really your personal rewards. So maybe those are the things that we really need to look into, and not just look at what is it in there for me, but what is in there for the patient. So that is really very motivating, is very, very encouraging. And I'll appeal to you that probably it is a story that is worth writing, that can be passed on from one generation to many generations to come. So with those comments, we've come to the end of this session. And I think there's, according to the program, we have presentation by the sponsor. I'm not very sure who it is. I don't know if there's a sponsor who is supposed to come. Yes, please come ahead and give your presentation. After which, we'll break for, we'll go on to the fourth session, about hand surgery, brachial plexus, and nerve surgery repair. And Dr. Esther will be our moderator.
Thank you. A very good afternoon, everyone. My name is Sunil Rotela. I'm from Healthium, and I take care of Africa business for Healthium. Basically, Healthium key focus area is into advanced surgeries, into advanced wound care, infection prevention, and arthroscopy. Our vision is to deliver access to precision medtech for every patient globally. Healthium right now operates in 90 plus countries. We have more than 85 plus patent. We are number one into surgical suture needles. So we manufacture surgical suture needles for almost all competitors throughout the world. That's why we claim that 1 in 5 surgeries performed globally uses a Healthium product. We are number 4 into full suture and number 1 into surgical suture needle. We have all major global accreditations like ISO, FDA, TGA, CGMP, MDASP, and we are the only suture manufacturer as of now who has EU MDR certification. This is how our portfolio looks like. So in wound closure, we have sutures, endostaplers, hernia meshes, hemostats, tissue glue, etc. In advanced wound care, we have wound dressings for acute and chronic wounds and post-op dressings. Then infection prevention, we have applicators to prep patients before the surgery, and wipes, swabs made up of alcohol and CHG, and surface disinfectant wipes, and surgical gloves. Then in arthroscopy, we have implants for sports medicine. So we have a complete range of absorbable and non-absorbable suture, be it plastic surgery, be it aesthetic surgery. So we have full range of surgical suture. This is one of specialized suture, which is a barbed suture, which has a triangular end stopper at the end, and it is attached with a 300 series needle. We also has a specialized suture, which is, the needle is black in color, so it will reduce fatigue to the surgeon eye. The body of the needle is square body, so it will not slip while doing a surgery, and it will not entangle because we have provided into very short lengths. This is our endostapler range. The brand name for endostapler is Vertex. So we have all kind of endoscopic linear cutters for open surgeries, hemorrhoidal stapler, circumcision stapler, beadless trocars, etc. This is how our endoscopic linear cutter looks like. It comes with cartridges. Coming to advanced wound dressings, Therapter is our brand name. So we have wound dressings for acute and chronic wounds and for post-op also. So first we'll discuss Therapter Novo. So Novo is a basically 3D hydrocellular matrix dressing. It can be used for acute and chronic wounds. This is a patented technology. The design is patented. So this is how this dressing looks like. It is made up of PET and PU. It has a non-adherent layer and it has a 3D open hydrocellular structure. So you can see a low density layer in between two high density layers. It also prevents exudate accumulation on the wound bed because it has a vertical wicking action. It also encourages optimum wound healing environment. It maintains MVTR. Coming to the method of action, so basically this dressing is a positively charged dressing. So as you all are aware that all microbes are negative in charge. So it works physically, it kills microorganism physically. So we call it attract, bind and rupture or physical kill mechanism. This is a electron microscope view of a bacteria on Therapter Novo surface. Now what is bringing Therapter Novo? First of all, it is an antimicrobial dressing with a physical kill mechanism and without any resistance concern. Then it is a 3D hydrocellular matrix which is managing the exudates very well. It's a long-term protection. It can be used up to 7 days. It is a non-leaching technology. So basically nothing is going into the wound bed like silver dressings or some other dressings. It is non-depleting and non-cytotoxic. There will be no pain when you change the dressing because it has a non-adherent pad. So these are the most common 27 types of microbes where we have done the studies. The studies are published and clinical studies can be shared to you if required. These are some of the parameters for ideal dressing, and Novo is everywhere in terms of antimicrobial, in terms of exudate management, promote wound healing, ease of application and removal. Plus there are two more advantages. One is there is no resistance. Second one is it is non-leaching. There are some cases I would like to show you guys quickly. So you can see day 5 and day 42, day 7 and day 14. You can see the wound on day 27, day 32, day 10, day 14, day 21, and many more. It is available in these 3 sizes, and the best part is it can cut in, as per the required size. Now we have a post-op surgical dressing also. The brand name is Therapter NXT. So basically it is a post-op dressing, but it is an antimicrobial dressing because it works again on physical kill mechanism only. So it will provide antimicrobial activity post-operation. So it has a support delivery layer. It is waterproof. It controls moisture vapor transfer rate. It is a 3D hydrocellular matrix. So again, it reduces the risk of surgical site infection, reduced pain while changing, waterproof. These are the few ideal parameters for that ideal post-op dressings should have. So out of 8, Therapter NXT has got 8 marks because it comes into each and every category. It is falling under each and every category. Thank you so much.
So just having a small consultation whether we take a break or we continue. But meanwhile, the Ohana group, welcome. Welcome very much. Yeah, karibu sana. So, continue. Yeah, so I'm told we'll continue with the next session. I think the next speaker is Dr. Kulba. Dr. Kulba is the founder of Ohana Group. For the last 5 days, we've been doing surgeries with him, both in Kijabe and in Kenyatta National Hospital. And we are really looking forward to your presentation, Dr. Kulba.
Thank you. Thank you for having us. Hold on, don't go anywhere. Doctor, I brought you a Ohana One surgical cap. I wanted to thank you for your hospitality and thanks for inviting us. So appreciate you being here. So thank you very much. Okay, thank you. Okay. Okay, so today I'm going to talk about adipose-derived stem cells and the application in the upper extremity. I'm a plastic surgeon, but I also have dual appointments in orthopedic surgery. I'm the head of hand and upper extremity at Cedars-Sinai Medical Center. This is Cedars-Sinai. It's a medical center in Los Angeles, around Beverly Hills. It's one of the top medical centers in the country and in the United States, ranked number 2 in U.S. News reports, and number 1 in California. It's sometimes known like where a lot of stars go, like the Kardashians, et cetera, but it's actually a real, it's a tertiary medical center. We do the most heart transplants in the world, and it's a very busy hospital. It's the number 1 trauma center in California, and we have a very busy plastic surgery department as well as a hand surgery department, hand and upper extremity surgery department. So I'm going to talk about fat grafting. I think we all know a little bit about it, that it's first described by a German surgeon in 1893. There's varying levels of refinement for it, which I'm not going to get into because we have plastic surgeons here. But just to say that it's been well used in different parts of the body, as we all know, in breast reconstruction, in lower extremity reconstruction, for volume augmentation and regenerative properties. The mechanism of action, it's anti-inflammatory, it's pro-angiogenic, and it's regenerative. And these are the properties that I think are really good for reconstruction of the upper extremity. Stem cells are fat, which is what I'm going to talk about. You can also get it from the bone marrow, but adipose-derived stem cells were involved in the perivascular compartments of the adipose stroma, and they can be isolated, so you could either just inject fat, which have the cells, or you could actually use collagenase to break it down so you get higher percentage of cells per volume of injection. The factors that affect graft survival is vascularity. I think it's important to look at the patient age, nutritional status, medication, comorbidities, and social habits. These are all the things I think of when I'm going to actually do fat grafting on somebody and whether it's going to work or not. And it's based on all these different factors. Also, graft viability has to do with trauma, so you have to really be nice to the cells when you transfer them. And I'll show you what I do now to harvest fat now. I used to do a lot of spinning it down. I trained with Sidney Coleman, and so I did a lot of centrifuge. Now I do very little to augment the fat. We know that the way that the fat works, it activates an inflammatory response, and the graft tissue activates growth factors, and there's a synergistic relationship between inflammatory cells and growth factors. And I'm going to talk to you a little bit about what I do with fat now, and I actually, in some of the series that I'm going to present, I inject it with PRP, plasma-enriched platelets, and there's a lot of studies showing that the PRP keeps the fat cells alive longer, and they work synergistically with each other. As far as hand surgery, there's many applications of hand surgery. I'm just going to put this down here. And The applications are for neuropathic pain, Dupuytren's, burn scars, soft tissue, and this is the thing, regenerative issues, osteoarthritis, and these are all the things I'm going to talk about. So putting it together, fat is more than just volume and cushioning. Mature adipocytes alone are not enough, and they can help with generative processes, and you'll see in this talk how I use it. So this is based on a paper that I wrote for PRS, and these are the different things that we're going to talk about of how I use fat in the upper extremity. There's me holding a big fat gun in the operating room. So I'm just going to talk about how I get the fat. Right now, I just harvest it with a syringe. I do something very simple. If I'm doing large volumes, then I'll use a device, but usually I'm only injecting for the upper extremity 20 to 40 cc's. And so I just harvest the fat with a cannula. I put it on Telfa, and I just let it kind of, all the exudate of the tumescent solution kind of sit there, and then I put it in a syringe. Then I go back and forth, and I go back in this cannula, moving it back and forth, and mix it with the PRP.
Okay, mixing the PRP
usually
with the fat.
Hand or the upper extremity. You don't need that much volume, so I'll do like 5 cc's of PRP mixed with 5 cc's of fat. I move it back and forth so it goes easily through a cannula, and I usually inject it with the cannula, which you'll see in a couple of the cases I'm going to show you. So first of all, I'm going to talk about scar revision and contractures. It improves skin quality, it reduces adhesions, and you can use fat instead of making a big incision for a tenolysis or a scar contracture. You could do it just for a blunt cannula, releasing scar and then injecting fat behind it. So this is a case of a scar contracture after extensive tendon damage and injury, and the tendon was adhered to the overlying tissue on the dorsum of the hand. So here I'm just taking the cannula, I've kind of bluntly released the adherence of the extensor mechanism to the scar, and then I'm injecting fat in it. And then you can see here the difference now. The scar, instead of being indented, it's released. The person's got good tendon gliding after you've injected this. They wake up, or I'll show you some other active slides. And so this is like a very easy way to kind of release a scar rather than, and you're starting all over again. So, you know, when people who have scars, you have to think about it like you need to do something different and augment the wound healing process. So this, if you're not a believer in fat grafting, I think this slide is the slide to look at. So this is a guy who he went to Burning Man, which is this like crazy hippie thing in the middle of the desert in the United States, not California. And people dance around the fire and do all kinds of crazy stuff. So this guy's a massage therapist. He fell in the fire, burned his right hand. This was after a year after skin grafting. He was left with this. He came to me and he said, look, I can't move my fingers. My hand's red and swollen. What can I do? And basically I did a series of, I did some web space deepening, some other things, but the biggest part was fat grafting. And so 3 years later, after about 3 series of fat grafting, this is what his hand looks like. So it looks almost like his normal hand. And I think I owe this all to the magic of fat and its ability to change wound healing and augment the inflammatory process. This is another good case to look at. The left hand, which is, or the right hand, that's someone that's their native hand. On the other side, I did arthroscopy and I did fat grafting for basilar joint arthritis, but I also injected fat around the basilar joint in the soft tissue, and you can see the skin on the hand that has the fat looks nice and shiny and new and revitalized compared to the other thumb. So now, of course, she wants her other thumb to look just as nice. But I think this is the properties of fat. It's also used for tenolysis. You can apply this both, as I showed you, for the flexor extensor tendons. It reduces adhesions, facilitates tendon gliding, and has regenerative properties. So this is a case who failed multiple attempts of tenolysis of her finger, like when you keep operating. She had a flexor tendon injury. She kept coming back, had a few tenolyses by other people, and kept getting scarred down and not being able to move her thumb and could not fit the finger and had a terrible result, even though she had good passive motion. So here we do another tenolysis on her, and then after you do that and free the tendon up completely, This is injected fat, so you close the wound, and then you just inject the fat. How much do you inject? You inject it so it's not too tight, so you don't see the skin blanching and you kill the tissue, but just enough where you feel like you've got enough adipocytes in there, but not to the point where you're causing a vascular compromise. So it's, how much? It's like probably
really good.
four
You want to make a fist?
in the finger.
Yeah.
You can see we wake her up so she can fully move
You
her
want to bend the
finger
hip again?
to
One
make
more
sure
time?
that the TLS
Yeah.
is work. And then this is 7 minutes later, and she has lived through this, and finally she's got a fully functional finger, really good motion, which she just could not get from the other surgeries. I think it's really great for nerve decompression, for nerve to protect nerves. It also is good for nerve pain. There's been a lot of studies showing that when you have neuropathic pain, that putting fat around nerves decreases the inflammation and the pain surrounding the nerves, and a lot of literature points to this direction. So how I use this in my practice, this is a girl who had like a dequiverin's release. She had severe pain and some atrophy from previous cortisone injections, and she's had 2 surgeries by other people and didn't get any better. Her radial nerve, and we know the radial nerve is not our friend, so when you get scar tissue around the radial nerve, it just doesn't get better. You get so much causalgia. In this case, she's got the vessel loop is the blue thing that's around her radial nerve. We've isolated it. We've done a neurolysis. But how do we prevent further scarring around this nerve? She's already failed 2 surgeries. So this is a recreated extensor. First extension.
Okay, so here's a branch of your nerve that we got out. Here's another branch of your nerve. So we cleared out all your tendons.
And then we closed the whole wound, and then just fat graft in that whole zone where she kept getting these adhesions and pain around her nerve. This is her afterwards. You can see the skin's nice and rejuvenated. She's got full motion, no recurrence, and super happy. And that's after 2 attempted surgeries by others.
Nice. So
This is another release from all the scar tissue.
See, there's a big dip.
Had already a couple
Right
surgeries
here.
and has had a recurrence. You can see the
The nerve
atrophy
is
of the
compressed.
first neurosseous
You know, the scar
compartment. You
tissue.
can see the nerve
Now
compression
we
there.
release it. Let's
So in this case,
So here is the European fat and injecting it over the nerve.
fat around it.
And hopefully this will help.
And
regenerate.
then what you could do just to make them happier, even though you're not helping their dorsal interosseous compartment, you can
Now
actually
injecting
inject
fat
fat
into the
in that
femur
whole
area to
compartment.
more.
So at least
Seems
cosmetically
like
it
we
looks
have
better.
muscles
Psychologically,
there.
I think it's good for the patient.
So
They
it's
don't
so
see
much
atrophy
of
there,
area
and
there.
it gives them this idea that
So we're
they
gonna
may
never
regenerate. And this person actually did
take
really
that.
well with this. This is another for endoscopic carpal tunnel release. This is a person who had recurrent carpal tunnel. Sometimes I do this endoscopically instead of making another incision, when then you're creating the whole inflammatory process again. So you're able, with a scope, to get rid of the nerve base and scar. There's the candid. You're going to inject fat and actually deposit scar tissue. The fat injected into the nerve after we release the transverse carpal ligament and the scar tissue around the nerve endoscopically. This is what it looks like from the outside when you're injecting the fat. And these patients do well. Here's another case of a person who has a neuroma, the severe Tinel sign at that area to the point where they just can't function anymore. Here's the neuroma
So
right
here's
here.
the
You can see
proximal
the
part of your nerve.
huge
This is the whole
neuroma that we
neuroma
do a
here.
neurolysis
Here we
on.
can
How do you
check it
prevent
out.
this from being a problem
Trauma
again?
continues
They've already had a couple
here.
surgeries and the
Let's
neuroma
go
keeps
here.
recurring. So here
Okay,
is
so
we
here's
inject
the
some fat after we close the wound. And over the neuroma, you can see I have a lot of fat here, so you really want to fill it up around the nerve to give it a good cushion. And that patient did not have a recurrence. It's like
Got
several
really
years
good
ago.
fat here.
Here's another.
Now here's the fat and keratin. Now we're injecting it all over your nerve, which is right here.
Like
How we place
nerve right in the middle, and kept recurring after a couple surgeries. This one I did open because the nerve really, you couldn't see it endoscopically. I didn't think it was safe to do it endoscopically because the nerve is just
gives
a
you a lot of
big divot.
protection
You
there.
really couldn't visualize it with the endoscope. So opened up, do extensive neurolysis, and then fat graft it. We use it a lot for Dupuytren's disease. I don't know. I know you see it in Africa, not that much. We definitely see it more in the United States. Roger Curry's written about it, and I'm a big believer that Dupuytren's, it restores the atrophic tissues, it has regenerative potential, and then if you have, it prevents recurrence because you're creating soft tissue between the palmar fascia and what you've taken out and the Dupuytren's itself. So it interposes in this area. So this is a guy with Dupuytren's disease, can't fully bend his fingers or fully extend them. This is the release. So I believe that, I like to do an open release in some cases where they're that severe. And we did a complete fasciectomy. You have to dissect everything out. You can see how scarred in he is because he's had multiple surgeries already. So this is like his third surgery for Dupuytren's. The blue things are the vessel loops around the neurovascular bundles. This is afterwards. He's awake, and we ask him, does it make, oops, let me go back here. Okay, I think it might be here. This is me injecting the fat in his hand. I not always use a Penrose drain, but sometimes if it's like such a big operation, I don't want a lot of blood to accumulate in the hand because that causes fibrosis. So I like the blood to leak out, but I like the fat cells to stay in. And this is it on the table.
Okay,
so
and then straighten your hand all the way
his
out.
hand back and forth.
All the way,
Just to make sure that
okay?
everything's moving
Nice.
well.
We can see now, checking the fat, and I believe that's going to prevent the scar tissue to Dupuytren's.
And injecting him with the Dupuytren, injecting him, and oops, and then you can see how it's completely straight afterwards and never recurred. So it's very useful for Dupuytren's disease. Even limited palmar fasciectomies, I think, is very helpful. Arthroscopy. So I think it's really great for arthritis. We've written a lot about this, and it seems like a lot of what I do now has to do since as you age with your population. So as I'm getting older, a lot of my patients are showing up with arthritis that's very debilitating. And so adipose-derived stem cells can help the inflammatory process of arthritis. Because if you think of arthritis, it's really more of an inflammatory process, and that if you could change the joint from an inflammatory joint to an anti-inflamed joint, then changing the biology of the joint may just be what you need. And this was surprising to me how well it worked, but it does. So we wrote an article on this. It was published in PRS, and it was basically using a nanoscope to debride the thumb joint and then inject fat and PRP into it. We did like I think 60 patients. I've done hundreds of patients at this point, and I probably have had to operate on one who started subluxing their thumb after this. But most of them, they're really happy with the result. You don't get rid of their pain completely, but you bring it from an 8 or a 9 to a 3. So this is like someone with basilar joint arthritis. This is what it looks like. You've got this little scope in there, 1.9 scope, and you're using a shaver to kind of do a synovectomy. You can see there's a lot of arthritis in that joint. And you can't imagine that they'd ever be free of pain with all that arthritis, but you do that. And then here's the fat being injected into the joint. I like to do this under direct visualization so you can show the patient and to yourself that the fat and the PRP are going into the right place. And there it goes. It kind of blows out. I always inject it into the soft tissue as well. And patients do very well. So when I found that really worked well, then I moved it to radiocarpal arthritis. So you can see someone with really severe radiocarpal arthritis. This is the arthroscopy showing the severe arthritis in the radiocarpal joint. The bottom is the radius, the top is the scaphoid. That's the scaphoid ligament. They have a little tear in that as well. And you can see there's a lot of arthritis in the radius. But what we do is we do a synovectomy very similar to what we did with the thumb, and then inject the fat. Eventually I'm going to inject some fat in there, but I'll just move on. This is kind of what it looks like on their scope. We have them in traction tower, and under direct vision we're injecting the fat. And then there you go. There you can see it going in on the camera. Also used it for ulnar impaction syndrome. You can see like the ulna is kind of going in. So we did a little wafer resection arthroscopy. We're doing coblation just to tighten everything up. And then injecting fat right over the ulna into the ulnar carpal joint. And you fill it up for several cc's. It stays in the joint. It has nowhere else to go. So it's there and it's doing its thing. And I think like patients do very well with this. They're tender over a few days, but by 3 months, they're like good to go. And that's the regenerative process of this. This is a guy who's had multiple surgeries. He's got atrophy of his upper extremity from from some, and he's a very prominent like design guy, an architect, and so he doesn't like the atrophy from his cervical issues, and then he also has severe arthritis of his elbow. So we do arthroscopy, kind
you
of
can see that the cartilage is missing completely.
So I can see you cleaned out your joint, and here is the fat and PRP going in.
Then what you can do is also inject the fat into the soft tissue. So he's more happier that that he's got a better looking arm than the fact that his elbow joint doesn't really hurt him. But that's LA. Another where that works really well is soft tissue atrophy. So there's someone who's had multiple cortisone injections, and you can see the soft tissue atrophy is pretty severe here. And then you can see what it looks like after the cortisone. A huge change. And here's another one. There's someone where you get depigmentation from the fat grafting, from the cortisone injection. You could see how terrible it looks. So this is someone I did a basilar joint arthroplasty on at the time, and I injected fat to make sure that the wound heals well, because the skin is not really healthy. If the skin's really, really bad, sometimes I'll inject fat and let it wait several months before I make an incision on it. So then here's what it looks like. We're fat grafting this area, and this is what the hand looks like after that. So big difference. And you can see the discoloration, and then afterwards where it looks really healthy. So I've written a lot about aesthetic hand surgery in this plastic surgery book and in the Journal of Hand Surgery about fat grafting. I think that's something that plastic surgeons should be doing if you have an aesthetic practice. As you know, one of the things that give away our age is our hands because of the atrophy that occurs in the dermis and exposed veins. It turns out that the most important thing about aging hand, and there's multiple studies looking at people's idea of what their aging hand looks like, it's the veins. And you really can't take out the veins, even though people do that. That causes a lot of potential pain and suffering, and you could have some neuropathic pain. So the best thing to do to get rid of the veins is to fat graft it, right? So this is someone who had a lot of veins. We fat grafted over her hand. What I do is I just put the fat. You have to put about 20 cc's in. That's what Sidney Coleman wrote about in PRS many years ago. And it takes about 20 cc's to cover the dorsum of the hand, a lot more than what you think. And you go all the way up to the MCP joints. And then I just put a little Coban on it. You don't want to make it too tight. And there you can see like the difference. The hand looks really rejuvenated. I'll just leave it with this. Fat's not only good for the hand, since it is an aesthetic conference, I think it works really well for facial atrophy. And this is a woman with Romberg's disease, and you can see the facial atrophy on one side and then after fat grafting. So ultimately, you're fat, but you're good fat, right? So fat it can be good for you, and I think that I'm really into regenerative medicine and using our own body to heal itself, and I think fat is one of the things that we should be using more of. I use it a lot in my practice now, and I think it's really improved the outcomes. So thank you very much for having me.
Thank you so much, Dr. Kulba, for that amazing talk. We're going to take questions after. We'll have a Q&A session, so you can sit there. Thank you so much. So I'm Dr. Esther, for those who don't know me, and I'm moderating this session. So we had a bit of a hesitant start because we thought we'd go for lunch first, but now we'll go for lunch after this session. We've got some amazing topics, and I know we are standing between you guys and lunch, so we'll try and keep the time for all our speakers. There's a gentleman sitting in front of us with an African shirt, so keep looking at him. If he tells you time's over, kindly adhere to that. So the next speaker is Dr. Constance Ndu. Yeah, we've got an exotic topic from a hyena bite. Welcome.
Good afternoon, distinguished ladies and gentlemen. I'm Dr. Constance Ndum, first-year plastic surgery fellow, training at AIC Kijabe Hospital under Dr. Ntumba and Dr. Masitara. And this afternoon, I'll be talking about presenting a young man, the case of a young man who was viciously attacked by hyenas and sustained several injuries, including the loss of his right thumb. And he was able to benefit from policization to reconstruct his thumb. I have no conflict of interest to disclose. And as we know, our thumbs are very important for hand function, and they actually contribute to about half of the hand function. And the opposable nature of the thumb is what enables us to carry out dexterous and complex tasks. So loss of a thumb poses a significant handicap to the patients that actually suffer from this. And this makes reconstruction a key surgical priority, as the patient's independence also highly relies on their thumb function. Generally, the reconstruction of the thumb is tailored to the site of the injury, and reconstructive options are actually suggested according to the level of injury, with policization remaining one of the established reconstructive options. And policization actually substitutes a functional digit for a non-functional thumb. So this diagram is just an illustration that is suggesting the different reconstructive options for thumb loss, with policization being one of them, usually at the level of the MCP. So our patient was a 27-year-old male who was attacked by hyenas 9 months ago. He sustained several injuries, including the loss of his right eye, the loss of his left eye, and important to this case, the loss of his right thumb, and also a small finger amputation and an open fracture of his left radius and all that. So that is just a picture showing this patient with his absent thumb, who presented to us a few months after. The X-ray, as you can see, several fractures, and important to this case, you can see the absence of his right thumb at the level of the MCP. Initially, after his injury, he presented at a nearby health facility where debridement was done. He had wound infection for some time, which was managed conservatively, and then 4 months ago, we took him in we decided to do a thumb reconstruction policization. And intraoperatively, we saw that he had a displaced fifth metacarpal fracture on the left, with a flexor deformity of the PIP on the left. He had amputation of his right thumb at the level of the MCP, and he had a distal radioulnar joint dislocation. Intraoperatively, the left hand, the small finger fracture was reduced and stabilized with a K-wire. And for the thumb reconstruction, what was done was, so we did a policization of the index. The MCP of the index was dislocated with preservation of the neurovascular bundle. The EDC and the EIP of the index were transected, and the index was now externally rotated and transposed onto the first metacarpal and fixed with a K-wire. The distal EDC and EIP of the now new thumb were reattached to the proximal EIP. And then the stump of the FPL was transferred to the FDP of the new index to now restore the flexure function of the new thumb. The flap, which had been raised from the index, was used to reconstruct the thenar region. So for coverage, what could be covered primarily was covered, and the rest was covered with the full thickness and split thickness skin grafts, with volar spleens placed bilaterally. So that there is an image showing the intraoperative findings. You can see the exposed stump of the remnant, and the other image shows the tendon transfers and the transposition of the index. Same here. So this is him a few days after his surgery, with his new thumb and his wounds doing well. And this is him a month after surgery. His thumb is still doing well, and for now, he's grip and his pinch have improved. His independence has improved. And of course, he still has a reconstructive journey to pursue, but his independence has greatly improved following this procedure. So in conclusion, this case just goes to demonstrate that policization is a reliable option for reconstruction for traumatic thumb loss, especially in areas where microsurgical options are not available. This is AIC Kijabe, beautiful place where I train. I hope you get to visit someday. Thank you for your attention.
Thank you so much, and thank you for really keeping time. We are now back on track. The next talk is from Dr. Andrea Goritz, all the way from Switzerland. Warm welcome. Thank you so much.
Thank you, dear colleagues. It's an honor for me to be here and to present about improving arm and hand function in tetraplegia and spasticity. So probably you may think that becoming a tetraplegic or spastic patient is something rare. It is not. Every one of us can become paralyzed every day. So you can have a stroke, you can have a traumatic brain injury, you can have a traffic accident, I can fall down this step, I can dive into the shallow water here, you can get an infection, and tetraplegic patients especially are very dependent on their upper extremity function. So you see, a patient that has only wrist extension cannot grab anything. He cannot close his hand, he cannot open it. And the thumb is in a very unstable and an unfavorable position. However, if you increase the hand grip function, you can give these patients a lot of independence, mobility, and quality of life. As the pioneer of this field said, their hands are their lives. So they can manipulate their mobile phones, they can paint their eyes, they can, of course, be mobile with a wheelchair, they can work. And if you have only one muscle below the elbow, this can make a huge difference. As you see in this patient example, where we used a technique that was invented in 1911. So only the BR was present. We put it onto the ECRB. He got a strong wrist extension. We did a key pinch procedure, and he can grab and he can eat on his own again. So he can manage his whole life, as you see, in many different aspects. He can manipulate his medical drugs, he can eat, he can drink, he can read, he can phone himself, and he has also developed some tricks, as you see here. For example, there's a classic situation in daily life when you want to get out your coins from your purse.
So jetzt los.
So he starts. Now he does a little trick with his, and then using his wrist extension, he can grab even a small coin and can pay himself. So that makes a huge difference. And if you have more than one muscle below the elbow, for example, plus ECRL or ECRB, you can do a combined one-stage procedure and give the patient back hand closure, hand opening, so active thumb and finger flexion, and you can furthermore improve the position of the thumb, and you can improve wrist alignment because most of them have radial deviation, and this gives them a strong grip. And if you do it in one stage, of course, you also decrease the rehab times significantly. So we call this procedure, because it was 7 steps, the glorious 7 was a bit, sometimes with 8, sometimes only 6. So we called it advanced, balanced, combined digital extension flexion grip. And then we summed it up in the alphabet procedure. So you see a patient, before he is not able to grab a pen, only with 2 hands, and then after the operation he can firmly grip it and write whatever he wants. So you have the first step in the operation, stabilization of the thumb, bring it into a better position with a CMC1 arthrodesis mostly, then also stabilize the joints, the IP joint above all, then give them an active key pinch using the BR as a motor, put it onto the FPL, then give them an active grasp using the ECRL, put it onto the FDP, the deep finger flexors, and then you can also restore some intrinsic function, give them a better position, and give them a better opening and a better closure. And then you can also balance the wrist. When the wrist is in a severe deviation, you can balance it out so it's straight and they do not lose any strength. So we always use side-to-side suture because they are very strong, and you can literally, they also glide a bit better than the pulver tuft. You can literally start training on the first day after the operation if you want. So this is a clinical example of a young lady. She had a transverse myelitis and she had no usable hand function. Oh, sorry. How can I activate this? I'm very sorry because I tested it and it worked. Excuse me. So she could not grab anything. She could only, you have probably a few grams that you can grab. This is directly after the operation or intraoperatively in the OR, so you can see the key pinch effect of the hand. So, yeah. Okay, so that's passive, but she can do it actively after the operation. It's not on the screen. Okay, sorry. Okay, can you go back once? And that is her after the operation when she has a firm grip of her hand and can use it to write. And there are also some things that you can really do only individually. For example, also eating is something very, you have to do it yourself. It's not the same when you're fat, and probably it's also the same when you paint your lips as a woman, or if you want to shave as a man. So something very personal that you have to do with your own hands. So thank you very much. You're never too late to have these operations. So this gentleman, it's a while ago, as you see in the picture, he was 67, and we did the operation almost 30 years after his accident, and he regained a pinch of 9 kilograms and a grasp of 10 kilograms. So he wanted to have a firm handshake, and he was very happy with it. So to summarize, regarding tetra hand surgery, you have many advantages if you combine the flexor and the extensor face in one stage. If you use the side-to-side suture, you can really start training on the first day. These procedures are very reliable. You have new options using nerve transfers. I could not mention that because it would be too much. You have a very high potential to improve the posture and the function of these patients and give them more independence, mobility, and satisfaction. So now I come to the second part, which is spastic upper extremity surgery. This is a huge patient group. It's probably, it's probably 10 times or 100 times more patients than with brachial plexus injuries, and only 1%, at least in the US, in other countries probably even less, are getting hand surgical treatment. So this is a study from 2018, and in the US alone, there are about 500,000 affected patients. So these patients have a typical deformity of the upper extremity from the shoulder, elbow, forearm, wrist, thumb, and palm that you see in this gentleman. And the surgical approaches include reduction of the spastic hypertonus, either by Botox or by hyperselective neurectomy, release of muscle contractures by tenotomies or tendon lengthenings, muscle slide operations, or tendon coupling, improvement of motion by tendon transfers, and then bony and joint procedures. So this is a typical pronation contracture of the forearm. You start usually with releasing the pronated teres, both heads, and you see the effect in this clinical example. So this is a trigger muscle. He controls the whole upper extremity, and then after release, he can use the whole upper extremity very well, and you can concentrate also on other functions. The second is the wrist, which is usually in a flexion contracture, which gives them limited hand use, of course, also can compress the median nerve and creates hygienic problems. You can treat this with a combined operation, including muscle releases, tendon lengthening, probably proximal row, or even wrist arthrodesis. If you do a tendon lengthening, you can do a set lengthening and then use side-to-side sutures, which is very stable, and they can immediately move. Or you do a fractional lengthening. Fractional lengthening, as you see here, saves you a lot of time, and it's very interesting. There was a study a few years ago which saved me many, many hours of my operative time, because they found out that the fractional lengthening is for the muscles that have an overlap zone, a big overlap zone of the tendon and the muscle. So each muscle of the forearm, for example, can be looked at regarding its muscle anatomy, and then you can decide if you do the one or the other technique, and that saves you so much time when you do it. A classic example of a tendon transfer is the ECU to ECRB. The ECU is normally an extensor, but it slides down palmally, and then it gives them a ulnar deviation of the wrist. So when you re-transfer it on the extensor side, you have a good functional position of the wrist, and you have also saved the FCU for a different operation. So you see a clinical example. This is a young lady after a stroke who tries to do computer work. Doesn't look very elegant and very able, but after the operation, just PT release, lengthening of the wrist flexors and the finger flexors, she has perfect position of her hand during the work, and she has also painted her nails, and she has a very nice arm bracelet. So the hand was previously always under the table. Now it's fully reintegrated into her life again. So there's a new aspect, very exciting in my opinion. It's the neurectomies, also nerve transfers. They're coming. It's the newest. They have, in a way, been invented or refined. We call it now hyperselective neurectomy to reduce the spasticity. So we go to the muscle branches that go to the muscle, and then we cut about 2/3 of them, and we reduce the hypertonus of the spastic muscle, but we do not lose any strength and we can also correct the deformity. So you see this in a gentleman where we did simply these two procedures on the nerves of his musculocutaneous for the elbow and of his ulnar and median nerve for the wrist. And you see both joints are in a much better position. And if you combine hyperselective neurectomy and tendon procedures, you can see this is a sequence from an operation. So first you see the classic spastic deformity of elbow, wrist, fingers, thumb, and then afterwards, after tendon lengthening, release operations, and nerve procedures, you see the hand in a new, normal, and much more functional position. So I sum up, these are straightforward and reliable procedures. You can address spasticity and contracture. You have new, exciting nerve procedures. You have a high potential to improve the posture, function, and also the social aspect of the upper extremities. The patients have less deformity, less impairment, less pain. They're more independent, more mobile, and very satisfied. This is a huge population, and you should look for these patients and help them. Thank you very much for your attention.
Thank you so much. That was extremely informative. We really appreciate. Next, we have Dr. Stephen Geshoro. Thank you very much. He's presenting another interesting, is it a case report? Yes. You're very welcome.
All right, good afternoon, everyone. So I'm going to describe a case of a single-stage multi-flap reconstruction for severe upper limb contractures after a snake bite. My name is Dr. Gishuru. I'm from University of Nairobi. We co-authored this with Dr. Constance here and Dr. Masitara. So to start, how do we end up with contractures in snake bites? Mainly, it is as a result of the venom-induced local tissue necrosis, which destroys the skin, muscle, and connective tissue. And then the compartment syndrome, which results causing swelling, which increases pressure and also causes further necrosis. The final mechanism is mainly abnormal wound healing and scarring, which limits joint movement. So our main goals is to allow for movement of those joints and to cover that particular defect when you release the joint with pliable, natural-looking soft tissue. When we are planning to excise a contracture, we usually incise it, excise all the scar tissue, and reorient the tissues around to allow for movement. And then postoperatively, we consider splinting, scar management, and early mobilization. So in our specific case, we had a 4-year-old male patient who came to us about 1 year, 6 months after snake bite, initially managed conservatively, admitted to the ICU for about 1 month, then discharged 5 months later with a chronic wound. At that particular point, no physiotherapy or splintage had been introduced. And even when they were discharged, they continued on wound care. Over the 7 months afterwards, they were noted to have progressively disabling contracture formation. And our first encounter with the patient was 1 year later, and we scheduled for reconstruction. Of note is the patient has not been very consistent with physiotherapy because of the financial constraints. So when you assess the patient, we use the Potocka's 5 Ps, the problems, where you look at the form or the appearance of the scars, the restriction, whether there's pain, itchiness, and the psychological issues the patient has. We ask the relatives to rank these problems, what are the possible options we can offer them, and what are the perceptions they have to those options, and what is our plan. So if you can see, in terms of form, we have, in terms of form, we have severe scarring that is present in the left upper limb, and specifically in the axilla, we have the shoulder in abduction, and the elbow is flexed, and the wrist is extended to about 20 to 30 degrees. There's limited function in all those joints. Specifically, there was no pain. Itchiness was noted, some mild itchiness, but there was no pharmacological intervention offered to the patient. Psychologically, the patient would reduce usage of that limb, and there was an element of social withdrawal, but there were no behavioral problems with the patient. So our priorities were to restore functional range of motion of the wrist and the elbow, to improve independence in daily activities, and secondarily offer cosmetic options that would improve the psychosocial well-being of the patient. So the principle was either we do staged or single staged reconstruction, and the staged is mainly based on the crane mechanism rationale, whereby we think of the elbow and the shoulder as the pivot and base, and the hand as the functional operational unit, because having a mobile wrist is of little use if the arm is not able to orient and reach. But the single stage was mainly considered, in our case, mainly because of the synergy by having a coordinated joint rehabilitation process, the efficiency of care, reducing the trips to theater, anesthesia risks, and for the psychological impact by having one procedure where you are able to sort out the patient and they get a boost in the moods and courage. The resource conscious strategy, because the patient was coming from a poor background, so this would help reduce the trips and the payments they have to make for multiple surgeries. So the perceptions of the patient and the surgeons were in line and very realistic, and the plan was multidisciplinary with single stage planned. So this is what we did. We did incisions were fish mouth incisions where we excised, and then we excised the scar tissue. For the axilla, we did one Z-plasty. For the elbow and the wrist, we did perforator plus fasciocutaneous flaps. So for the elbow specifically, we used thoracoepigastric based on the superior epigastric vessels, and for the wrist, we used contralateral paraumbilical based on the deep inferior epigastric perforators. This is immediately post-op. This is on the first change of dressing when we started initiating early active movement. And this is 3 weeks after, before flap division. This is after we divided the flap immediately. And then this is 1 day post-op after the flap division with the elbow in extension and the wrist in neutral position. And this is 3 months later with intermittent physiotherapy. You can see that the elbow is still having some flexion contraction. Thank you very much.
Thank you so much. So, Dr. Kulba, thank you so much.
Okay, I'm going to try to go fast because I know it's lunch.
No, we are not running too behind. We are fine.
So I'm plugged in. Just you guys change it over to this. What do I need to do? Okay, here we go. Okay, so this is worth your while because this is going to blow your mind, okay? So I'm going to talk to you about using meniscus allograft to reconstruct joints in the hand. And this is something that's pretty far-fetched, but it works really well. And I've been doing this for the last 12 years, so I've got about 12 to maybe even 14 years of follow-up. So I'm going to tell you how this started, okay? And my disclosure is I'm on the board of directors for the MTF Biologics, which is the largest tissue bank in the world. And this is probably how I got access to this tissue and got to thinking about biologic reconstruction of joints. So just as a background, small joint reconstruction and wrist and even elbow joint reconstruction, it affects our pain use. Oftentimes we use prosthetics, or you have to fuse the joint, and it impacts both our daily living and use of our hands. And it's a very difficult problem to treat. There's no really great solutions to this. And I think the idea of putting mechanical things in your joint, like foreign bodies, to reconstruct your knee or your hip or your elbow or your shoulder is really something that we're going to look back on thinking it was fairly barbaric and primitive. But what's happening is as we are living longer because We're figuring out better ways to keep our organs alive. Our musculoskeletal system wasn't designed to live that long, and so we are handling a lot of people in their 60s and 70s, 80s, 90s, which we used to think were old. Now they're young and they want to walk and not have pain. I think that the current surgical techniques for the upper extremity or arthrodesis or just joint replacements, which have limited time length of they actually break, they fracture, they get infected, and they don't last forever. And I think they don't last for a very long time, and they're really subject to a lot of complications, especially in the hand and wrist and elbow. So I just happened to have a patient many years ago who is an artist and a big Swedish guy, 6'4", liked to sail. He had arthritis of his MCP joint. I'll show you his case in a second. And I was thinking to myself, well, fibrocartilage maybe is a better lining of a joint than hyaline cartilage. So hyaline cartilage, it's very fragile. If you fracture it, the cells die, the chondrocytes die. A lot of research has been made on how do we make cartilage? How do we make hyaline cartilage? And I think that's probably maybe not the right way to think of it. I think as people are aging, we have to think about how do we make something better than hyaline cartilage. And so I just happened to be at MTF, and I was looking at fibrocartilage, which is in the knee in patients, which is weight bearing. And fibrocartilage is really strong. It doesn't require a lot of metabolic support. And if you look at a 90-year-old fibrocartilage, if it hasn't been damaged, it's in great shape. It takes the wear and tear of the body very, very well, and it's a weight-bearing cartilage. So why can't you use it to line joints? So that was my thought of maybe that meniscus allograft, which is decellularized meniscus, so it doesn't have any DNA in it. It's completely treated, and maybe that could work, okay? So this is all the idea of why it would work. I can retain joint motion. You'll see all these cases why this may be a fairly good idea. So first, before I started doing this in human beings, I did a pig model, load-bearing model. We created an arthritic model. We put the meniscus in it. You can't put a cast around a pig, it turns out. They eat it and tear it apart, so there's no way to mobilize a pig's leg. So I learned that for the first one I did. It didn't work. So then we have to go to internal fixation, which seems kind of crazy, but that's the only way to immobilize a joint in a pig. Otherwise, they're able to just eat it in a second. We got an MRI showing that it gets reintegrated. 8 weeks post-op, it's totally part of the joint. We could see the load-bearing surface maintains, and these pathology results totally integrated on pathology. This is one of the joints we use, which is a non-load-bearing joint, and this is the meniscus sutured in place, the mobilization, and then a week later, you could see it's totally integrated. So within 1 week, you decorticate the joint, so you have the medullary cortex, which has the stem cells that grow in and repopulate the meniscus allograft, and then you've got a totally integrated joint. Within a week, it's adherent. So we've written a lot about this. I'm going to talk to you about several joints. I'll go through it really quickly, but I've written many papers about this with long-term follow-up. So this is the first case I did. This is before, it's now manufactured, but before I used to have to cut it on the back table, and you basically have two sides of it. You got the rough surface, which goes into the bone, and then a smooth surface, which goes onto the joint. This is this artist who had severe arthritis of his MCP joint that I told you about. He didn't want his joint fused, and he would have gone through a joint replacement like a siloelastic implant in a second. So it'd just break it. He's just a big guy. So he told me, figure out something else, and I'll do it. So this is what I figured out. Here's the chondral defect in his bone. That's the metacarpal head. This is the meniscus. This is it sutured in place. That's what it looks like ultimately when you're done. I just put some transosseous sutures. And the more I've done this, the more I realize you just need a couple sutures to hold it in place because it's in a joint. It has nowhere to go. It's not going to go anywhere. And you just immobilize them for a few weeks, let the medullary cortex grow into it. This is what it looks like on the X-ray, MRI, because it was the first one I did, just to see that it gets integrated. And this is function. Okay, this is about 10 years post-op. Fully functional, and it's its third digit. You can't even tell. It's stood the test of time. So moving on, this is an elderly female, 65. I don't think 65 is so old anymore since I'm almost 65. But anyway, severe arthritis of her hand, and you can see She has really limited motion of her index finger. So she's going to be asked to bend her index finger. It doesn't bend. Very painful. So normally this is something you'd fuse. The implant wouldn't really work very well for this. You can see the severe derangement of her joint. So we're going to do a meniscus arthroplasty, basically decorticate only. I realized you only have to decorticate one side of the joint. So you just decorticate the more deranged side. You put in the meniscus, which is, you can see the allograft is in placed. It's really in the distal part of the joint. There's a suture anchor there for the collateral ligament. And then this is her motion afterwards. Let's see.
Great, let me see first.
And I don't think you could get any better with it. Yeah, that's pretty good, right?
And
It's a
if you
hinge
know?
joint. You can't get better motion with an implant. This is a guy, a little young kid, dislocated his joint. He has no motion of his finger. It's a little dislocation. He didn't get treatment in it. So this works for young people too. So he has no motion, dislocated joint. The joint has arthritis in it. So here we're going to decorticate the joint. I think it's really important that when you do this at the burr, decorticate the cancellous bone, because the cancellous bone is what has stem cells in it. So there's the decortication. There's the meniscus suture in place. Right there, I'm pointing to it with my pickups.
Anchored down to the base. There's the lower.
There's the X-ray showing the joints now realigned really nicely. This is intraoperatively. You can see the range of motion in his finger. It's really nice. It goes all the way down. This is 4 weeks post-op. Pretty good.
And good.
This is 10 weeks post-op.
10 weeks out, let's see the best.
Very good. This is another case of a PIP arthroplasty in a lady that I did like about 8 years ago, and she came back to me to see her for arthritis. This is what the case was. This is actually 8 years now. Stop. And this is the range of motion of her finger, is her third finger. So it just shows you that it stands the test of time. And this is way better than you could do with an implant. So this is another case of a thumb IP joint I did several years ago, severe arthritis. I normally would have fused this joint, but there's a meniscus sutured in place. And here's his thumb bending. So instead of having a fusion, he's got some flexion of the IP joint, which changes your life, being able to bend your thumb a little instead of having kind of a straight thumb, especially if you play instruments or do fine motor. And so I've gotten to the DIP joint. Normally, DIP joints we fuse. It's super common to have arthritis of your DIP joint. But people who play like instruments and do fine motor things, it's a big deal to fuse their joints. So this is someone who I fused their DIP joint. Instead of fusing it, I did the meniscus arthroplasty in, and you can see this afterwards. They have no pain.
Arthroplasty of the DIP joint. You can see there's motion here, but it's not painful.
They have zero pain, and we're actually rating this up. So then I went to the thumb joint, basilar joint arthroplasties. That's probably the most common, is thumb arthritis as we get older. And the ones that fail, like the PRP injection, or the ones that have unstable joints where they're just mechanically too bad. This is like someone who just has severe arthritis. This is joint resurfacing. This is the meniscus sutured in place. And there it is, right in the base of the thumb trapezium. That works really well. You could see the nice joint space. This is an MRI showing the meniscus in place. This is someone afterwards that have no pain in their thumb. It's really dramatic, the outcome in this. And you're not, instead of taking out the trapezium bone, which has been the standard of care, I think that's really a bad thing to do. You should do everything not to take out the trapezium. It collapses the thumb. You lose strength in your hand. You get a floppy thumb, especially it's really a good operation for old ladies who don't use their thumb, and that's what it was invented for. But now we see much younger people getting arthritis at the base of their thumb. And people are living longer, and they want to do activities, and they require a lot more out of their thumb than it used to be. So I think it's really incumbent upon us not to take out the trapezium. Here's another very similar one. I think it's important to close the capsule about a couple other cases. I used it for STT arthritis, which works very well in the hand. And there is a suture into the STT joint. We wrote this up in a CMC joint arthritis, a young kid who had a CMC joint non-union. You could see the arthritis at the base of his fifth metacarpal CMC joint. We put the meniscus in, and he got better, and it's longed it. So we also have done it in the wrist joint, PRCs. We wrote this up. So this is, I'm going to show you just a really bad joint. This is a guy who's a doctor. He's a fertility doctor. He's had 20 years of cortisone injections to his wrist. You can see what his wrist looks like. It's a disaster. Just cortisone all over the place, severe arthritis in the joint itself. There's the meniscus sutured in place at the radiocarpal joint. And then here he is. He couldn't play golf before, and he loved playing golf. Of course, so this is him in Los Angeles at the Hillcrest Country Club teeing off about 3 months after surgery. It's an okay tee shot, not great, but anyways, he's able to hit the ball, okay? This is interesting just to show you. This is a lady who I did a meniscus arthroplasty of her thumb. A year later, her horse kicked her in her thumb, dislocated her thumb, so I had to repair the dorsal capsule. So I put a scope in to see what it would look like, and you can see the base where the trapezium was surface looks like a brand new joint. So I was really glad to see that. This is another person who I had to reoperate on many years later, and I did a meniscus arthroplasty, and she broke her hand, her proximal phalanx. So you can see the meniscus is really in place. And then this is a really interesting case. I usually don't do rheumatoids with this because her bone quality isn't good enough, but there's a young girl who had severe rheumatoid arthritis, and so I did a resurfacing. That's the picture on the left. The middle picture is the meniscus in place, and then it turns out she went off all of her anti-rheumatoid medication because she was feeling so good, and about a year later she ruptured some tendons. I went back and I looked into her joint, and I think the important part of this slide is that you look at the distal carpus, which looks really sclerotic distally, and now you look at the carpus and it looks nice and red and healthy. So, and you can see the meniscus completely adherent there, like a brand new joint. So this is available commercially. It's pre-cut now, and it's called the Vivo, and it's very similar. It comes in different sizes. And then this is just to bring this home. So this is Colin Hay. He's the lead singer of Men at Work. I took care of him, and I'm at his concert. I was not expecting this. I don't know if you hear this, but he gave me a shout out.
And this is my doctor, David, who fixed my hand. He gave me a new cartilage.
Cartilage in my joint. So he gave me a shout out. So thank you very much. I appreciate it.
Thank you so much. So, thank you so much to all our speakers. Dr. David, that was mind-blowing, as you said. It was a really nice or really informative. I didn't know that existed, menisco allograft. So thank you so much. Your other topic was also very, very informative to do with, we do a lot of fat grafting here, but it's nice to have new applications. So that was extremely informative. Dr. Stephen, your talk was amazing, showcasing the complex problems we see here. That's very typical for us, so thank you for that. Dr. Constance, polycization is probably the most complex procedure a hand surgeon attempts, so that was amazing. And Dr. Andrea, thank you so much, dealing with extremely complex patients that sometimes we just see and we tell them there's nothing we can do. Thank you for showing us that there's a lot we can do. So thank you so much. So a round of applause for all our speakers. Thank you. So now we're going to go into a Q&A session. So because of time, we're not going to take a lot of questions. So we're going to take all the questions first, and then you can sort of note the questions you have and then address them one by one. So any questions, please, for the speakers? I think we have a first question. Will be the next question.
Yes, thank you. Excellent talks. Ndum, what did you do? You did a disarticulation of the index finger at the MCP. Jay, how did you handle the metacarpal, the second metacarpal, and how did you handle the proximal phalanx of that index finger, given that you had your CMC joint, the first CMC joint intact? The number two, to Dr. Andrea, on tendon versus high selective neurectomy. I don't know how you compare your high selective neurectomy versus the tendon procedures. How do you decide which you want to do now that you have the latest thing that you're doing, which is the highly selective neurectomy? And do you do any Botox to just see whether you have any improvement before you go ahead to do the HSN? Gishuru, yes, you showed us the results later. We still had some elbow flexion. Thinking retrospectively, do you think maybe staging the procedure would have given you better results in as much as the elbow is concerned? Then lastly, Dr. Kulba, you're using fibrocartilage allografts to do all that amazing work. In Kenya currently, we are not yet there. Are there sources of autologous fibrocartilage that we could get locally before we get to the allografts? Thank you.
All right. So we're just going to remember the questions that you've been asked. We're going to get another set of questions. Kindly hand over the mic. And then after that, I'll just allow only one more, and then we can answer the questions.
Yeah. Thanks very much. Thanks, Dr. Kulba, for the excellent talk. Just a quick query. I think you may have tried it, but have you tried fibrin glue instead of stitches to hold the allograft? You know, just curious about that. If you've tried fibrin glue instead of sutures, I suspect you may have tried that.
All right, and any, yes, please.
So my question to Dr. David Colbert. So do you process the fat into microfat or nanofat before injection? How do you just process it?
Okay, thank you. Just one last question, Dr. Wabwire.
Thank you very much, Dr. Kuba, for your two very informative talks. Maybe going back to the first one, other than fat grafts and this relation for nerves and tendons as well, have you tried periaponeurotic membranous or adipofacial free grafts?
All right, so that wraps all the questions. So we'll start with Dr. Kulba, and we can remind you if you've forgotten.
Okay. Let's see. So the first question was about autologous cartilage, fibrocartilage, and no, you need all the cartilage in your body. There's not one place that you could lose fibrocartilage. It's mostly in your knee, and you need it the most there. So you cannot, you can't borrow any cartilage from your body. That goes the same with collateral ligaments, and we actually have a paper coming out about using MCL ligaments from the knee to reconstruct collateral ligaments, because you can't borrow those. So oftentimes we use tendon grafts which stretch out because they don't have the same properties of ligaments. So the answer is no to that. The answer to the fibrin glue, I worked at the Red Cross, and I did some of the initial testing, inventing the fibrin glue and the device that delivers it. Unfortunately, I was telling my colleagues I didn't patent it, and I was happy to be a research guy because I was back in the 80s. But I use fibrin glue judiciously, and I do use it on these cases. And sometimes I'll put a suture in, but I also put fibrin glue in between the meniscus and the joint just to create a space so it doesn't adhere while you're immobilizing them. So I didn't show that in the photos, but yes, fibrin glue, great idea. I love fibrin glue. It has great growth factors, and it does all this other great stuff. Regarding the micro fat, so I don't do that for the upper extremity, but if I'm doing facial cosmetic work, then I'll do some micro processing of it and either centrifuging it or side, because I think in the face you can have big clumps of fat tissue. You have to be very careful, especially around the eyes, around certain parts of your face. I think you have to be a little more careful with how you inject the fat, because you could get big clumps of fat in that area. But for the joint in the upper extremity, you actually want some of the volume, so I don't think it's been an issue. And then finally, the adipofascial free grafts. I do like adipofascial flaps. I haven't taken a free graft for anything except for frontal facial fractures where you put fat into the frontal bone, but I've not used it as a full-on graft in other places. I think I'm just worried that it's too much fat that would maybe not get revascularized as well and not completely live. Okay, thank you.
Yeah, just one more question. Oh, sorry. A comment. Yes.
Yes.
Congratulations. I also like fat grafting in nerve problem, the peripheral nerve problem. But the case with the neuromen continuity left me a little bit uncertain, because neuromen continuity is one of the worst clinical situations you can find. Very difficult to solve. But theoretically, you should resect the neuroma, leave the intact fibers.
Yeah, so on that,
and then you should
so in
graft.
that case, here's the real problem, okay? The patient had full sensation in her fingers, but pain. So you can't really, you have to be very careful, because if you resect the neuroma, right, then she's insensate. You've done her a big disservice. So this was like debulking of the neuroma under a microscope without taking out the neuroma itself, because I agree, if you have no sensation and you have pain, you resect the neuroma, right? To healthy tissue, you can either graft it or repair it primarily. But when you have full sensation, you're stuck. You don't want to take away her sensation. So it's debulking and then fat grafting. But yeah, I agree with you, yes.
Right. Thank you.
Thank you. Dr. Barra, yes. So the studies have shown the convention is to start from proximal to distal, and they've shown that there are better outcomes. There are more long-term studies that have shown that. There are other shorter studies where some surgeons have done proximal to distal to proximal. Those ones have shorter follow-up, so we can't really speak on that. But for our case, I think we opine that the reason why we're having some of that is because of the poor compliance with physiotherapy. So that's why we think maybe that recurrence is coming in. Thank you.
I hope this is okay. For accuracy and clarity, can I refer my question to my consultant?
Yes, we agree.
The assumption is I was listening. So I guess back to Dr. Kulba's statement. There are several ways of looking at the thumb, either as a fully mobile organ or as a post. So if you can't get a fully mobile, non-painful unit, the organ, then what you want to create is a post that everybody else comes to. Having said that, what you need in a thumb is a distal phalanx, proximal phalanx, and then the metacarpal. So what was left of the metacarpal was about 1.5 centimeters. And so in order to create a thumb sitting on the metacarpal, which is a blessing because then your CMC is in place. Your CMC is really the most important joint on your thumb. Then what we did was take the middle phalanx, take the base of the middle phalanx and seat that and everything else. So basically what the young man had was a ray amputation, taking away the metacarpal and the metacarpal, proximal phalanx, and base of the middle phalanx, and then positioning it. I don't know whether that answers. Thank you. And then the other is, important thoughts are, you can divide the digital nerves and hook them on to the thumb, native thumb digital nerves, if those are available. The problem is the hyena wasn't surgical, so avulsion is more likely. Moving the index to the thumb without doing that requires re-education at the brain level to be able to know that that's the thumb. It's much better if you can actually shift the digital nerves. I think I'll stop there if I've answered your question. Thank you.
Thank you, sir.
All right, thank you. We move on to Dr. Andreas.
Thank you. So the question was how to do hyperselective neurectomy and when to do nerve procedures and when to do the conventional classic tendon muscle procedure. So in a spastic deformity, you have both components. You have a contracture that results from the spastic hypertonus. And the spastic hypertonus comes from the brain. You cannot operate in the brain. You can operate on the peripheral nerve that gives the signal to the muscle for the hypertonus. So you try to differentiate between the musculoskeletal contracture, and you correct that with tendon lengthening, muscle release operation, muscle slide, or tendon transfers. In some instances, you can also do a joint fusion, for example, in the wrist. However, if you do not correct the spastic hypertonus, they will most probably, you create a new balance, but they will have a recurrence. So you try to reduce the hypertonus by selectively transecting about 2/3, sometimes more. You can use a stimulator and then test it, for example, in the muscle nerve that innervates the biceps and the brachialis. You have usually 3 to 5 branches that go into the muscles. So you dissect them, and then you stimulate them, and then you decide, okay, I take out, because the brachialis has probably 3 branches, I take out 2 branches. And then I leave one branch that still innervates the brachialis. And I do the same with the biceps. And then I look for the radial nerve, because there's also a branch to the brachialis, so I take out that one if it's present. And if you leave 1/3 about of the motor fibers, the patient can still move the arm with the same strength, so he does not lose any muscular strength, does not downgrade, but the hypertonus is much less, and the rate of recurrence is also much less. And some of these patients, they have no contractor, they have only a hypertonus, for example, in the biceps or in the brachialis, so you can only do this fun nerve procedure, which takes you probably half an hour, and then on the next day, the patient who was previously like this, he will greet you like this, because he has full command and control of his previously hypertonic arm again.
All right. Thank you. Thank you very much. Thank you very much to all our speakers. Another round of applause, please. Thank you. So we're going to proceed to lunch in the main restaurant. And after lunch, kindly visit our sponsors' booths. And also, for those who have lingering questions, I'm sure, kindly discuss them with our speakers during lunch.
There's more alteration of made in the order of the presentations, so that we get a feel of what orthoplastics is, and then we can have the case series or the case reports after that. So we shall start with the last 2 presentations. They are listed as masterclass in the program, and our first presenter will be Professor Innocent from the Orthoplastic Surgery Department, Regional Institute from the University of Bologna in Italy. You're welcome, Professor. So there are many scientific events different from orthopedic surgery. This is the definition given by ChatGPT. So it's bridging the divide between orthopedics and plastic surgery. This is a simple, good definition. But I prefer the one given by Scott, who is the modern father of orthoplastic surgery, and he defined this subspecialty as that specialty where principle and practice of both specialties are applied to clinical problems simultaneously. So the ideal orthoplastic surgeon is that surgeon double board certificated, so with experience and a background in plastic surgery and also in orthopedic surgery. For example, I have like this. I have both specialty in my background. But this is not very common to find. So an alternative way to apply orthoplastic surgery is to have a very good interaction between an orthopedic surgeon and a plastic surgeon. Because the characteristics of the two types of surgery are different. And we should take advantage of the best of both specialties. So the orthopedic surgeon is a master in osteosynthesis, of course. Is more used to emergency procedure. When a big trauma comes to the emergency room, is usually the orthopedic surgeon who is there, not the plastic surgeon. He knows much better than the plastic surgeon prevention and treatment of infection. So the damage control is in the hand of the orthopedic surgeon. The orthopedic surgeon is very experienced also in function and biomechanics. And if you want to reconstruct a limb, you must know the function. The plastic surgeon, on the other side, has the know-how and management of soft tissue, is expert in the knowledge of the small vascular network, which are nowadays used in microsurgery. It's supposed to have this more gentle surgeon, to have a soft approach to the tissues. He must be expert in microsurgery, in a way. And last but not least, the plastic surgeon take care also of the cosmetic result, because nowadays, in 2025, it's not enough to fill the hole. We have to give also a good appearance, the best appearance that you can, both in the receiving area and in the donor side. So the most difficult thing in orthoplasty is to teach it, because there are no programs so far. Of course, we have to share a protocol. The orthopedic surgeon must at least know the basic of plastics and the reverse. And this is not easy to teach, because orthoplastic surgery doesn't mean that the orthopedic is in their art
show you how many different ways to fix the bone exist. An interesting topic in talking about orthoplastic surgery is the functioning muscle transfer, because, as I said, the first aim of the orthoplastic surgery is to restore function. Then aesthetics come, possibly, but function is more important. And I show this case. This case, to my knowledge, is unique in the world, because this is the youngest patient who had a functioning muscle transfer. In the literature, I didn't find anything else. So she was affected by neonatal synovial sarcoma in the forearm, involving the entire posterior compartment, so all the muscle and the radial nerve were resected by the tumor surgeon. So we had to reconstruct the soft tissue and also restore the function. So I decided to do a conventional tendon transfer to reconstruct the extensor pollicis longus and the extensor carpi radialis. But since I had to put a free flap for the soft tissue defect, I said, okay, why not do functioning? So I harvested the smallest latissimus dorsi of my life. See, in my hand, and I have gloves number 7, so I have very small hand, and this is even smaller. And in this pedicle there is an artery, a vein, and a nerve. So we put in the forearm, we did the vascular anastomosis and the nerve captation with the radial nerve, and look. Okay, this is 2 months after surgery, and the function restored is the extension of the finger. A result like this is possible in a 7 months baby, because the biological potential is amazing. If you do something like that in an adult, you would expect some result after 8 months, maybe 9 months. But at 7 months, you have this amazing result, and this is the same patient 4 years later, free of disease and with a very good function. We have also good experience in reconstruction of the quadriceps resection after sarcoma. We have the biggest series in the world. We published some years ago. So we have 11 patients. It's not very common, but I've been working with the 2 major sarcoma centers in Italy, so we collected almost all the cases in Italy. Of course, the result is much better if only 2 parts of the quadriceps are resected. So if you put a functioning latissimus dorsi, you just reinforce. But when you resect everything, when you have a total resection of the quadriceps, so the function of the transferred muscle is more important. And you see this case is almost total resection of the quadriceps. Okay, the video is not working. Anyway, he is able to extend the leg in the knee, and he has no problem in ascending and descending stair. This is a presentation I gave in Barcelona at the World Congress a couple of months ago, and I would like to show you also, because amputation is not a simple procedure, and if you revise it, the amputation according to the new concept, you will see that it is a very, very technical operation. Is really a true reconstructive procedure, because amputation means to save the level, try to stay as distal as possible, and give a functioning limb. So this is, of course, maybe the oldest surgical procedure in the world, but it's a surgery where, in my opinion, wisdom and experience are as important as technical skill. It's not something that can be done by the residents. It's something which must be done by experienced surgeon. And also the decision making, all these points that you find here and you find everywhere, in every presentation, in every paper, age, gender, weight. In case of the amputation, they have a real value because it depends on the lifestyle of the patient. So you have to consider a lot of things, choosing a type of amputation instead of another one. And I'll show you just a few cases. For the salvage of the stump, we have been using free flaps for many years, so there is nothing new in this. But look at this case. This I did personally, this amputation in this guy 20 years ago. But the stump was unstable after 20 years. The popliteal artery had the thrombosis, so the blood supply was very bad. And he had ulcers, recurrent ulcers, so he wanted to have an above-knee amputation. When you do an above-knee amputation, the regular one is usually mid-shaft. It means that all the muscle have no insertion. So all the muscle are cut together with the bone, and they are free inside the stump. If you do this, so we did a disarticulation of the knee, not a mid-shaft amputation. Disarticulation of the knee. We saved all the extensor apparatus. You see the thing that I have in the hand is the patella. I pull the patella inside the intercondylar groove, which is where the cartilage is removed. And as you see, now in the X-ray, so you see that the patella is fixed to the distal femur. That means that this patient has full function of his quadriceps. And this is very important because the elevation of the flexion of the thigh to the hip joint is controlled by the rectus femoris. If the rectus femoris is flying in nowhere, the function is much less. That means that you have to talk with the prosthesis guys because the prosthesis is different. The joint is more distal than the contralateral knee. So it's something that where you have to work, but you have a much, much better result. And look at this. This is after 30 days, the stump is perfect. And, okay. I don't know how. Okay, don't worry. Anyway, you see the contraction of the quadriceps. It's very strong. Only 4 weeks after surgery. We have to try to keep as much length as possible. So this guy was transferred to us 45 days after injury. Timing is a big problem in orthoplastic surgery. Somewhere else, they did a bypass of the popliteal artery to the peroneal artery. Don't ask me why. Because, you know, you have the anterior tibial artery, you have the posterior tibial artery. Why to do a bypass to the peroneal artery? I didn't understand. Anyway, the bypass was not working. So the foot was infected, not very well vascularized. So the orthopedic surgeon said, okay, I do a transfemoral amputation. And so but I said, no, we can do something else, because you see that the problem was that the stump of the tibia is too short for a prosthesis. So from the orthopedic side, they say, okay, we cannot do anything. We cannot do a prosthesis with such a short stump, so we cut above. But I thought we can do an amputation moving the distal part of the tibia proximally connected to the soft tissue, so it is vascularized, and it gives a length for a prosthesis. So you see, the small piece, the white piece of bone that I cannot fix it with an external fixator is the distal part of the tibia, which has been resected, moved up, and fixed to the stump. And you see, it healed. There's 6 months post-op. There's a very nice stump. And this is 6 months later. He couldn't do this with a transfemoral amputation, no way. This is unfortunately true. So last year I went to Ukraine for a few weeks. And it's interesting that in Vinnytsia, this city, this is the home of Nikolai Pirogov. Nikolai Pirogov is one of the fathers of orthoplastic surgery, and he has a beautiful museum in his house. And it did also many innovation. He's particularly loved by the soldier because he introduced the anesthesiologist in the battlefield. So it was much better to have amputation under anesthesia than without. And I show you just another case to show how to make simple what could be difficult. This is a soldier from the front line 45 days after injury. I have seen a lot of amputation of stump not closed after 1 month, 2 months, and this is all infected, is not easy. So in this case we had a defect in the popliteal fossa, right side, left side also. So on the left side I did the propeller flap and I closed the skin. But it is interesting the right side. So this is the left side, but this is just normal surgery. The decision making in right side is something more interesting. So in this case, I have a too long bone, because the bone is too long. I don't need such a long bone. I have a big defect in the popliteal fossa, and I have a good calf with the posterior tibial artery working, very well vascularized. So the plan was to move as a block all this proximally to close the defect in the, then you expose the tibia, of course, but the tibia is too long, so we cut the tibia. This is all the bunch of tissue which is posterior and can be moved proximally. You see the result, no, here, you see the result, which is really nice. And so with a simple procedure, you save the knee and you have a very good stump. So this introduced the concept of the spare parts. And I show you a couple of cases. Particularly in emerging countries, it's particularly important to use what you have and try not to throw in the basket anything. So this is a man with a recurrent of a rhabdomyosarcoma. 2 ray were involved. So we had to resect 2 MP joints, second and third. So in a fancy Korean hospital, they would do toe-to-hand, vascularized joint transfer, tendon transfer, think very complicated, which of course can be done, but not here probably. And also, for me, was too much. So what I did is just to try to use part of one finger to have the other finger working easily. So I did the amputation of the second finger, saving the PIP joint, as you can see there, and the skin. So it's vascularized. So I moved the PIP joint of the second finger in the third finger to do the MP joint, and you see the X-ray, and you see the result. And believe to me, this is much better than any joint transfer. It takes months for rehabilitation and with the uncertain result. And this is the function. He missed one finger, but functionally, no problem. Another case, just talking about spare part. This is a special case. It's a long history, so I go through straight to the point. This girl, very young and nice girl, had an amputation right side with a very unstable stump. On the left side, she had a horrible knee, horrible joint, multiple surgery, and she didn't want to do any more surgery for the knee. So she asked for above knee amputation on the left side. I said, okay, let's do this, but we want to use the anterior tibial muscle and the skin to resurface the stump, because the stump on the other side was very bad. So instead of us harvesting an altissimus or ALT flap, I just used the spare part. So this part was going to be amputated, and before the amputation, we harvested the flap, which is not in the literature, because of course you cannot do in a healthy person. You can, it's too invasive. You make a big damage. But since this piece of the body was going to go in the basket, we used this flap, and you see the new stump, which is very good. And this patient, after a few months, was able to go to the gym. Be creative. So in our surgery, the biggest appeal is that if we wisely apply our knowledge, we can do something really sometimes exceptional. So this is a boy, 7 years old, unisarcoma distal humerus. We had to resect the entire distal humerus. And at 7 years, there are no prostheses that can use. So the only option, the only option would be arthrodesis of the knee, of the elbow with a vascularized fibula. But we can do something better. So I decided to do a prefabricated flap using the proximal part of the iliac crest. If you turn upside down, you see that the contour is quite similar to the olecranon. And then I put a fibula to make the diaphysis. So this is the project. So the fibula, then the iliac crest with the side anastomosis between the peroneal artery and the deep circumflex iliac artery. So both segments are vascularized. And that is. The tumor, the fibula, the iliac crest fixed together, the X-ray, and the result at 12 months. So this is like a biological prosthesis which has never been done, and this is a very good option for this patient. But innovation is not only science fiction. Sometimes you can do something easy. I showed this technique that I described also a few years ago. So everybody is very familiar with medial gastro. You can do medial gastro myocutaneous or only muscle. But if you do that myocutaneous and you look for a perforator, you can have what we call gastropropeller flap. So you can move the skin island whatever you want. This is the case. And this is the flap. You see that the muscle is there, and the perforator, which provide blood supply to the skin, you see there, little. And the skin is 90 degrees to the muscle. So the muscle goes to the tibial tuberosity, and the skin goes where we need it, over the patella. So the skin is a good gliding surface. We put an external fixator, then it was implanted a prosthesis, and this is the result. Last case, hybrid reconstruction. I think that the future is in the marriage between biology and technology. So this is a very severe case because it's a 12-year-old girl with subtotal resection of the humerus. So only a small part of the epiphysis survived. And this is impossible to reconstruct conventionally. And even with the fibula is impossible. So we decided to do a custom-made 3D printed prosthesis in titanium. It's a cage where the fibula is inside, and there is a window in the cage to do the anastomosis of the pedicle. And you see the X-ray, the prosthesis, it's outside, the fibula is inside, the anastomosis has been done mid-shaft, and the fibula provide the blood supply to the residual part of the humerus, which survived, as you can see. So this prosthesis will not last for the life of this patient, but if it works for 6-7 years, when it failed, we remove the prosthesis and we have a humerus there, ready for a new, more conventional prosthesis. So the last, I want to acknowledge again the very good cooperation between the Italian Society for Reconstructive Microsurgery and Lavazza. The Lavazza Fellowship, we have here with us the winner of the last year, and we are waiting for the winner of the next year. So in conclusion, orthoplastic surgery belongs more to the plastic world than to the orthopedic, but cooperation between the two specialties is essential. The next step would be to have a specific educational program and guidelines to standardize as much as possible the procedure. And don't forget that it is a very creative surgery, and it is something which is very appealing for young generation, I think. Thank you very much. This is our library in Rizzoli.
So thank you, Professor Innocenti, for that presentation. You'll take your seat, and at the end of the session, we'll have a Q&A. Next up is his colleague from the same university, I believe, Maury Francesco, who will be speaking to us on establishing an orthoplastic collaboration. You're welcome.
Thank you. I want to thank Professor Angole to invite me. Thank you. And Sarah, that is coming, I think. I'm talking now about an algorithm, our experience in lower limb reconstruction, from the more simple to the more complex. Oh, sorry. As you know, lower limb reconstruction is one of the most challenging. The etiology can be trauma, cancer excision, diabetic, infection, and it involves multiple structures like skin, bone, muscle, tendon, vessel, nerves frequently. And the goal is to restore ambulation, long-term coverage of vital structure and prosthesis, and satisfactory appearance. One of the fathers of orthoplastic was Godina, when in 1980 published his famous theory on fix and flap, that it's that's actually today. Fix means bone fixation, flap means soft tissue reconstruction, with the idea of Godina must be done in less than 72 hours, which is correct. Nowadays we can extend the time until 5 days, 1 week, but the time is important in reconstruction. And you know, as all you know the advantage, lower rate of infection, failure of the flap, shorter time to bone healing, and shorter time to hospitalization. So in our experience, when there is lower limb soft tissue involvement, only soft tissue, when it's superficial, it doesn't require a lot of surgery. You can manage with negative pressure or with skin graft or Integra, whatever you prefer. This is a case, a very young patient with a calcaneus ulcer following plaster removal. That was easily treated with a negative pressure. This is the result after 3 weeks, more or less. But when it's a full thickness defect with exposure of the prosthesis, the fixation device or the vital structure, this can be different. And I divide in the different anatomical structure in case of the leg. When we have a small defect in the proximal part, our first choice is the medial or lateral gastrocnemius. As you know, it's quite an easy flap. It's a muscular flap. You can detach distally and rotate proximally. And this is one case with a patient with an infected prosthesis with a medial gastro. This is the result after the end of the surgery, after 1 month, more or less. In the case of a small defect at the level of the middle third of the tibia, our first choice is the soleus flap, which is similar in some way to the gastrocnemium. It's a muscle flap with the main pedicle that arrives from the popliteal artery. This is one clinical case. This is a military soldier with a blast injury from Ukraine, with an exposure factor of the tibia, the middle third, that we treated easily with a soleus. You elevate like the gastro, but in a deeper position. You detach from the gastrocnemius, you detach from the Achilles tendon, and you can easily rotate to cover the defect. In the distal part of the leg, there is less tissue, and it's easy to expose the tendon. And our preferred choice, the propeller flap in this case, and an alternative, the sural flap. All you know, the propeller flap with the perforator, which is the pivot point of the flap. You elevate, and you can rotate up to 180 degrees. It's really, it's a powerful procedure in the lower third of the leg. This is the movement of the propeller up to 180 degrees. This is a clinical case, an exposure of the fibula, a fracture, an exposure fracture of the distal fibula that was easily covered with a propeller on the peroneal artery. An alternative of the propeller was the sural flap, which is a fasciocutaneous flap based in a comitant artery of the nerve, of the sural nerve. This is the flap and the result to cover the defect in a very old patient at the level of the Achilles tendon. When the defect at the level of the leg is bigger, our first choice is a free flap, most frequently ALT, but also AL latissimus dorsi, ALD. A clinical case, a patient with an old fracture, maybe 30 years ago, treated with a plate and screw, that healed. He stayed well for 30 years, but then developed a superficial squamous cell carcinoma of the leg, and they didn't want to treat with excision, but they preferred to do radiotherapy, and this is the result after radiotherapy with the exposure of the plate. So we decided to remove all the dystrophic skin suspected for squamous cell carcinoma, and we remove the plate and we reconstruct the soft tissue with an ALT. ALT is one of my preferred flap. It's on the lateral aspect of the tite based on the perforator. It's very useful. And this is the result after 1 week, 2 weeks after surgery, or maybe it's more, I don't remember. So we have talked about the leg. Now I want to talk about the knee. When you have a small to medium defect at the level of the knee, you have to think about the patella. And you can divide the defect in the patella and below, or patella and above. When it's at the level at the patella and below, our first choice, the gastropropeller flap. I'll show Professor Innocenti previous. This is a combination of a muscle flap with a propeller flap. That it's based on the same artery. This is the sural artery, which gives a perforator that perfuses the skin. This is the muscle and the skin, which are completely detached, one from the other, so you can move freely up to 180 degrees. This technique was published in 2010. And the advantage is that you can cover with the muscle the proximal part of the tibia, and with the propeller you can cover the distal part of the femur, so you can cover a bigger defect. With only one perforator, you can harvest all the skin above the gastrocnemius muscle. This is the clinical case of high energy trauma. It's the same case that we presented before. This is the importance is that with the gastro and the skin, you can cover a much bigger defect. And you can move independently the one from the other. This is at the end of the surgery, before exchange of the cement with the prosthesis, and this is the result. But when there is small to medium-sized defect at the level of the knee, but the patella and above, quindi more near the thigh, our first choice is the propeller flap. Our first choice is the profunda femoral artery distal perforator flap, which is the perforator from the profunda femoris artery. You can raise the flap and you can rotate to cover the defect at the level of the knee. And this is the result at 1 or 2 months post-op. We have talked about a small defect, but sometimes you have to deal with a big defect at the level of the knee, and the only things that you can use is a free flap. I want to show one case, a complicated case, an oncological resection for synovial sarcoma at the level of the knee. The knee was reconstructed with a megaprosthesis. As you can see, the oncologic surgeon removed the tumor. The knee was reconstructed with a resection prosthesia, megaprosthesis, and the extensor apparatus was reconstructed with an allograft. This is the prosthesis with the allograft for the tendon. And the soft tissue were reconstructed with the LT flap. And this is the result at months post-surgery. So, at the level of the thigh, usually, if there is no exposure of the femoral neurovascular bundle, it don't need a big reconstruction usually. Because there is a redundant skin, you can close primarily, you have enough muscle, you can skin graft. But when there is the exposure of the neurovascular bundle, it's different. And you can use a lot of different flap. You can use a pedicle LT, a round flap, a gracilis flap, or TFL, or you can use a free flap. Like in this case, this is an oncological resection in a young male patient with a grade myxoid librosarcoma. So the surgical treatment was the resection of the sarcoma, the soft tissue reconstruction with an ALT, and then we planned an LVA to reconstruct the lymphatic system. As you can see, the tumor go inside, infiltrate all the sartorius muscle, so the oncological surgeon must remove the sartorius. If you remove the sartorius, you expose the neurovascular bundle. This is the tumor inside the muscle. But also, as you know, all the main lymphatic vessels go through the medial aspect of the thigh to the inguinal lymph nodes. So if you manage to remove this part of the skin, you will have for sure lymphedema. So we, preoperatively, we made an ICG, that is lymphoscintigraphy. You put the green endochania at the level of the foot, and then you wait or you push until you see where it's go at the level of the lymph nodes. Here you can see I'm marking the direction, the position of the lymphatic vessel. As you can see, all the lymphatic vessels go inside the tumor and the position of the resection. This is the tumor. It's not easily see. No. But at the end, this is the marking, and you can see the lymphatic vessel go over the tumor. It's not inside, it's in the skin over the tumor. So where you remove a tumor, you will have for sure lymphedema. This is the resection with the exposure of the neurovascular bundle. It was a big resection for a big tumor, 24, 25 centimeters or maybe more. But also you have the exposure of the you sever the lymphatic vessel, as you can see in the image. This one, it's not, sorry for the picture, it's not a vein, but there is a lymphatic vessel with patent blue inside. We inject also patent blue. And we clip it during the resection to avoid the lymphocele. These are the lymphatic vessels. So we plan a free LT flap from the contralateral tight. This is the harvesting of the flap and the flap inside. And we planned, we made an LVA, a robotic LVA. For LVA, we frequently use, almost always use this robotic platform, the Simani. You can see he has a robotic chart where there is the hardware. But he has also the nano instrument, which is the tip of the robot, and the chair, which is the control where you can sit and you can control the robot and move the instrument. The most important things, it's the scaling. If you move, as you see in this video, if you move your hand 10 centimeters, the tip of the robot move only 1 centimeter. So if you move 1 centimeter your tip, the tip of the robot, your hand, the tip of the robots move only 1 millimeter. With this robot, it's really more easily to perform the LVA. You can see on the right there is the lymphatic vessel, on the left there is the vein, the recipient vein, and the robot's really precise. It's a little bit slower than the hand, but more precise. This is the LVA at the end of the procedure. And here you can see the endocyanin green that flow from the lymphatic vessel to the vein. And this is the result at 3 weeks post-op. And after 9 weeks, the flap healed completely. At 2 months, there is no signs of lymphedema. It's a little bit early. We'll see after radiotherapy how it's going, but until now it's going well. So more complicated case is when you have soft tissue and bone, when you have to deal with both. In the case of small bone defect, less than 5 to 8 centimeters, our first choice is to reconstruct the soft tissue with local or free flap, and bone reconstruction with bone transport. That is more an orthopedic procedure. Like in this case, is a young man with a military accident during an exercise with a supracondylar fracture of the femur, open multifragmental fracture of the distal third of the tibia, and skin necrosis at the level of the patella tendon. So there is soft defect, loss of soft tissue and bone. It was temporarily treated in emergency department in another hospital. This is how it looks, the distal third of the tibia. So we have planned 2 surgeries. The first surgery, the orthopedic colleagues treat the femur fracture with a standard, with a plate. And after 1 week, 10 days, I don't remember, we treat the lower limb. We treat the leg. We debride all the necrotic tissue and bone. And this is the result after the debridement. And we decided to reconstruct the soft tissue with a free LT flap. We also made a medial gastro to cover the defect at the level of the patella. At the same time, the orthopedic surgeon removed the necrotic bone and put an external fixator, a circular external fixator, and prepared for bone transport. This is immediately at the end of the operation, and this is after 8 months. So you can see here, there is all the regenerate bones that come from upside and go down to reconstruct the defect at the level of the distal third of the tibia. Then the last case, when you have big soft tissue defect, but also big bone defects, longer than 5 to 8 centimeters. In this case, we usually do in 2 surgeries. At the first surgery, we reconstruct the soft tissue and we put a cement spacer. And after 3-6 months, we reconstruct the bone defect with a fibula. a clinical case, a young patient that arrived from a different hospital with an external fixator and a failed latissimus dorsi, a bad bone alignment, so it's almost a disaster. And they escape from the other hospital because they want to amputate the leg. He doesn't want, and he arrived to us. Our first surgery was to remove the necrotic flap, remove all the necrotic bone, so these two big fragments, to put a cement spacer, a new external fixator, and reconstruct the soft tissue with a latissimus. And this is the result after 1 month of the surgery. In the second surgery, at 6 months, due to an infection from Candida that required more time, we made a second free flap. We removed the cement spacer and we put a fibula, and we reconstruct with the fibula. In this case, it's complicated because you have only 2 main vessels at the level of the leg. When you just use one for the first free flap, with the second one, you have to do all interminolateral, which is not easy in the posterior tibia because it's quite deep. And this is the result at 6 months. You can see that the fibula is completely integrated in the bone. And at 1 year, it starts to petrify. And this is the aesthetical and functional result. He can walk easily without any problem. So, thanks for the time. Thank you.
So we'll take questions for Emma at the end. Next should be Ruben Kamundi, who will be talking to us on free fibula graft for a case report following a snake bite injury. Welcome.
Good afternoon. Sorry about that. Yeah, I'm happy to be here today. We'll be talking about reconstruction of a segmental tibial defect using a vascularized fibular bone graft in an 8-year-old child. Now, here in Africa, we have a big problem of snakes, not everywhere, but in the drier areas of our country. And this young man happened to have come from one of those areas with the most poisonous snakes. And he sustained a snake bite to his leg, as we'll go forward to see. Sorry. So it's a case report we managed to recently publish in our journal, the Pan-African Journal of Plastic, Reconstructive and Aesthetic Surgery. Our lead surgeon was Professor Nangole, together with the Professor Biakika, orthopedic surgeon. This was a case of orthoplastic, as we've just been highlighted to in the previous presentations. Thank you very much. So we had to come together and work together to try and see how to save this young man's limb. So this was an 8-year-old boy presented in October 2024, which was last year, with a 5-month history after snake bite. So he came with a foul-smelling proximal leg wound, a protruding necrotic tibial bone, okay, with knee deformity. Of course, he was in fair condition, but the right limb was non-functional, and X-ray images showed a pathological fracture, sequestrum, and chronic osteomyelitis. So this is the image. Okay. You can see the protruding tibial bone, okay, with the x-rays and a lot of sequestrum. So he had femur necrosis, tibial necrosis, with right knee contracture and osteomyelitis. We were able to take a culture and we were able to grow staphylococcus, as usually is the case, and then we went straight ahead to management. And of course, with such a wound, the first step will be surgical debridement, surgical toilet, sequestrectomy. You want to remove as much of the dead tissue, necrotic tissue as possible. Went ahead to do vacuum dressing, negative pressure wound therapy, and a knee spanning exofix to stabilize the knee. And we suffered a complication along the way. He sustained a fracture, which we went ahead to manage. So the goal was to control the infection. A series of concoction of antibiotics, surgical debridement. Eventually, we were able to bring down the inflammation markers, and the infection was well controlled. We went ahead to cover the wound using a flap, gastrocnemius rotational muscle flap, and a skin graft, and then he was able to recover. However, we had a very huge bone defect. And after much consultation, bearing in mind we're in a resource-constrained environment, we decided to go ahead and do what we call a tibialization of the fibula, using a vascularized fibula flap to bridge that bone gap. We had a very huge bone gap, as I'll be able to show in the next slide. So basically what we did, we just raised the fibula bone and telescoped it into the tibia to bridge that gap. And as you can see in the images here, allow me to go back just a minute. So you can see this dead tissue of bone. So once you remove that, there's a very huge gap. And then fast forward to this image here, you can see the gap, okay? Yeah, so that's basically what we did for the individual. And these are images showing the harvesting of the fibula flap. It was a pedicle flap. And you can see the bone attached to its pedicle, then telescoped, and we were able to secure it with plates and screws. So we harvested the diaphysis, basically, of the fibula, preserving the proximal and the distal fibula so as to support the joints, both the knee joint and the ankle joint. This is a video of the procedure. You can see us doing the dissection. Okay. Yeah, and this is the post, the result after. So you can see the fibula is slowly integrating into the tibia. Okay. So what are some of the learning points from this case? Good graft incorporation, restoration of structural stability and limb salvage, functional recovery, of course, with ongoing physiotherapy. This we have to work hand in hand with our colleagues in physiotherapy to achieve good results. Surgery is just, say, 50%. The rest of the work really is physiotherapy. Tibialization is an effective biological reconstruction for large tibial defects, and works better in children because, you know, children have much stronger regenerative capacity. Provides practical, resource-sensitive solution in low-resource settings. Segmental tibial bone loss remains one of the most difficult orthopedic problems, especially in children. And this is mainly due to trauma, infections, as we all know. And in this case, we had snake bite-induced necrosis. The objectives when faced with such a challenge is to eradicate infection, restore bone continuity, and regain limb function. And success usually depends on the defect size, anatomical site, and soft tissue condition. And as we all know that infection is a huge challenge, okay? And also being in a resource-constrained environment also, so some of this, let me say that the number of surgeons who can do this at the moment are very few compared to the population that we have. And that is why we need to train more surgeons, train more microsurgeons, so that we're able to reach more and more people in our society. Briefly look at other conventional reconstructive options. We have the bone transport, the Elizarov method, the allografts, and destructive osteogenesis, musculate technique, which are options. And then I think I'll skip this. Basically what this means that the technique we chose comes with living osteocytes, okay, that are more resilient and resistant to infection, and it heals by primary osteogenesis as opposed to the creeping substitution. And okay, it's just a summary of the presentation, and it's a practical, basically tibialization of the fibula is a practical solution in a resource-limited setting. Then lastly, this is the best slide of my presentation. Being able to restore a smile to our patients. That's the patient and the dad. And I think this is the moment we all live for. Seeing how your surgery has changed someone's life. And that's basically why I got into plastic surgery, to be able to put a smile. And I'm sure that's why you all got into the field, to be able to change the lives of our patients. Thank you so much.
Thank you, Ruben. The man who transported the first leg foot that was ever implanted in Kenya when he was an intern. So our next presentation is from Dr. Dan Odhiambo from Aga Khan University, who will be presenting to us on, is it this one or the other one? It's this one. Okay, on lower extremity free flap reconstruction case series.
Thank you, Dr. Obire. Humbled to actually be presenting after our guest speakers. Thank you, Prof. Innocenti, Dr. Marco, for honoring our invite and gracing our occasion. Thank you, Ruben, for the preamble. My name is Dr. Dan. Today I'll be presenting on lower extremity using the free flaps. I think this is a field that is growing, and some of us are actually quite interested in the field. So disclaimer, I'm not an expert in the field. I just happen to be an able assistant. I work closely with Dr. Esther in Aga Khan University Hospital. Part of my talk really today is to inspire the next generation of East Africa microsurgeons, including myself. So outline of my presentation pretty much is to look at what do we know about this topic. I think much of the flap types and anatomy has been covered by the previous speakers. Some of the planning considerations, some technical pearls therein, some case series to elucidate on the same, and a take-home message, really. So some of the questions I was asking myself looking into this topic is, what do we know about the incidence of lower limb trauma in our setting? Do we actually have the numbers when you compare public versus private? What is the satisfaction rates of these patients that we actually perform reconstruction? Do we know the functional outcome, mobility, and how to overcome the barriers? So why this area? I think Prof. Innocenti has actually told us why. That compared to other forms of reconstruction, breast surgery, traumatic lower extremity salvage really presents the reconstructive surgeon with a slightly different environment, and it can be viewed as a true providing ground for microsurgical techniques. And this one I quote one of the authors who said that. So when we look at the history of lower limb reconstruction, I think historically the progress in this particular area is driven much by conflict, starting all the way from 300 years ago maybe, when we started seeing maybe the Prussian Wars, the Vietnam Wars, and even what is happening between Ukraine. So really you can actually see historically that conflict really has progressed this field. And we know that indeed there are multiple factors which would lend the decision on whether to amputate or to perform limb salvage. So I looked at a few papers really looking at the epidemiology, including, I think there's a study done by Ken, maybe it just hasn't published, on the knowledge of orthoplastic among practitioners. And what we see really is you'd see a maybe younger populace male, and this could be driven by the motorization such that we are seeing even in our developing setup. But I think also this one, we are also seeing also the age shift slightly up. Previously, you can see a predominance in the second decade, but now we are seeing even more in the fourth decade and even affecting women. Yeah, so as reconstructive surgeons, again, what we know in the literature, we rely pretty much on principles set forth by Gastillo, Anderson, and Marco Godina. This is tracing back in the early 80s, where they actually proposed that it's better to do early reconstruction than delayed reconstruction. And the benefit really is infection control, better healing, reduced length of stay, and cost. But in our setup, we pretty much know that this is not possible. There are a couple of challenges which pretty much hinder us from actually having that pathway from referral to antibiotics, debridement, skeletal fixation, and soft tissue cover, as we shall see as we move forward. So what are we seeing in our setup? Indeed, there are challenges. This is the decision whether to salvage or amputate. And this decision is also influenced by the patient, because not only the surgeon driven, the patient also has a say as to what they want for themselves. Again, we see a lot of delay. This delay could be one in terms of the healthcare seeking behavior. It could be transport to the facilities which offer this particular service. And again, it could be finding the specialized caregivers who can actually provide this service. A collaboration between orthopedics, plastics, the therapists, the wound care nurses, all that. Do you have protocols that are standardized and that can sensitize patients and caregivers on the same? Maybe not. Again, we know that for us to perform these procedures, there's cost to it. So again, cost is a major hindering factor when it comes to this particular area. Like I mentioned, managing patient expectation and psychology. And again, yeah. So there's advantages to limb salvage, but in certain scenarios, again, amputation is treatment by itself. So much as we are proponents of limb salvage, in certain scenarios, amputation could actually be the treatment that patients could be afforded. So advantages could be you avoid major amputation, preservation of the native limb, so hence you end up fulfilling the patient wishes. You have adequate soft tissue reconstruction, you prevent systemic complications, and again, the psychosocial and social outlook of the patient. Just to recap from the morning talk, again, you can see that where the skill is not available, you still have options that you can play around it. From muscle flaps, gastrocnemius is still a good flap to use, combined with the skin grafts for proximal defects. Then you can have the peroneus brevis flap, muscle flap, still a good flap when it comes to the distal leg, of course with the skin graft. You can have your fasciocutaneous, such as the medial-sural artery perforator flap, for very small defects, especially in the proximal area, with very good donor mobility, because you'll just have to graft the donor. You can have the reverse sural, which again, many general plastic surgeons would be able to perform these flaps with ease. But, sorry, why free flaps? I think I'll allude to what one of the presenters said, that some answers can be simple and wrong, but some can be complex and right. So again, it's a decision making would also come here when it comes to what to do in terms of site of injury, vascular status of the limb, and again, the timing. Timing is key. You don't want to do early reconstruction, but in most scenarios, you'd end up doing a subacute to a chronic reconstruction, especially in this part of the world. So free flaps, again, can be divided as either muscle flaps and skin flaps. Muscles are better to plug holes because of the abundant vascular supply and increased blood flow that they have. The ones that we commonly use include the latissimus dorsi and the gracilis. Skin flaps, again, are good, especially the ALT flap, but and also the radioform flap. So I just put images here just to remind us of this elegant flap described by Tansini in the 80s, first used for breast reconstruction. Again, you can see its blood supply, which comes from the third part of the axillary artery, which gives branches to the circumflexus scapula, the serratus branch, and the thoracodorsal, which supplies the LD. So it's a type 5 in Mathis and Nahai with a single dominant pedicle. And you have a retrograde supply coming from the serratus branch. So why I put this slide here is important to just remember this is an anterior approach of harvesting the muscle. So while harvesting the muscle, it's important to take care of the insertion of the serratus muscle, and then again to preserve the serratus branch, because you may use it when it comes to when you're doing your anastomosis in terms of the venous, if you're doing two veins, because remember I said it's a single dominant pedicle. So unlike the other flaps where you'd actually have a vena comitante, this one you don't have a vena comitante. So that's why I put that slide there. The next flap is the gracilis. Again, this again was described by Pickrell in the 50s for pelvic reconstruction, but it has gained popularity in different realms, facial reconstruction, etc., including even sphincteric reconstruction, actually. What is important to remember about this flap is that you can have minor pedicles which you do sacrifice, but again, you can have variations, as I'll show you in the case series. The ALT, again, a good flap described by Song, but again, no one LT is the same. The radioform flap or the Chinese flap, again, a very good flap. What I've come to appreciate about this flap is actually it's like a shunt. So you have a big artery coming in and a big vein going out. So it's quite an interesting flap, actually. So preoperative considerations, again, when it comes to reconstruction, is examination of the limb above and below, the vascular status of the limb. We tend to see a lot of Gastilo 3B, 3C. So definitely, much as you've done your trauma series, your CT angio is the one which will guide you in terms of the vascular status. But interesting to note, or maybe a question to the audience, really, can your CT angio predict whether your patient has peripheral arterial disease or not? Then again, the reconstruction priority, remember form and function. And when it comes to the lower limb, your function is weight bearing and rehabilitation. And the principles of the reconstructive ladder still apply. Why I put this image, again, just to remind us of the anatomy of the leg. Remember, it's like a cylinder. The position of where you find because it's a hub of vessels. So you have the anterior tibial artery with its vein, which is usually found next to the tibialis anterior and extensor hallucis tendon. You can have the posterior tibial, which is usually 1 centimeter posterior to the medial malleolus, again, which gives abundance of perforators. And you can have your peroneus, or your peroneal vessels, which technically you'd have to remove the fibula to access it. But remember, apart from the mother vessels, you still have the perforators, which you can still use for anastomosis. And the accompanying venous drainage, both the superficial and the deep system. So when it comes to considerations, really, the wound requirements really guide us when it comes to what do you want or which flap we choose for that particular wound. Where is it located? Is it centrally? Is it eccentric? Remember, Ackland described in the 90s, getting out of the zone of injury. So it describes going more proximal, getting good quality vessels. But also there's been a lot of work that has been published on doing anastomosis either at the site or even distal to the injury with different outcomes. Anastomosis again, whether to do end-to-end, end-to-side, again this one in the literature is purely surgeon dependent. Whether to use vein grafts, I think the morbidity there is the associated thrombus risk. And then whether to do one vein versus two veins, with proponents, I mean, two veins is always better because you have a backup. But again, remember your increased OR time. And then whether to do loop anastomosis or surgical microscope anastomosis. Postoperatively, I think what is most important is keeping the patients filled and warm, so well hydrated and warm. Anticoagulation, I think here we use just low molecular heparin, but some people combine dual, including use of aspirin, but studies have also shown no advantage in the same. And then the different rehabilitation protocols, when to start stressing the flap against gravity. And those protocols do vary. But I think what we know is in most centers it tends to coincide really with wound healing, which starts at around day 5, where you have angiogenesis and all that. So you can actually, most people start flap training from day 5. I think, yeah. So just to, because of time, just to show you a couple of series. So this is a soldier or police officer who had been handled in multiple occasions by the orthopedic colleagues. Multiple flaps had been attempted, and now had presented with chronic osteomyelitis with a defect in the distal leg. The flap choice there was the gracilis. In this particular case, the lesson here was because of the frequent surgeries that had happened, there was a lot of fibrosis encasing the vessels. So much as one would go more proximal, still getting a good quality vessels was still not that easy. So then again, it tells you that you can use still the perforators that are coming in that area. And here was a staged procedure where grafting of the flap was done later. So you can monitor your muscle free flaps and graft them at a later stage or same sitting. This was also another lady who presented with bilateral fractures of the midfoot and a dislocation of the ankle on the left side with the joint exposed. Again, a free gracilis was done with grafting in the same sitting, and that's how the flap is almost 4 months post-procedure. You can see actually what you're talking about when it comes to working closely with the orthopedic colleagues. So this is an example of very severe injury. This was also a soldier with a blast defect in the midfoot. So you can see actually it's an uncontained defect. So, but the fragments have been held in place with the K-wire. So again, reconstruction was done using free latissimus dorsi. Bone cement was placed at the same sitting, and the muscle grafted, and that's how it looks more than 2 months post-procedure. This is also another case example where this is also a middle-aged lady who had this compound nervi of the big toe with a high-risk potential, high-risk malignant transformation potential, reconstruction with a radioforearm free flap. The challenge here is this lady actually had peripheral arterial issues, so we lost the flap. But the good thing is, post-free flap, there's usually granulation tissue on the recipient area, which you can actually do a skin graft. This particular case, the interesting thing about this particular case, it took us to a different territory, because we started off by, it was a patient who had a defect on the lateral side and the medial side, exposed implant on the lateral side, and on the medial side you can actually see that there is also exposed joint and tendons. So this procedure started off with us raising the free gracilis But we found that actually the pedicle, the medial circumflexus femoral artery that supplies the gracilis was not present. So the procedure ended up with us having to raise a partial thickness adductor magnus flap. But the pedicle for the adductor magnus is quite small, 4 to 5 centimeters. Grafting of the in the same sitting. But unfortunately, again, because it's difficult to really predict whether a patient has arterial disease or not, we lost that flap, but subsequent reconstruction with the AAT flap was done. Again, this photo again, the reason I put okay, I'm actually just there. This is just to remind us that you can still have other recipient vessels apart from the traditional anterior tibial. So this was a latissimus reconstruction of the knee, but it reminds me that in the knee you still have the genicular vessels, which are actually very good recipient vessels. And I think we also did another case where we used a parascapular flap for knee defects. So I think that's why I put that image there. This was just parascapular used for a lower limb reconstruction. And this was a patient who had a degloving of the foot. So a very huge and thick ALT was used to reconstruct that defect. Currently the patient is ambulant. I was unable to get the postoperative image, but the patient is actually mobilizing on the foot and is due for debulking procedure. I think that is all. Thank you for your time and attention.
So we can have a Q&A. Dr. Kimtai. So we'll collect questions we shall have a round of questions and then responses.
Thank you very much, all the presentations. I think they were very, very good. Maybe my first comment is not a question, a comment is that, yeah, even locally, some time back it was very difficult for us to work with the orthopedic team, but slowly they're accepting that we have a role to work together. Because initially all the patients will come with compound fractures, the orthopedic will do it all along, and only they call us when it's too late, infection and everything. But I think the awareness is increasing, and now the role of orthoplastic is also taking root in this country, which is a good thing. My question, maybe two questions to Innocent. One is, in those defects that you've got extensive, Francesca and Innocent, in those very extensive defects that you've got extensive bone and soft tissue loss, and you've got only one vessel. I think you talked about one case that you did 2 flaps, and the first one you used the vessel. So do you have a role for flow-through flaps that you can use 2 flaps, one to use for soft tissue and the other one to use for bone reconstruction? And if that is the case, would you do them at the same time, or would you do one first and then still come back again and still use the other flap as they flow through? Then the second question is, do you have any experience with a cellular dermal matrix or any of the skin substitutes for management of some of these extensive exposed bone? Because I know that in literature, in some centers they will use a matrix and then they put a vac on it for some time, and they say that that will stimulate granulation, and if you get good granulation, then instead of doing a flap, you could just come and do a skin graft.
Yes. Okay, I have them noted down, so. Okay.
So, Professor Nangolet, two interesting questions. The first one is related to a single vessel limb. Okay, there are only two options: end to side and flow throw. Flow throw is very elegant. I like it. The problem of the flow throw is that you have a problem. You don't you don't lose only the flap. You lose also the leg. So, because in an end to side you might have a problem, but almost never affect the main vessel. So you lose the flap, but the damage is less. I think the only limit of the flow throw is this. And not all the flaps are good. The pedicle, not all the flaps are a good pedicle distal, or even the LT flap, which is maybe the best option for flow throw. Distally, sometimes the vessel is small, is not maybe the best, maybe not matching the recipient vessel. So, but it's a very good option. I agree with you. And the second was about the matrix. I think it makes a lot of sense. We are microsurgeons, but we very often use alternative methods. When there is the indication, so it's only the problem of indication, of a balance, cost-benefit, the type of patient, the need of the patient, the age, the location of the defect. So there are many variables that you should consider. And even if you are a superstar in microsurgery, you must not discard easy solution. So I don't agree with the pure skin free flap. No, now it's very fashionable in the Far East. So just derma and skin. So come on, you do a skin graft is the same. I cannot say this in international meeting, but a lot of people think about that now because it's so thin. And if you have a good recipient area, what's the reason to do a dermal network flap? Come on. So this is my answer. And the second, who is the second? Oh, yes.
When you do a gastrocnemius propeller flap, so do you see for the skin perforator first, or you elevate the mycutaneous flap and then see for the perforator?
This is also an intelligent question. That means that you understood what I was showing. The best would be move the muscle and the skin together without elevating, because it's more easy to manage. Sometimes you have to pass below, I don't know, a skin bridge. So if the two components are tightly connected, it's easier to manage. But I always want to see the perforator. I don't trust 100% to the Doppler. So I want to see the perforator. Sometimes I find that another one, also because according to the location of the perforator, you design your skin island in a different way. So this is a second reason, unfortunately, to dissect the propeller flap before transferring, because you need some information, and so you know what I mean. If the perforator is very distal, sometimes you don't do very proximal. You don't do a propeller. You do a propeller, but not reverse flow. You do in the normal axis, no? So you must be the perforator, choose the perforator, and then you design the flap.
Oh, thanks. Great talks, everyone. So I just wanted to ask, like, how do you determine, when you're deciding what you're going to do as far as the micro goes, using the Samani for the robotic microscope, which I've used, It's very cool. I find it does take a little more time, and I don't know if I'm any better with it. I don't think I am. I think I can do micro with loops, or I could do micro with a microscope. And in Africa, sometimes they don't have access to a microscope, so you're stuck doing it with your loops. How do you, what are your feelings when you're deciding, am I going to use the microscope? Am I going to use the loops? Am I going to use the robot? Which cases do you decide to do it on, and how do you do that?
Yes, now we have in our armamentarium a wide range. I would add the esoscope, for example, and then we are working in a virtual reality vision. So this is, stand up so I see you. No, I stand up. So now the very interesting new thing we are working on is a 3D visor who are able not only to record in virtual reality, but also to do the surgery in virtual reality. So we look at our hands filtered by the vision system. No? So this field is expanding so much that is really exciting to be in. Maybe you know that I am the clinical advisor of MMI from the beginning, so I've been following the platform from the day one, when it was nothing, just a distal wrist, and then we developed all the rest. And I changed the idea of the indication of this machine as long as we were working on it. At the beginning I thought, okay, it can be good also for not very experienced microsurgeon, maybe just a general orthopedic surgeon who wants to do altissimus once upon a time. But this is not a good indication, no. Then we had to do many cases, as you might know, in Europe to have FDA approval. So we expanded very much the indication, and we have been using the Simani in 10 different universities, also for easy flaps, latissimus, something like that. This is not an indication, because you do a very accurate work. But with vessel 1.5, 2 millimeter, you can do very well by hand, and it is faster, and so on. So in my opinion, the real indication, and it is a big, huge indication, is lymphedema surgery, number one, and perforator to perforator. So if you shift the paradigm and you move routinely to perforator flap surgery, that makes the difference. Because believe to me, the case Francesco showed you is 0.3 millimeter. So not everybody is able to do anastomosis in such a small vessel. So I think that you should be wise in using things. You must be well balanced. And if you can use your loops safely, use your loops. It's easier, cheaper, faster. So I think that you have to have a good balance between fancy things and what is really useful. But again, robotic microsurgery will have a big future. I know that everybody of you knows about this new topic about Alzheimer, mental, brain disease, and the connection with the what they call lymphedema of the brain, which is not a real lymphedema, but maybe everybody knows about that. So if this is true, if this will be validated on the world scale, can you imagine the number of cases? Because you can really recover from Alzheimer. It's something from incredible, no? So in this case, Simani will be very useful because you can do routinely. You can do 3-4 cases every day. So I think we are living in an exciting time for technology. And let's see.
Yes, thank you, Prof. Thank you, Professor Innocenti. I have two questions for you. One, in your vast experience in orthoplastic specialty, are there maybe life lessons that you've learned with regards to the recipient vessels that you use in anastomosis? Are there some vessels that you learn to avoid despite them being in a favorable positions for the anastomosis? I know so many factors come into play with regards to the recipient vessels that you use, but I don't know whether there are any particular vessels you want to avoid because of really the lessons you've learned from them in terms of the outcomes of your free flaps in lower limb reconstruction.
So the question is that if it's better to avoid some vessel instead of others, or
which is your preferred blood vessel, or the other factors help?
I think any pulsating vessel is fine. But there are some general rules that I learned, not in the books, just in the experience with failure, basically with failure. So, for example, we have seen that high energy trauma, even if you have a good angio CT up to the injury, that is much better to go 10 centimeter more proximal. Because for some reason, you do maybe spasm, no, it happens often. You do a perfect anastomosis, and you are a spasm, it doesn't work. So this is a suggestion. In high energy trauma, go up. Don't trust a nice pulsating vessel close to the injury, because if you cut it and you wait, probably after 30 seconds it's going to and then close. So you must go up. The second topic where I can give you some suggestion could be atherosclerotic vessel, for example. No, they're not an absolute contraindication, because paradoxically, if you choose the right point to do the stitch, the atheroma is like a cage. You know, it's like a stent which keep the vessel open. So the important thing is to stay between the plates, between atheromas, because and then you can do the end to end. You can never do an end to side in an atherosclerotic vessel, because it's impossible. You cannot make the hole in the atheroma. Say that, I think that all the vessels are good. The bigger the better, of course. And I don't think there are other special rules. Of course, avoid vessel in infection, with the surrounding tissue is not good. This.
Thank you. Lastly, on do you have any particular preferred order of which you do your things routinely? All the other factors held constant. I know some microsurgeons prefer even inserting the flap before doing the anastomosis. Artery first, then do the vein once you unplug the clamps. Vein first, and then do the artery.
So just three concepts, very, very, very easy. In my experience, 99% we make the inset of the flap, and then we do an anastomosis, because at least a tentative fixation of the flap. Then maybe we refine the closure after the anastomosis. The second point that we do, and it's not written in the book and nobody talk about that, we don't like to do the washout of the pet. So when we cut the pedicle, we always have a clip. So it's a closed system. A clip in the artery, a clip in the vein. That means that there is no way to have thrombosis inside the flap, because the coagulation is activated by the injury of the intima. If you have clipped, there is no injury in the intima. So if you don't leave the vessel open, you don't need the washout, which in my opinion is not a good idea. And then what else? Was there another question?
Artery vein.
Sorry?
Artery vein, vein.
The artery vein. We do always the vein before, always. This is a personal choice because some surgeons like to do the artery before. Theoretically, our opinion is more right because, of course, if you have already established the drainage, when you have the arterial flush, you have already circuit open. If you do the artery before and you have the closed vein, you have some congestion inside the flap, and when you put the clamp in your vein, the vein is bleeding a lot. So I think there is no reason to do the artery before, and this is particularly important in replantation. We started with replantation, and in replantation we do always the vein before, but this is a matter of preference.
Yeah, thank you for the wonderful presentations. So this is a question to all the panelists on the stage. So when you're challenged with an exposed implant, orthopedic implant, for example, how do you make a decision whether to cover the implant or to remove it? Sometimes orthopedics don't want you to touch the implant. You have to cover the wound. So how do you make those decisions? Thank you.
So what I learned from the infectivologists that work close with us, they want, when it's exposed or a prosthesis, they want to remove it, 100%. You can leave, wash well when it's earlier than 30 days. If they put the implant 2 weeks before and then exposed, you can leave there, wash very, very well, and try to cover, but not 100% secure. It's different for the plate. The plate screw, you can leave there. You wash back, you clean there, but you can leave also after 3 months, 4 months. It's different, a prosthesis from a plate, what I learned from the infectivologist.
Yeah, I agree with you. Yeah, it's safer to remove the implant or the hardware. Then you debride as much as you can and try to put in a new implant. However, if that is not possible, then I also tend to agree with what he said.
Okay, looks like the other two panelists agree with the two who have responded. I hope, Nelson, you are happy with the answer. I know this is a very common problem in our setting, but probably discussing with the author person so that you reach a consensus that is works for both of you and the patient would probably be ideal. So thank you very much.
Excuse me.
Well, there's still. Oh, I thought Nelson was the last one. Okay.
Thank you. Thank you for the good presentations, all of you. I was particularly impressed, Professor Innocenti. Which prosthesis do you use and how do you choose the prosthesis after you've reconstructed the amputation stump?
It's a too difficult question. I cannot answer. Also because there is an evolving word about the prosthesis. This is really exciting because, now we have different way. The end will be the bionic limb, which is a completely different concept with the central control of each muscle. But also now, with the conventional prosthesis, we can do a lot. The thing is that now, maybe if I don't have an urgent case, somebody we can talk about and think about, we call the prosthesis company, and we say, okay, we have this patient. We had not done the amputation yet. So give us the best level according to your technology. So what you can do. And then we do what you need. So it's the opposite. So it's not the surgeon who cut and then send to the prosthesis, and they have to manage with what they have. I think this is quite new. And if you have a good cooperation between the prosthesis company and the surgeon, you might have really good result without going to the science fiction of a bionic hand, and it will be a reality in 3-4 years. Technically, it can be already done, but it's too expensive and so on.
What material is the prosthesis made of?
I'm not an expert in this. I think they use basically titanium as a good ratio between weight and resistance. And then there are all the new, for the, I don't know the name of the, in English, the part which goes, the plastic part. Now is Kevlar. They are very well, they are customized, so they can do with the 3D printing according to the shape of the patient. So things are really improving a lot. And even in the conventional prosthesis, without going to the bionic limb, already, for example, in Korea, my friends, they are working effectively in a leg prosthesis where the ankle can adapt also to the, to the inclination of the ground. So if you are walking this way, the conventional prosthesis stay in one position. This one can adapt, and the adaptation is with the muscle, so it's active. You can move your peroneal muscle, residual peroneal muscle, in order to activate a part of the hardware which can move accordingly. It's quite exciting, this field.
Thank you very much. I didn't see this in the earlier session, so I would want all the 4 presenters to have a group photo for that session. For purposes of that orthoplastic session, those who will be chairing tomorrow, you can follow suit. So so as they're having their photo, Vipingo, I hope you are in here. Kindly get your presentation ready. So we'll have a brief sponsor or industry presentation, and then after that we shall have, I think, a tea break, and I don't know if Olive is here or if it's Mukami to tell us where the cocktail will be. So thank you very much. So kindly, I hope people don't disappear. Let's listen to them. There will be 1 or 2 other announcements when they're done.
Good evening. Thank you so much. My name is Wycliffe Mairura from Vipingo Development. It's a pleasure to be here today and talk to you. But today, I just want to thank you for the good work that you're doing. while you're busy making our lives better as doctors, we also want to come and chip in and make your other side of life stress-free. The other side of life I'm talking about is investment in terms of real estate. And I'm here to just showcase what we have and what I've brought to you today, and how can we come in and help you in terms of reducing that headache. Today I just want to display very nice pictures for you to see, but not lecturing per se in terms of what I'm going to tell you. So I'm from Centum Real Estate. Centum is a subsidiary of Centum PLC. We are the developers of our flagship project was 2 Rivers Mall in Nairobi, and we are located in East Africa, that is Nairobi 2 Rivers, here in Vipingo, Kilifi County, as well as Entebbe in Palmarina. So that is about the developer. So I came across this rhetorical question asking, when should doctors begin to invest in real estate? I know that one is a very rhetorical question, but you don't need to answer me. The answer is, people say yesterday, or better if you didn't do yesterday, today is the best day. But don't worry about it. So I'm going to show you what we have today, and then I'm going to show you what we are trying to build here in Vipingo, mostly. So we are the leading developers in East Africa with a huge portfolio, over 10,000 units on our pipeline. We've issued a number of them, including, we've categorized all our assets from affordable housing, mid-market, as well as luxury market. That is in terms of residential unit. In terms of land investment, we have residential land, commercial land, as well as industrial land. So there's something for each and every person. So I'll start with Nairobi. I think that picture is very familiar. That is the picture I'm talking about. That is the 2 Rivers Mall, where we've created a social city where you can live, work, and also your families can also thrive. So that picture is very familiar. I just want to show you that picture and see the kind of community we are creating there. Now, this other section of 2 Rivers is where we are doing the residential homes, where we've done Riverbank apartment, that's the luxury side of it. We have done loft residences, and right now we are building Cascadia and Mzizi. So all these units, just to give you a recap, they range from 5.5 million all the way to 40 million, depending on what product you want. So those are the loft residences. We did them. Mostly, we've also targeted the diplomats, doctors, and also the UN workers. They really do well. And especially those people who want to invest for passive income. Also, this one works very, very well. That is Riverbank Apartments, and now that is Mzizi that we are building. So we are not just building houses, we are just building for you a generational wealth. And generational wealth we mean where your kids can have facilities where they can play. Your fitness comes in mind. We have gyms fitted in most of those residential units, as well as the pools to just cool you down. So that is about housing in Nairobi. So going down to recreational spaces, for those who have gone there, you've seen there's go-karting, there's Ferris wheel, there's Cinemax, there's eateries, all sorts of things in 2 Rivers. But what is supporting all that infrastructure is we have a solar plant that is supplementing our electricity. We have a power substation, and as well as water, where we are purifying water and also helping the community as well. So moving on from Nairobi, I think Nairobi, I've just mentioned it briefly. Here in Vipingo, Vipingo is just 30 minutes away from here. For those who are here for the first time, I want to invite you to Vipingo officially. Vipingo, we are trying also to create a model city, just like in Nairobi, but we've already started. And this model city has taken shape. We have done phase 1 of our projects, and right now we are doing phase 2 of our projects. So we have a bus tour, and I want to thank those who have come to our booth. The bus tour starts from tomorrow in the afternoon, and also the last day. So we'll be able to take you there, go and see what we have, get to see what we are planning to see, what we're planning to do, And for those who have not seen the technology that we purify ocean water into potable water, we also have it the other side. We call it the water desalination plant. That was our first flagship project we did before building the residential part of it. So that is an estate called Awali Estate. We've invested so heavily on the greenery, whereby 30% of our development is green and 70% is what we build on. So these are standalone villas, very suitable for holiday homes, as well as retirement homes. When you come here for holidays, you have your home there. When you're away, you can just rent it out for Airbnbs and rentals, which I'm going to show you how it works. That is the entry to Awali Estate, and now we are selling phase 2. For those who don't want standalone building, don't worry, I got you covered. We have apartments. These apartments are called Palm Ridge or Mzizi at Vipingo, ranging from as low as 2.45 million all the way to 8.9. So they fall in affordable market category. So you can be able to have your 1 bedroom, you can be able to have your 2 bedroom, a very nice environment where you can come and during holidays with your family, as well as you can set it up for passive income. So these are not just apartments. We've created a very good environment there. There's a pool, there's a mini market, there's a place where kids can play, very humble parking, as well as security is beefed up in that area. You can see how green and beautiful it looks. So those are the villas in a close range, 3-bedroom bungalows and maisonettes. That's what we've done in Vipingo. That's the interiors of the villas. That's still the interior. That's where we have the dining. Those are the bedrooms. And this is now the outside the apartments now. There is a mini mart and also a pool as well. That's where the kids can play, and that's the interiors of the apartments. So moving on to the infrastructure I was talking about, that is the seawater desalination plant. The seawater desalination plant, we are using this technology. We adopted it from Israel and Dubai to just curb the problem of water. Many people can tell you, when you come to the coastal region, if you cannot address the problem of water, then you're going to lose clients. So we got you covered. We produce 3 million liters of water every day, and our consumption is around 700,000 only. So we are in surplus, and then the rest we help to the community. So you can see we are next to the ocean, and that is what we do to support our community as well. So Vipingo is known for several things. One of them is we have Vipingo Airstrip, just right outside Awali Estate. So 55 minutes only you're in Vipingo. So you take FlyLS, Safari Link from Wilson all the way to Vipingo. So we have daily flights as well. When you use SGR, we are 1 hour, 55 minutes from the SGR when you use SGR. Vipingo is also known for the golf course. We have the largest PGA 18-hole golf course in Vipingo. And for those who have heard about it, this is where tournaments take place, and we welcome you. So it's a perfect holiday destination as well. That's just a recap of what Vipingo is all about. We have, from the apartment, we have what we call residential plots. Residential plots, we sell for you a piece of land which is fully serviced. Fully serviced, I mean that every plot has connection of electricity to its individual plots, connection of the water desalinated plant, that's potable water, sewer reticulation, and cabro roads. They're already done to your plot. So once you come there, you just come and build. And in between the plots, we've built green spaces. So the green spaces is what you see there at the middle between the two houses. The green spaces, we set aside a piece of land where we just plant trees and flowers, not just plot following each other. So that is what we are creating in Vipingo. In Kingswood, you are able to build out of the 4 designs that we give you, but you can custom make it to your own specifications. Those are the 4 typologies I'm talking about. And then from Vipingo now, I'll just give you a highlight of what we've done in Uganda. So I know this organization cuts across East Africa. So for those also interested in Uganda, we have the beautiful Entebbe in Uganda. And this what we've done is along the shores of Lake Victoria. We've done also the same villas, just like the ones that we've done in Vipingo. So in Uganda, you can also get a very good investment opportunity there to come and also invest there. So Uganda, we also have apartments, plots, as well as bungalows and mansionettes. Yeah, so Men may wonder now, I've talked about what we have, how can you invest? There are so many payment options. Our selling process is very easy. You come and view, you identify, our deposit is 10%, and then the rest of the payment plan you can pay within 1 year, interest-free. Suppose you cannot be able to pay within 1 year, we have financing options available. We've partnered up with most of the SACCOs, we've partnered up with most of the banks. You can be able to be financed for the rest of the payment. Then when it comes to the apartments, the ones which are off plan, you pay across the construction phase, but the ones which are complete, you pay just like the plots, 12 months. So the mortgage plan is still there, what I've talked about. We'll connect you to that. And then the last part I want to talk about is property management. Very, very important. I received so many questions. I know some doctors are interested to invest, but they're telling you I'm a very busy person. So I don't want someone calling you, you are in the middle of a procedure, mtu anakuambia tenant ametoroka. You know, it's very, very, I don't know whether you can receive that call with a positive attitude or no, but that's what we are coming now to bridge that gap. That while you're busy making our world better, you're busy with your medical stuff, no one should disturb you. Everything should be in place. So we do property management. So our property management starts from tenant sourcing. We do for you the tenant sourcing. We do for you tenants paperwork and onboarding. And then we do the rent collection for you. And then also we do tenancy discharge. So that is what we do. We do all across, so that for you, what you do is just to receive the money, and also there's a percentage usually deducted around 10% for maintenance. Let's say, for example, you're running the Airbnb, 10% is deducted for maybe the agency and also for cleaning services and maintenance. So that's the only thing. Then the rest of the money is given to you. Yeah, basically that's it. I was just showing you what we have. You can take my number. My number is there, 0769 718891. My name is Wycliffe. Can repeat, the number is on the screen. 0769718891. You can scan the QR code, the bigger one. Still my contact will come there, but that is my contact. My email is there as well. So personally, I'm based here in Vipingo. So I'm looking forward to have this site tour with you. Come and see the kind of model city we are creating in Vipingo. I'll be more than happy to answer your questions, as well as share your feedback as well, so they can make us better. I was there during the opening ceremony, and I think the president said that don't just come for the conference, walk around to see what the town has to offer for you, right? So, exactly. So, sasa nataka kuwapatia form. That's how Gen Z say it. So don't worry. We provide means of transport from here at the venue to Vipingo and then back. So you don't need to worry how you'll get there and how you'll come back. So that one, leave it to us. All you need to do is just to register with us. We'll take you there, go and see, and bring you back. Sawa sawa. So thank you so much. Any question before I close? Discount. Exactly. Perfect. So we have the doctor's discount. Any project you invest with us, you'll have a 2% discount across all the projects. Thank you so much.
Thank you, Wycliffe. I don't know why you are putting a caveat to the discount. But thank you for that presentation. I think for our guests from abroad, you forgot to invite them. They can have a holiday home. There are many people who have holiday homes in Kenya, and I saw the same thing in Dubai. So even for our guests, you're welcome. So ladies and gentlemen, we've come to almost the end of our program for today. But there's one more thing that we shall do, and that is the cocktail welcome. In about 40 minutes from now, it will be at the Jumbo Bar. I don't know if anybody has been to Jumbo Bar. Okay, so when we are done here, you go to the exhibitors, and then you find an exit after the exhibit.